We're waiting on just a couple of things to be uploaded, so y'all catch your breath a minute. It's good to see everybody. Good morning. Thank y'all again for being here. I know it's not an easy time of year to do this, and with apologies again for the reality that we had to walk through with a hurricane that impacted so many members and even presenters as we started this really important conversation. The pause that took place, I'm sorry for. I had great plans for everyone to come to Rome, Georgia, where I live, spend the night and have 2 days of getting not only to know my community, but to hear from some really strong voices there and have some casual exchanges as well. But as always, it's good to regroup and to be here today. I want to thank you again. The work we will do today and tomorrow will conclude the meetings of the House Study Committee on Alternatives to Opioids for Pain Management. We have a robust agenda today. We have members that are trying to get here and members that may be joining us and listening, but they will certainly get all of this information as we follow up with them. I look forward to some of these insightful discussions. Tomorrow, the committee will discuss the recommendations, and then we will work to produce a report in the coming weeks. So with that, let's introduce ourselves again. We'll start again since we've had a bit of a pause. And I'm going to tell you, I may not have all your numbers written down, so you might need to shout them to me as you get ready to introduce yourself. I'll start on my right here with Chairman Cooper and just ask you to make sure to tell everyone about you.
I'm State Representative Sharon Cooper. I chair the Community and Public Health Committee. A long-term member. I have a master's in nursing, as was a family practitioner, and all things healthcare of a great interest of mine. I've done a lot of work with opioids and what we've done to change our response to opioids and mental illness, and that's who I am. Thank you.
Georgia Association of Health Plans.
Now we hit the moment where I may have to know your number. So I'm going to start down here, Jeff. Number 3. Okay.
Thank you, Madam Chairman. I'm Jeff Breedlove. I'm a person in long-term recovery from addiction, and I'm with two organizations, the Georgia Council for Recovery and the American Addiction Recovery Association.
Thank you.
Hello, I'm Taylor Payton. I'm the opioid abatement liaison with the Georgia Department of Behavioral Health and Developmental Disabilities. I've been working in opioids for the last 9 years, and I'm also a person in long-term recovery.
Thank you. And number 7. I think I've got him now.
Great. I'm Alan Wong. I'm a practicing internist and also head up a company called the Riser Institute in Swanee, Georgia, where we have a clinical program for inpatient, outpatients in interdisciplinary pain management for patients. That's a different approach to the standards there.
And number 11.
Thank you, Madam Chairwoman. Good morning, everyone. My name is Michael Pursley. I'm the Chief of Police of the Albany Police Department. I currently sit on the board of the Georgia Association of Chiefs of Police as a chairman for the district reps, and also a partner with Mr. Breedlove and a champion for recovery efforts here in the state of Georgia. Thank you.
Thank y'all. Thank each of you for being here as we begin to work through the final information gathering right now. So our first presentation today, and we're trying to get a couple more things uploaded. So we're going to start with Chris Fox for Voices for Non-Opioid Choices, please. And if you'd rather be at the podium or sit at the table, whichever you're most comfortable. This will be, I think you each have this presentation too with you. So that's it.
Good morning. Thank you again for having me here, Madam Chairwoman, other members of the study committee. I appreciate the opportunity to share the thoughts of my organization. Just a little bit of background again. I was here in, is this working? I can do it that way, the old-fashioned way. There we go. A little bit about my organization. Voices for Non-Opioid Choices was founded in 2019 amidst a then growing opioid addiction crisis. When we founded Voices in 2019, the NIDA numbers that we were citing saw that we were losing 115 Americans every day to an opioid-related drug overdose. Well, now I'll get into it a little bit more during this presentation. I'll give you a little bit of a flavor about what the current opioid addiction crisis looks like. But really what Voices was founded to do was to try to address the opioid addiction crisis a little bit differently. On my most critical days, I like to say that the overall response to the opioid crisis has been incomplete, in that we have focused largely on efforts to prevent opioid-related overdose deaths, which, again, while laudable, if I'm being equally honest, we're not very good at it. I liken it to trying to pull drowning victims out of the river and not enough on trying to stop people from falling in the river to begin with. And so that's why a lot of federal and state efforts have focused on very worthwhile causes, no doubt. Things like naloxone availability in communities, help for the healthcare workforce to deal with increased incidents of opioid use disorder and substance use disorder, support for first responders, again, all worthwhile causes. But if I'm a grader, I'm going to give it that I for incomplete, because we have not taken that opportunity to focus a bit more upstream at opportunities to prevent opioid addiction where we can. And with that, at Voices, we really try not to boil the ocean, and we try to solve for the piece of the pie that we think we can, which is for those who become newly persistent opioid users following exposure to opioids for an acute pain incident. And so when I say acute pain, I'm talking about a short episodic pain incident, such as an accident, a trauma, a surgery, or something along those lines. So I teased a little bit about the current state of the opioid addiction crisis. I think we've all probably seen the headlines. The CDC has been in the news over the past month or so, talking about some improvements that we've seen in opioid-related overdose deaths. In fact, we'll talk a little bit more about that. But as we look at the crisis here, this is the CDC chart that really tracks the different waves of opioid overdose deaths. Obviously, most recently, a lot of the spike has been attributed, I think correctly, to fentanyl and fentanyl-related overdose deaths. But this is the current state. So when we founded Voices again in 2019, we were losing 115 Americans every day to an opioid-involved overdose deaths. Well, now, even despite those improvements that we've seen at the national level, we still lose about 205 Americans every day to an opioid-related overdose death, which represents a 78% increase in just 5 short years. So again, I want to dive a little bit deeper into what those CDC numbers look like, just to give us some context. The other thing I'm going to do as part of this presentation, I was asked to lay out a little bit about what the current policy landscape looks like for access to non-opioids versus opioids, and then give some recommendations from my organization about exactly what you all might want to consider as part of a final report in terms of some policies that can make a difference in terms of freeing up some of that access to non-addictive pain management approaches. But first, just level setting here. So again, I noted that the CDC does a 12-month look back as they forecast overdose deaths. And so they'll say these numbers right now, about that 17% decrease, that is in the 12 months from August 2024 through August 2023. So again, they'll keep playing catch up in those 12-month windows. When we're talking about 17%, it's really that window from the year prior. And so again, 17% increase. In the state of Georgia, you're doing a bit better down here. That number is actually 20% increase, or decrease, I should say, over the last 12 months. And so again, things seem to be trending in the right direction, but there are some very specific reasons why that might be happening. And I also want to note that these declines are not universal. We're not seeing them across all different cohorts and amongst all different patients. Some groups, in particular Black Americans as well as older Americans, are actually seeing fairly significant increases during the same month. There was a report that was done by the Kaiser Family Foundation that saw that in this same window, opioid-related overdose deaths amongst older Americans actually increased by 9% during the same time. And we're seeing the same trends exist and persist in some of these minority communities as well, which again, cause for caution. I think most notably, the CDC is quick to point out that they don't really know why these declines are happening. So they're quick to point out that they can't point to a single reason necessarily for what they might attribute these declines to. On the other hand, Ann Milgram was recently at an event. She's the head of the DEA, and she was talking about what her agency is seeing. And she said, and this is her quote, that she is attributing attributing the most significant reason for these recent declines in deaths is that the cartels have figured out that it's bad business for them to kill some of their customers. And so they're watering down fentanyl. And that is what she is attributing a lot of these decreases in opioid-related overdose deaths to, is less potent fentanyl. So again, while it's certainly, we prefer to see these trends going in the way that they are, there still is some cause for concern. And it's a bit too soon, I think, to pat ourselves on the back. Simply put, more can and should be done. I want to talk a little bit about the economics of opioids versus non-opioids. As is usually true in policy circles, the saying "follow the money" holds true. And it's certainly true when we're talking about the practice of medicine, and particularly the practice of pain medicine. So, cost considerations. All prescription opioid pills are now available in generic form. You know, while all the Netflix documentaries are out there talking about brand name products and manufacturers, every single one of them is available in generic form right now, which makes them exceptionally cheap, which makes them, if you are a insurance company or you're a facility who is trying to maximize efficiencies of procedures, makes them an extremely attractive pain management approach. And in this sense, we actually inadvertently incentivized opioid-based pain care in this country because the two things we value in our healthcare are quality and cost. And unfortunately, opioids in some circles are seen as highly effective, and they are certainly cost effective. And so this holds true in both hospital systems that are subject to a bundled payment for some of these surgical procedures, as well as among some payers in terms of coverage. This is why generic opioid prescriptions enjoy almost universal healthcare coverage, oftentimes at little or no out-of-pocket cost to a patient. And so what we are hoping to do is change this equation a little bit to make sure that we are creating a level playing field when it comes to accessing opioids versus non-opioids. We don't think there should be an economic consideration, or certainly not an incentive, to utilize a narcotic-based pain product. These cost considerations are also not true when you start to think about the long-term considerations of opioids. Depending on the research that you believe, between 6 and 20% of patients who are prescribed an opioid will become newly persistent opioid users. Now, these definitions are important, and so I'm very intentionally using the phrase newly persistent opioid users rather than opioid addiction, opioid dependence, opioid misuse. They all have slightly different meanings. So when I say newly persistent opioid users, that is simply somebody who is still taking opioid pills 6 months after they were prescribed them, indicating a problem there. So again, the research that we cite here, between 6 and 20%, oftentimes is procedure specific. And so they will follow a patient after, you know, a knee replacement surgery or shoulder surgery or some other type of orthopedic procedure or others, and they will follow those. And this is where that range comes from. So on average, we'd like to say about 10% of them may. Of these 6 to 20%, some of these patients will be diagnosed with an opioid use disorder. We did an economic analysis of those in Medicare who were who developed an opioid use disorder. And again, I want to be careful to say that this is a medical diagnosis of an opioid use disorder. This isn't just a case of a patient maybe taking a little bit of medicine and getting a little, out of it later at night. This is a medical diagnosis by a medical professional. And so in 2022, there was a federal report done by the Office of the Inspector General that found that there were 1.1 million Medicare beneficiaries in this country with a diagnosis of an opioid use disorder. Of that 1.1 million Medicare beneficiaries, 145,000 of them were newly diagnosed in 2022. So this is just a snapshot, a one-year snapshot. I'm sorry. Yes, this is Medicare beneficiaries. I'm sorry. We are in the process of updating this number to do state-specific looks at Medicaid. However, right now, all I have is Medicare data to show. I apologize. Of those 145,000 Medicare beneficiaries with an opioid use disorder, the added costs, direct cost to Medicare in 1 year alone was $4.3 billion in 2022. This equals out to about a $30,000 add-on per patient in that year alone. If you extrapolate that $30,000 cost to the entirety of the Medicare population with an OUD cost Medicare $33 billion in 2022 alone. So I want to talk a little bit about the current policy landscape. And again, this is, I apologize, largely going to be focused at the federal level. I promise we will get narrower and talk about some implications specifically for Georgia. But when we talk about the current policy landscape, Our work traditionally has been in Washington, D.C. and with members of the federal government. That's changing a little bit, obviously, now and into the future. And so we will have some policy recommendations for Georgia Medicaid, as well as some things potentially to be done with some opioid settlement dollars, as well as other recommendations for you to consider. And I'm happy to take questions as well if that's appropriate. So separate payment for non-opioids, because of that incentive that exists to utilize opioid-based pain products, we worked with the CMS, as well as members of the U.S. Congress, on a piece of legislation. The piece of legislation was called the Non-Opioids Prevent Addiction in the Nation Act. And the reason that this legislation was necessary was that starting in 2019, CMS made a policy change, and it was a fairly significant policy change. And so starting in 2019, CMS allowed for a separate payment to be made to an ambulatory surgery center for the use of non-opioid pain management approaches. From 2019 to 2020, CMS did an analysis to figure out exactly what the impact of this policy change was. And they found that in 1 year's time, use of non-opioids increased in the ASC setting by 120%. So it more than doubled by virtue of this. Unfortunately, again, I'm a grader, maybe I'm a tough grader, but if I'm grading this policy change, I'd give it an I, because again, this was limited to the ambulatory surgery center setting and not flowed through to the hospital center. And so because the majority of these procedures take place at the hospital setting, we worked with CMS and we tried to convince them that they needed to do more to make this policy change available for procedures at the hospital. CMS was bullish. We told them that for sure we could agree that there are certain subsets of patients that we should not expose to opioids. People in long-term recovery, for example, we said, like, for sure you can say that we should not be exposing them to opioids. And maybe for these, again, they were reluctant to make such a policy change. And so it facilitated the need for us to go to Congress, go around them to say, Congress, there is a very real disincentive for utilizing non-addictive pain management, and we need your help. And I'm pleased to report that in December 2022, the No Pain Act was passed. And what the No Pain Act will do is, starting in January, so next month, the No Pain Act will make separate payment available for the use of non-addictive pain management approaches in both the ASC and the hospital setting, up to 18% of the cost of the procedure. And so there's a separate payment that will be made for, again, this is in Medicare. So in Medicare Part B as in boy payments, that starts in January. And CMS did a rulemaking over the summer and found that there were 11 products that met the clinical criteria for what qualified as a non-opioid product. Those were 6 drugs and 5 devices. Happy to follow up if there's interest on exactly what those products. I'm happy to follow up. I have it in my laptop on another deck that I'm going to give. I'm sorry.
Here we go. I'll ask if it's okay. Is it all right to interrupt you?
Please, by all means.
Is it all right? Okay. When you say a separate payment,
Mhm.
give me an example. Okay, you had somebody that went to, they're now doing knees
Mhm.
on people. Well, on Medicare,
Sure.
people, I don't know whether they're doing knees on 65 or older, but okay, give me an example of what
Sure.
that means.
So can I speak in hypotheticals? Because I'm not going to be
Sure.
correct on exactly the amount of the payments, if that's
Sure.
okay. Is that right? Is that okay?
Right.
Okay. So say, you own a ASC, right? And you have a patient that's coming in for a knee replacement surgery. Under Medicare, they define the amount of the payment that is made available for that procedure, right? Let's say just for discussion purposes, that amount is $5,000. So CMS will make a payment of $5,000 to you. And what you will do is you'll divide up this payment, right? To pay for any supplies that you would need for the surgery. Like, do you need any plastics or any, whatever you need? You'll pay for the surgeons, you'll pay for the anesthesiologist, and whatever's left over out of that bundled payment is profit for the facility, right? And so this incentivizes the facilities to seek out lowest cost options to maximize the profitability of these procedures. Unfortunately, because non-opioids are often considered surgical supplies, it eats into the profitability of those procedures, whereas opioids are often prescribed out of a separate pot of money, that is Medicare Part D, as in David. And so the facility actually doesn't incur any cost of the pain management other than the modest cost that that an anesthesiologist might use in providing that patient. So when I say separate payment, so what happens now is CMS will make an additional payment up to 18, I can't do that math in my head, but up to 18% of that $5,000. So just less than $1,000 would be available up to them for the use of non-opioids. So if you
Okay.
paid for any blocks, for example, it wouldn't eat into the profitability of that procedure.
Okay.
Does that answer your question?
That's pretty simple.
Is that helpful? Okay. This legislation was exceptionally popular in Capitol Hill. If you pick up the newspaper or you listen to talk radio, getting 175 members of Congress to agree on anything, let alone what's for lunch, these days is fairly impressive. And so we were proud that the legislation had 52 senators who co-sponsored this legislation and that it was supported. We've been participating in the rulemaking with CMS to make sure that they get it right as they implement this law. Again, this will be the law of the land starting January 1st, 2025. So that's the current landscape of access to non-opioids. I want to talk a little bit about what 2025 opportunities look like and beyond. But first, just to level set, the last time I was here, Madam Chairwoman, I teased a poll that I did not have the results yet for. And so we do have the results at this time of what that poll looked like. And this is just about attitudes about access to non-opioids. And so what I didn't show here was that 94% of older Americans saw opioid addiction as a major risk in terms of being exposed to prescription opioids. And then we asked them about their attitudes in terms of
Older?
yes, 65 and over.
Okay. Do you have a question?
And so I'm happy to follow up. I have a link. It's on our website. I'm happy to follow up with the physical poll and as well as some of the top lines. But then when you look at this, 8 in 10 voters agree that patients should have the same level of access to non-opioids as opioids, right? Slam dunk. And so this was a poll that was conducted over August this past year, just to level set exactly about senior attitudes in terms of access to opioids and non-opioids. Because again, today, despite all those Netflix documentaries that you may have seen, 90% of acute pain patients still receive opioids to manage their pain. Now, they might not receive opioids in the same quantities as they once have because states, have taken steps to make sure that the amount of opioid pills have been sort of reined in. And that's why we've seen exactly a 50% reduction in the number of opioids prescriptions dispensed in this country. They peaked in about 2011 with about 250 million prescriptions for opioids dispensed in the United States. Right now, according to the latest data from the CDC, there are about 125 million opioid prescriptions dispensed in this country. So again, still relatively high, but not nearly at their peak.
What was the number you used for prescriptions, the number that are still
In terms of dispensed in the country,
right?
So-
In the hospital, in the surgery.
oh, 90% of patients, 90% of acute pain patients continue to receive opioids today, 90. And so, again, not in the same quantities that they once did, but they are still receiving opioids to manage their pain. And again, a lot of the reasons for that are the cost considerations of it. But we also know that we have some apathy amongst healthcare professionals. It won't be surprising to learn that many medical professionals did their training in opioid-based pain care. It's how they were taught to treat pain. And so, it's what they're comfortable with. And I also am sympathetic because I know no healthcare professional wants that call from a patient at 2:00 in the morning with a patient writhing in pain saying, "How could you do this to me?" And so I am sympathetic. However, I think that we might all be able to agree that 90% of patients receiving a narcotic might be not the best practice of pain care in this country. When you look at pain care across the world, the United States is unfortunately leading the way in terms of opioid-based pain care. The United States consumes 80% of the global supply of pharmaceutical opioids. If you go to the EU, the practice of pain care looks very, very differently. Very seldomly do they use opioid-based pain care, where today, unfortunately, it still is the standard of care for many. So I teased this earlier, and I apologize that it's taken me a minute to get here, but just some opportunities for 2025 and beyond. And I'm going to organize this, if that's okay, by payer. And so I have some considerations for Georgia Medicaid, then some public sort of funding opportunities that might be available. And then also I want to talk about implications for private insurance companies. So those who might have a state regulated commercial insurance plan or state employee health insurance plan, and some opportunities for them to make sure that there is access to a non-addictive pain management approach. So 2 opportunities in terms of considerations for Georgia Medicaid. First, we talked a little bit about separate payment that's available in Medicare under Medicare Part B. There is an opportunity for Georgia Medicaid to follow suit. Obviously, the saying generally is as Medicare goes, other payers follow. Well, we hope so, including in Georgia Medicaid, so there is that opportunity. But the other opportunity, I think, is in Medicare Part D, as in David, that covers the prescription drug benefit plan, and to make sure that we are ensuring parity in terms of access to opioids versus non-opioids. I'll give you a case study. So we took a look at out-of-pocket expectations for a patient, and we did this in Iowa. And the only reason we did this in Iowa was because we have a federal piece of legislation called the Alternatives to Pain Act, which stands for Alternatives to Prevent Addiction in the Nation Act. I'm happy to follow up with you on more on that. It has 20 senators who support this piece of federal legislation right now. It has 54 members of the House of Representatives who endorse this. We're working to get more of the Georgia delegation on board with this legislation now. But what the legislation essentially does is it says to patients, it tries to solve for an unequal or a disparity that exists right now in terms of access to opioids versus non-opioids. So our champion for this piece of legislation, the U.S. House of Representatives, is a member from Iowa, Ms. Miller Meeks, who is an ophthalmologist by training. And we did an example in Iowa for a typical Medicaid recipient, and we looked at 2 medications, and these were for migraines. And the one was hydrocodone, which everybody might know better as Vicodin, and the other was for a branded NSAID, combination NSAID product. And we looked at what that patient's out-of-pocket expectations might be for obtaining the same 30-day prescription. So under Iowa Medicaid, for hydrocodone, the out-of-pocket expectation for that patient was $1. When you went to the NSAID product or the non-opioid, the out-of-pocket expectation was $66 for that patient. And so there was a very clear disincentive that exists for that patient in choosing which medication they might want. Similarly, we know that plans have tools at their disposal, like step therapy and prior authorization, that can be used to help manage costs. I think we have some concerns there when it comes to a narcotic about use of prior authorization or step therapy. Simply put, I wear a bracelet every day, and maybe my board chair is listening. It says in memory of Taylor Rhodes. And I apologize if I get emotional here, but my board chair is a woman by the name of Carrie Rhodes. She's in Richmond, Virginia. She lost a son to an opioid addiction that started after he had shoulder surgery. And it says, every day, try to do the next right thing. Taylor was a phenomenal athlete. He was a tennis player. He was likely on his way to a scholarship, I'm told. And he unfortunately hurt his shoulder, as happens sometimes with athletes. And he got prescribed Percocets to manage his pain post-surgically. I hope Carrie wouldn't mind me saying, but she would tell me that Taylor told her once the first time he ever felt normal was the first time that he took that Percocet. Felt normal. I want that to sit in for a little bit because it's just terribly tragic. And so that's why I say when we're talking about a narcotic, one pill can do it. It can be one pill that can ring that bell. And we can't say, Madam Chairwoman, did you like that opioid a little too much? Because if so, I'm going to take it away. We can't do fail first policies when it comes to opioids versus non-opioids. And similarly, we shouldn't make patients make choices based on their medication, narcotic or non-narcotic, based on cost considerations. So what we're trying to do is we're trying to promote parity. Say, you want that opioid? Fine. Here's that opioid. This is what your out-of-pocket expectation is. If you want that non-opioid, let's normalize access and not impose increased costs on that patient to say, do I have to make a choice between buying groceries for this week or my medication? That's not an appropriate step for us. And so we have federal legislation that looks at this. And we're working in a number of states also to promote parity in terms of medication approaches. I'm sorry, it looks like there's another question.
Okay, could you get the chairman, and I'd like to copy some of that sample legislation?
I'd be more than happy to. It's on our website. Morgan, maybe if it's okay, I'm happy to follow up with you on all of that stuff. We have a lot of information on that. We're working in a number of states on this too. Again, we can do this obviously for Medicaid through limiting some of these practices, but I'll get to it again. There are also opportunities for those who are governed by state regulated commercial insurance plans too. But these are the 2 opportunities for Georgia Medicaid specifically.
Thank you.
Of course. And sorry, I don't know how I'm doing on time. I hope I'm okay. Okay, thank you. Funding awareness programs. So there's that old saying about if a tree falls in the forest and nobody's there to hear it, doesn't make a sound. And so we had this policy change that's coming. Groundbreaking, January 1st, right? Non-opioids would be paid separately in both the hospital and ASC. I should note it's for 3 years. So 25, 26, 27. We'll have to work with our delegation, our champions in Congress to try to extend that, obviously. But first, I think we want to see the impact of this. But further, we want to know that patients and providers understand the availability of non-addictive options. We would love to partner with Georgia Department of Health, for example, on some tools and resources for patients symptoms, what to know before you undergo a surgical procedure, questions to ask your surgeon, your anesthesiologist, opportunities that might be available for you in terms of accessing a non-addictive product. We know, again, on the provider side, that a lot of surgeons and a lot of providers are trained to treat pain with opioids. And so we know that there's work to do about re-educating that healthcare workforce about the ability to treat pain without prescription opioids. And so we know we want to do that. In terms of where the funding comes from, our suspicion, and I know it varies by state, but our suspicion is that this would be an eligible resource from opioid settlement dollars, for example, or it could be something that could be appropriated separately through to the Department of Health to partner on some public awareness campaigns, as well as educational resources. Again, I don't want to put all the onus on providers. I think patients have a very real responsibility here too. Just anecdotally, I think I told this story the last time too. I'm a father. My son had his tonsils and adenoids out a couple years ago. I remember the conversation distinctly. The nurse practitioner who was counseling us before my son went under was looking at me, and she's like, "Here," she said it very. I think she of course meant well. She's like, "I'm going to send you home with a couple Percocet just in case Matheson, that's my oldest son, needs them." And I said, "No, that's okay." And she looked at me almost like I was a negligent father. And I remember the conversation very well. She's like, your son's going to be uncomfortable and these are going to help." And I said, "Ma'am, I understand. My son's going to get popsicles and ice cream, and we're going to rotate him off NSAIDs and acetaminophen, and we're going to manage that way." And she pushed back, and she kept pushing back. Ultimately, I don't think she understood who she was talking to, and she picked the fight with the wrong guy on the wrong day because it didn't happen. And I remember reflecting back on that, not with pride or I wasn't happy about that, but I was really hopeful. And that I'm hopeful that there's a day that other parents can have that education, those resources to be able to push back, just as I did with my son. And it might not be for a son, it might be a partner, it might be a parent, it might be somebody else, but just to have the wherewithal, to have the knowledge about what's out there, to be able to push back similarly. And I think there is a day where we'll be able to do that. I think there's just some help, and we're happy to partner here to get there in terms of getting the materials put together and making sure that we're partnering with the surgical societies and others about the awareness, as well as doing our side on patient awareness and education. Finally, and this is my last slide, I'm happy to take questions that exist, but we talked about Georgia Medicaid and the opportunity to make sure that they had access to non-opioids through prescription drug benefit plans. Again, we want that same opportunity to flow through to those who have commercial plans. And so whether you are a state health employee plan or whether you're a state regulated exchange plan, we want to make sure that those plans are similarly incentivized to make sure that they are promoting parity in terms of access to medications, both opioids or non-opioids. I get accused a lot of being anti-opioids. I want to level set here again, and I will say it till I'm blue in the face. I'm not necessarily anti-opioids. I believe that there's a time and a place for opioids and a patient profile that it makes a lot of sense to utilize opioids for those patients. That is not for every patient. And for far too many, those patients don't have choices right now when it comes to what their pain management looks like. And as the name of our organization would indicate, we're all about choices. And so we are pro-choice in the sense that I am not going to stop. I'm not going to consider my job done till every patient in every setting has access to choice. We did that for Medicare patients via the No Pain Act, governed by Part B as in boy. We're working at the federal level to make sure that Medicare patients with a Medicare Part D as in David plan have the same level of access. And we'd love to partner with Georgia and other states around the country to make sure that not just Medicaid patients have those same opportunities, but also those with a private insurance plan have equalized access, I should say, to non-opioid pain management approaches. Thank you again for the time and the opportunity to be here before you. I'm happy to provide any follow-up information or answer any questions that you might have.
Okay, if anyone has a question, if you'll just punch your button. So. Chairman Cooper.
Sorry to be the one. Okay. I think that there's one group of people that you're leaving out that need to be educated, and that would be the legislators in the state. For years, I fought nurse practitioners and PAs having the ability to give opioids. They finally got it last year through another committee. It was limited, I think, to 5 days. And not anybody under 18. And that was a huge battle for years, every year, the nurse practitioners, the PA say, oh, well, we have it all over everywhere else and we don't have it. So part of it is I think they would like to replace physicians, or they want independent practice, and, they'd be able to do it and this kind of thing. So, and legislators don't understand. Legislators with kids, one of the things was, oh, well, what about my kid that plays football and he goes in and he, has an injury and he's 240 pounds and he needs that opioid. So I think if you want states to do things, you better have some kind of program specifically directed toward the legislators, because we also grew up through that period of time when the doctors were freely giving them for everything. So the expectation is not only for the physicians who we're trying to retrain, and we did require opioid training for our physicians, is that, it's okay to give them. And it's a hard attitude to change.
For sure.
So I would
And
just like to suggest that.
I look forward to working with you, Madam Chairwoman, on educating the lawmakers. We have a lot of work to do. When we were working on the No Pain Act specifically, and we told lawmakers and they didn't understand, we said, well, even if my surgeon wants to make available a non-opioid for me, it's not up to the surgeon, even as they are often independent contractors that have privileges at certain facilities, right? It's up to that facility what they're going to make available to that surgeon or that anesthesiologist on that day. And so this sort of thought process of, the surgeons have a choice. Well, no, the surgeon didn't even have a choice in that regard. It's up to what the facility is going to make available to them. So I agree with you wholeheartedly that we have a lot of work to do to raise awareness amongst lawmakers about what's happening, what's not happening, and what the opportunity is. And that's part of why we're here today. I promise this is not I would say one and done, but I was here in August. So this is not a two and done. I'm not going anywhere. I'm happy to continue to be a resource here for lawmakers in Georgia and across the state. Me and my team are ready to partner with you all, because there is a day in time when we will change that status quo, where opioids will not be the default. And I think we're getting there. I think there are some barriers in the way, and where there's a barrier, I'm there to knock it down. I think I'm of the age, and raise your hand if you sort of heard this saying, like, we got to stay ahead of the pain, right? So we would take pain before we were actually in pain, right? That's such an antiquated view of pain management right now. And so we need to change that. Again, that awareness and that education needs to happen across a lot of different audiences. And I'm sorry that you had that fight here. We're happy to help to the extent that we can. We represent over 200 patient, professional recovery groups and clinical societies in our organization, many of whom are here in Georgia. We're happy to partner with you on what we can do.
And thank you. And also, you said that about to work with public health, and I will talk to Dr. Toomey and the public health about handouts for patients, because, we require the doctors to give patients something, and, they hand you a sheet of paper and it's a full page of, the small type.
Yeah.
Nobody reads it.
Yeah,
So-
for sure. One of the other things, it's not on here because I think it might be a little bit further in the future, but one of the things that we've been thinking a lot about is individualized pain management consults and who can provide them pre-surgically. And so we know by and large that surgeons don't have the time to do it, and that anesthesiologists often don't have the time to do it. But we know very well that nurse practitioners could have these conversations with patients, PAs could have these conversations with patients, and others could. And so one of the things that I'm thinking about as I look into the future, and as we have further discussions, is what are we doing to facilitate these conversations? And oftentimes it starts with reimbursement. And so we know that there's an opportunity, I think, to have those, because pain is personal, and what might work for one patient might not work for the other. But I think if we can facilitate at least a conversation between a healthcare professional and a patient, we know by and large what the patient prefers. And I think we can eradicate a lot of unnecessary exposure to prescription opioids that way.
Thank you. Ms. Payton.
Oh, welcome back. I really appreciate you consistently bringing up the anecdote about your friend's son verbalizing that he felt normal after taking his first opioid. I think it's really important to highlight that for many people, opioids are not their problem, but the solution to their problem of a greater underlying problem. My question, however, is not so much about your presentation, but I did wonder if, is that economic impact analysis that you referred to, is that an existing resource on your website? Is there a way to receive that?
Of course it is. So it was not done by me. I don't have any fancy letters after my name other than FOX. And so it was done by other economists, PhD types, an independent firm that we hired called the Moran Company. And it is on our website. Again, I'm happy to follow up and provide you a link, not just to our press release about it, but to the actual findings. And so you can read all about the methodology that they took. Essentially, they took a look at, I'm sorry, this is a mouthful, 2 actuarially equivalent patients. And so say, you, Jeff, and you, and they said, okay, they have the same age, the same health profile. And they took a look, maybe one patient A has an OUD, patient B does not have an OUD. And what's the difference in terms of their cost to Medicare in that year? And they found that the patient with an OUD cost roughly $30,000 more than the patient without an OUD. And they extrapolated that. But yes, the resource is available. I'm happy to share it.
Thank you so much. That was my only question.
Of course.
Mr. Wethington.
Thank you, Madam Chair. Thanks again, Chris, for being here. So my question related to the bundled payment in the ASC setting in Medicare. What kind of informed that 18% cap? Was that sort of unique to the economics of ASCs? Is it the Medicare population? And is y'all's recommendation for bundled payment in Medicaid and commercial kind of contiguous to that? Or is there another way to arrive at that from a value prospect?
So it's a little bit into the sausage making, so I apologize. But as with anything, the legislation was introduced in one form, and we had a lot of conversations with the Senate Finance Committee on any tweaks to the legislation. And there was a very strong belief that they didn't want to cut a blank check for high cost medications to simply be covered. And so they wanted that downward pressure still on prices of non-opioids. And so the thought was that 18% was an appropriate cap there in terms of what it looked like. We did a look at all the procedures and what that cost might be. And it was just where we netted out after conversations with the Senate Finance Committee was, again, we started at 20, they started at 15, we landed at 18, to be honest with you.
Thanks.
Thank you. Dr. Wang?
Yes, thank you, Madam Chair. And Mr. Fox, I think we've talked about empowering the patients and then also getting down to legislation. I think the crucial part is around physicians. You gave a couple stats, 80% of the opioids around the world are prescribed here. And if we look at, I just did a quick calculation of the world's population, we're about 4% of the world's population prescribing 80%. So that's just 20 times more. As a physician, I've stopped prescribing opioids, period. The problem is it's not all the generations of physicians coming out from physicians older than me and younger than me are still taught that this is an okay thing to do. The other issue is you've got physicians that pain is a universal symptom. So as a dermatologist, a radiologist, a surgeon, an internist, emergency room, cardiologist, all of us are taught pain is a symptom and we should treat it. That's a huge thing. That means every single physician, just about the universal thing we can all prescribe is pain medicine. And so the amount of education that we have there for physicians is not enough. You mentioned that the number has decreased by 50% from 250 million to 125 million. That's good, but it's still not good enough. So I think more legislation, more education around what we do with physicians. We've done something here in the state with PDMP and how we get registered, and we've seen a decrease, but it's just not enough. When you look at anybody that takes an opioid, 6 to 20% could become addicted. We just cannot write. We need to write 20 times less opioids than what we've got currently. So just a comment on that.
Sure. I still remember to this day, my wife, when she gave birth, the nurse would come in and remember the smiley faces that were on the wall. And they would say, where are you here on these smiley faces? And I remember distinctly, one of these days she said, I'm at like a 3. And again, it's 3 out of 10. The nurse, boom, gave her an opioid. And I was sitting there like, but she's like, gave me the look, and it was fine. But, there was a time and place where we thought of pain as a vital sign, remember, and that we needed to treat it as such. I think we are pivoting away from that a little bit. And, I talk to patients all the time and I say, pain can be constructive. And you need to be sort of understand, like, so for individuals who are going through physical therapy or rehab, the physical therapists oftentimes want patients to feel pain because it's useful to know what your limits are. And so you understand what you can and you can't do. Similarly, if I am cutting you, as you know, Dr. Wang, like, you can expect some discomfort post-surgically, but the physicians and the surgeons that I talk to a lot say that rather than valuing a patient reporting a 0 on a pain score, they value function. So a patient being able to walk out of the hospital out of a knee replacement is more valuable to them because it's easy to sedate a patient if they're in a hospital bed all day and you pump them full of opioids and to get to that 0. But what's better is getting that patient to be able to put their shirt on themselves after they have a shoulder surgery, or being able to walk up a flight of stairs or down a flight of stairs after a knee replacement. That's what we're hoping for. And so again, I agree with you wholeheartedly. There's some education that we have to do. And, I know me and my team, we're happy to work with you and others on what this looks like. I think legislation is a very real opportunity. I'm happy to follow up on some examples that we have at the federal level and at the state level that might be instructive here. Again, we are here to help, but it takes 2 to tango. And so we hope that you're willing to work with us.
Thank you so much. Are there any other questions or comments?
Thank you, Madam Chair.
Mr. Breedlove?
Yes, ma'am. I don't really have a question. I just want to thank you for your presentation. And I want to thank you for clarifying that you're not, I'm paraphrasing you, necessarily anti-opioid, but you're here for a choice. And I think that is important that, and then I think to Chairwoman Cooper's comment, I think the reality that we've spoken about a lot of things, but we haven't spoken so much about the money behind a lot of the opioid companies. And I think legislators do need to be educated. And I think the medical community needs to be educated. And I think, to your point, the patient community needs to be educated. And my wife has been on a medical issue at one of the best facilities in Atlanta. And I can tell you, I mean, it's internationally one of the best. We brag about this facility. And the men and women that work in there are incredibly busy. Just go on a random day, and they are dealing with hundreds of patients. And time is a factor in this. And so it's easy to understand how they might say, well, here, take some opioids. We've got to prioritize on the front end of these procedures what all the options are, every option, not just one. And I thank you for bringing that to our attention.
Of course, happy to.
Just a minute. Wait a minute. Wait, can I get your microphone on? Wait just a minute. Just a minute. Chairman Cooper has another question.
Sorry. Yes, you've talked about alternative methods. I mean, are you talking about things like, I have scoliosis and my back gives me a lot of trouble, and sometimes they go in and kill the nerves. Is that the kind of thing you're talking about? Or can you give us the thing you said you had on what the alternatives were?
Yeah. So, so there's a clinical standard for what qualifies as a non-opioid product. And this is very much a discussion that we had as we were crafting the legislation. And what we view right now as part of the No Pain Act, and it's the same clinical standard that we've flown through to the state about what a non-opioid looks like, is on the drug side, it has to meet some criteria. One, it has to be FDA approved, right? We're not talking about the Chris Fox Miracle Cream here.
Right.
So it has to be specifically approved. It also has to have a very specific indication for providing post-surgical analgesic support. And so this is different. Again, that post-surgical indication, I want to underscore, because it's not general analgesic support, but post-surgical analgesic support. And third, and I think probably most importantly, it has to have peer-reviewed data demonstrating the ability to replace and reduce the number of post-surgical opioids consumed. And so in the case of the drugs, that was 6 drugs that were identified by CMS. I have them in another deck on my laptop over there. I'm happy to follow up with you about exactly what those 6 drugs look like. On the device side, the standard was a little bit different. Not much, but again, we're a little semantics there, but they also approved 5 devices as part of that, meeting that clinical standard for a qualifying non-opioid. And again, I can follow up with a list of where CMS
That's
landed
what I
on that.
wanted. If you give us that list so we know what those
Yeah.
alternatives.
And I want to say that list is a starting point. That is year one here. There are products all the time. Frankly, there were products that did not make that list, and CMS in the final rule had a discussion about exactly why they didn't think they qualified. There are new products that may be coming to market soon that we want CMS to take a look at as well to determine their eligibility for separate payment. And so this list is going to evolve. But as of January 1, 2025, I for sure have a copy of that list. I'm happy to follow up with you.
Thank you.
Of course. But I'm sorry, the other thing I wanted to mention there, these are just medical products that we're talking about. One of the things that we've talked a lot about is what we call restorative therapies and their ability to treat people with acute pain, things like acupuncture, physical therapy, chiropractic services, physical therapy, and others. What the No Pain Act did was it required a report to Congress about the effectiveness and the ability of these therapies and treatments to treat people with acute post-surgical pain and report back on barriers that exist. We expect that report will be final in July 2026. And so once we get that report, I think we'll understand exactly what barriers to access looks like there and how we might extend those therapies that might be appropriate for the use of acute pain treatment as well.
Well, I certainly thank you for the group's work. This is one of the most positive things I've heard in a long time in our fight against addiction. Because I think one of the problems we have in this country is that people, and I was just in the hospital with my sister, and those smiley faces on the pain thing is
Still
still, and it's a very good little hospital. But there it is in intensive care, and the step down for it, the little smiley faces. And I threw a fit when her back was hurting because she's basically been in a coma and she's coming out of it a little bit. And the first thing they did was give her a shot of morphine. And apparently a real problem. And I said, no more on that kind. Get her up or try to get her up, this kind of thing. So I'm really encouraged. Thank you very much for the work you do. And I appreciate
Of course.
that. And I look forward to seeing what the devices are. And thank you for getting Congress to do something. Yay.
Sure. Well, I look forward to partnering with you all as well on things we can do specific to Georgia as well.
Thank you.
Okay, 1 minute, Mr. Breedlove.
Are there other states that are interested in doing something at the state level?
Yeah.
And are there any you can name?
Yeah, there are. Some states have passed what we call pain parity legislation that would equalize this. So Maine is one, Tennessee is another. There are some that are on the precipice in Massachusetts and Illinois and some others. And so there are some states that have taken this step to make sure that we are level setting access to opioids and non-opioids. I'm happy to follow up as well with the list. We expect that there will be many, many more in 2025. And again, we're working on two different tracks. We're working at the state level and then also obviously federally with members of Congress on a piece of legislation that we hope will be introduced very early in the next Congress, January, February. Because again, I unfortunately don't think it's going to go anywhere this Congress in lame duck session, but in next Congress, it was a brand new policy for U.S. Congress, introduced in January in the House and February in the Senate, brand new. And I think when all is said and done, we'll end up with about 60 House members who supported it, a little bit more than 20 on the Senate side. So for a brand new policy approach, it did pretty well. And I think we have a real opportunity in the next Congress to get it over the finish line federally and obviously hopefully work with some states to do the same thing.
Thank you, Mr. Fox, for coming back. Both presentations have been very important to this work we're about to really dig into here. And I want to thank the committee. Great questions, great discussion. Really helps us out a lot. And I just look forward to hearing the more information that you're going to send to us and the work that I hope we can do together also.
Thank you. Thank you. Happy to help. Thank you for having me.
Thank you so much. Okay, so next we have Dr. Cliff Williman, the practice director for Children's Orthopedics and Sports Medicine. I know there's more to your story, Dr. Williman. Tell us a little bit about yourself too before we start. And I believe that this is the presentation, committee members, if y'all have that. Yes.
Thank you, Madam Chair, and the committee for the opportunity to present some of our work at Children's and what we're focusing on and trying to improve and with you. And I grew up in LaGrange, Georgia, so it's great to to be back, and been here since finishing training in 2011, practicing at Children's, and so it's wonderful to contribute back to our state and along with your efforts. So I wanted to share some of the work that we're doing. I'm an orthopedic surgeon at Children's. My practice focuses primarily on sports medicine and trauma surgeries. I'm the practice director currently. I was the medical director for our research efforts, quality and outcomes in orthopedics before that. And it's clear, I think you've heard a lot of the background information from Mr. Fox and others on the crisis and epidemic that we're living in. And we certainly see that in the pediatric and adolescent population. It's a vulnerable population. And that's what prompted some of the research. And these are some of the statistics on that. It affects at least 2 million Americans. I think that's a vast understatement, but these are based on reports and publications. I think this is shocking that opioids prescribed in 1 year could medicate every American around the clock for 3 weeks. It's a 5 or 6 year old data, but it's shocking. Drug overdose is the leading cause of accidental death. In Georgia, there were in 2017 about 1,500 deaths in Georgia related to opioids, and down slightly, but still alarming in 2021. And in the U.S., about 300,000 adolescents are non-medical users of narcotics, and I suspect that is also underreported. If you look on a national level, shocking numbers as well. You can see the vast impact that it's had on our nation. And so, well, how could this be? And I think it was referenced in the last talk, pain became the 5th vital sign. And in 1990, it was brought up, and then in the American Pain Society introduced that officially in 1996, the 5th vital sign. The Joint Commission introduced standards to improve the care of patients with pain. And because of that, there were other unintended consequences. With it being a 5th vital sign, physicians and other healthcare providers were then judged and rated, and their careers were affected by that tremendously based on pain reports. And if you look at the timeline of this, as the vital sign, OxyContin was introduced in 1995. You look at the number of prescriptions in millions. 87 million, and just in 2013, 207 million. And you can see the dramatic rise as this was monitored. It's been hailed as a commercial triumph and a public health tragedy. Again, the timeline, 1995, OxyContin obtained FDA approval. In the labeling, it was labeled as iatrogenic addiction is very rare. I'm sure you've seen from, in news reports, documentaries, that go into much greater detail, but all expense paid marketing campaigns directly to physicians. There were extraordinary bonuses paid out related to this. And then in 2002, it started to change, removing the prior labeling. And then the backpedaling began. The 5th vital sign, as pain was removed from the Joint Commission education materials in 2004. In 2007, there were lawsuits and guilty pleas and huge financial fines paid. And then, finally in 2011, both pharmacologic and non-pharmacologic strategies have a role in the management of pain. So we still have a long way to go, and it certainly has affected our great state. You can see news reports and headlines and reports from others here today on the effect that it's had on our citizens. The 3 ways, Mr. Fox showed this. I think it's a great slide because it's not, it's a mix of recreational and prescription opioid and narcotic is a problem. The first wave we talked about with OxyContin and oxycodone and the FDA. The second wave was related to heroin. And then the third wave is that related to synthetic opioids, or those being mixed in illicit drug formulations. So really, it's not just an adult problem. This affects all populations, all ages, all walks of life. And so we all need to help. And this is kind of the approach that we took, and that I was taking at Children's, that it's really not limited to age, race, gender, or region. statistically, it affects everybody. 1 in 4. So you, your family member, neighbor will be affected. At that time, we were starting a study. There were no published studies in the pediatric population at this time. And so we took the ownership that if we're going to be the experts, we need to take ownership before others do, and we need to drive this. So in 2017, my team, we published a study that when I was starting practice in 2011, it became clear to me, you learn lots of things when you're starting practice. And parents would always ask, well, how long is Susie going to be out of school after the surgery? And well, there's really not any data. I'm just using my anecdotal experience to say, well, you can go back to school in 3 days or 4 days or whatnot. And say, well, we should do a study to actually, gosh, look and see how long kids are out of school after a variety of surgeries. So we did that, and it was found to be extraordinarily helpful. We spread that, and it was published and picked up by news polls and whatnot. And so in the same lines, so why don't we look at narcotic use in children, excuse me, after common surgeries that we do? And the whole goal of this was really to get an idea of the pulse of where we were, how many narcotics were being prescribed, what was being used, what wasn't being used, what wasn't working, what was working. This was not a study designed to make a change in providing education. We were trying to get a baseline understanding of where we were. And so that helps us determine narcotic medication use following these procedures. And then in phase 2, to make change. So this was the study that we did, and it was published last year in the major pediatric orthopedic journal for the country. So we looked at 7 common procedures. Their elbow fracture pinning, so children falling off monkey bars and skateboards, breaking their elbows, or supracondylar humerus fractures. Scoliosis, spinal fusion, so long segment spinal fusions kind of from the shoulders down to the waist. Growth plate surgery for children with differences in the lengths of their legs or severe knock-knee or bow-legged alignment. ACL tears in the knee, reconstructing those. Other knee arthroscopy, shoulder arthroscopy, and hip arthroscopy procedures. So that was in patients aged 5 to 21 years of age, boys and girls included. Some patients were excluded if there were other confounding medical problems that would make the study difficult to obtain. And the patients were compensated $25 if they filled out the questionnaires. They filled out a logbook reporting their medication use, both narcotic and non-narcotic medications, Tylenol and nonsteroidals like ibuprofen, Motrin, Aleve. And so in this, we had 340 patients. You can see it was about 50 patients per procedure. And the mean age was in the teens. The lowest age of the elbow fracture is 7-year-olds up to 15 to 16-year-olds for the majority of the other procedures. So what did we find? So there were 9,867 narcotic pills prescribed in 342 patients. 44% of these doses were consumed. 56 were unused. So you never improve things until you start studying them. And these may have chill bumps just reading those numbers. And they're certainly alarming. And, so surgeons, the joke, sometimes wrong, never in doubt. And so it always helps to measure these and find these and report it so we can improve. So if you look at consumption related to the surgery, as you might imagine, the highest amount of doses consumed was after the most invasive procedure, scoliosis surgery. And but even in those patients, 42% of the doses were unconsumed, and the lowest amount was after hip arthroscopy. So if you look at the duration of use, it was fairly similar between the procedures, but there's a really wide standard deviation. So if you go upper one, plus 1 standard deviation or down, you're including about 68% or 60 of people in that group. So for example, with ACL reconstruction, the mean number of days that someone used from the day of surgery afterwards was just less than 5 days, 4.8 days, but the standard deviation was 3.4. So about a third of patients used it for 3 more days, and a third were in the range of just about 1 day. And so that's a huge amount of variation that we need to improve. When we looked at patterns, There were no significant differences in the amount of narcotic consumed based on the age, the sex, or ethnicity of the patients. If you look at the entire group, and you look at other things that they did to try to improve, the only independent factor we found to predict less narcotic use was nonsteroidals, ibuprofen, Aleve, Motrin, Advil, etc. And those that did used 5.1 less tablets and about 2 days less of narcotic use if they did or didn't use nonsteroidals. About 3% of patients did not use narcotics, and while 10%, almost 10% used all of their prescription. That occurred most frequently after spine fusion or shoulder arthroscopy. If you compare those that did use all their medicine or didn't, there was no difference in their backgrounds, prescription size, or their use of non-medicinal methods of pain control. But again, nonsteroidal was the most frequent among those that did not use all their medicine. So when you look at non-medicinal methods of pain control, icing, and other things such as virtual reality to reduce anxiety, meditation. There wasn't a strong association between all of them, but most people were using some element. And I'll get to why that probably didn't have as big as effect as you would expect. And you looked at satisfaction, about 91% were satisfied with their pain control, regardless of what they used in that. The average satisfaction was not different based on the surgery type, less invasive or more invasive not being different. Female patients and those who use all of their prescriptions were less satisfied statistically. So we looked at patient instructions, and this is where we have a lot of room for improvement and made huge changes. 95% of patients confirmed they received instructions about how and when to take their narcotics. 58% reported receiving instructions from only one person, most commonly a nurse, 74% of the time. And physicians were cited as the source only 50% of the time. And in spine patients who had the most invasive procedure and likely had the most pain, only 38% of the time. So overall, there was a significant decrease in the duration of narcotic use associated with the receiving instruction. Makes sense, right? If you're given more specific examples and instruction of how to manage your pain, not just using narcotics, but how to manage your pain, use less medication. So education is clearly important, and that's the underlying theme of all of this. So narcotic use in pediatric patients following orthopedic surgery was much less than the quantity prescribed. Again, 56% of the pills unused. The duration of use was longer than anticipated, with a wide standard deviation, a wide variation in use. Non-steroidals significantly decreased the number of doses consumed of narcotics. And then patient education decreased the duration of the narcotic use, highlighting the need for more education across all spectrums of healthcare. And so based on the results of this, it provided more accurate data as a starting point for where prescriptions should occur. This was then published last year in this journal, the Journal of Pediatric Orthopedics, which has really been helpful to educate not just the surgeons locally, but nationally, and to help lead these efforts. So what do we need to think about and improve on? If you kind of break this down into pre-surgery, time of injury, surgery, and post-surgery, many of these injuries are occurring on the playing fields or at school, and certified athletic trainers in schools are really important. There are nurses in every school, but not athletic trainers. And so these are professionals trained in healthcare with master's level training or more. They're really experts, not just in managing bumps and bruises, but life-saving techniques such as defibrillation. There's in the last few years, we've had about one student in the Atlanta metro area has had sudden cardiac arrest during sports, has been resuscitated by an athletic trainer. And so, but also they're really important in managing these early injuries, and they're huge, they play a huge role in these patients. Getting the swelling down, using non-narcotic methods of pain management, starting that early, rather than the patient being placed into a cast or a brace, sitting at home with lots of pain and stiffness and pain that's worsening, anxiety that's worsening. And again, and then before surgery, physical therapy, pre-rehabilitation to get the patients moving, to gain more confidence, to decrease their anxiety and pain level regarding their injury. And then in the surgical management, overall, the trend is certainly less invasive surgical techniques. So things that just 5 years ago, 10 years ago, that we may have repaired through an open incision, making an incision and seeing the damage and the repair with our eyes, versus using less invasive and then arthroscopic techniques where we're placing cameras through small keyhole incisions in various parts of the body to repair these damages. Bleeding management, right? Bleeding causes inflammation and pain. So there are medications that we can use now during surgery to decrease the bleeding and blood loss, which decreases overall swelling and inflammation and thus pain. Using combinations of narcotic and non-narcotic management. And so using things such as steroids actually to decrease pain after surgery. Using nerve blocks where we give numbing medicine around nerves that supply feeling to that part of the body having surgery, or injecting numbing medicine in that surgical site. And then really importantly, patient and parent education and having pathways of care to unify this message, which we found was that you're only as strong as your weak link. And so if the doctors, the nurses, the physical therapists, and the rest of the members on the team are not on the same page or delivering the same message, one person saying, oh, we've just got to stay ahead of it, let's go ahead and take this, it erodes all of that other education. So that's where we've made a lot of progress. After surgery, mobilizing the patients quickly in physical therapy, using multiple modalities of pain control, not just pills, whether they're non-narcotics or narcotics, ice machines, e-prescribing has also played a huge role in that, because what we found in patients that were traveling for surgery for hours away, you can't call in narcotics. And if someone is having pain, the tendency was they would overprescribe, because versus giving a very small amount or none. And so with e-prescription, that makes follow-up prescriptions or initiating prescription much easier. And you can say, well, that's maybe making the access too easy, but actually I would argue that it's improved narcotic prescription habits, because instead of writing a large prescription, no prescriptions written. If these non-narcotic methods are not working after surgery, then you would have an option, or you only give 2 tablets, use only if necessary, versus giving 20 tablets. So e-prescription has been a good benefit. And then unified messaging, as we talked about. So what about other opportunities? Further widespread pain management and education post-surgery is so important, and that has to occur at so many levels, as you've heard from the earlier talks in this one. Athletic trainers in the school and support and funding for them is critically important. Opioid disposal programs, I didn't talk much about that, but as you could see, with 56% of unused doses floating around, you could say, well, the problem now is maybe is more in synthetic opioids being in illicit drugs. Well, maybe that's the case, but the initial could be the 10 pills left in the cabinet drawer left over from surgery. And so we need few of those around, and we need to get rid of them when they are. And then certainly further follow-up studies at Children's to monitor the changes that we're making. Anecdotally, now the number of pills that are prescribed, when I look through our logs, are dramatically lower or none. And so we have made a lot of progress. These studies are very expensive to do, and so it takes a bit of time to rebuild, to recharge for this. So with that, thank you again for having me. I'd be happy to answer any questions and participate further as able.
Chief Pursley, I'm
Yes,
sorry.
ma'am. Thank you for the presentation, sir. For both presentations, I've heard a message about educating and messaging. How do you propose getting your message out to those rural areas where some medical people may do things, they deal in strictly cash because the people they can't afford insurance, or it's a very poor group. We'll say that. How do you propose getting this messaging out to where it can affect those, even those people who've been in those old school doctors, and they've been physicians forever and a day? How would that work?
I think there are a couple of parts that, messaging and education. How do you get out into the schools? How do kids learn about it? Whether it's through formal educational talks, through, like athletic trainers have a huge impact on these students, and the ones, particularly they're exposed to more playing sports and the impact they have on them. So that is a great opportunity. If we're spending time having athletic trainers in schools teaching about how to manage an ankle sprain, well, we certainly need to provide education on this and provide resources for that. In terms of physician education, that does seem to be improving with opioid prescription education efforts. When DEA licenses are renewed now, there's a mandatory opioid education that has to be completed. There are a variety of outlets to do that, but that is a way that is far-reaching for any physician that is prescribing opioids. That has to be done. I think general public awareness, having more public awareness and patients and families saying, gosh, and approaching the physicians and having them empowered is also really important, and that helps initiate the conversation. And then, someone, I think Mr. Fox was saying that, surgeons are busy. They are, but this is really important. And I think the most impactful person when someone is having surgery, it's a surgeon, me sitting down before and after surgery and say, all right, here's our game plan, not just to fix your ACL, but to manage your pain. And this is how we're going to do it, with very specific instructions versus, as Chair Cooper was saying, here's the 9-point font and 48 pages of things to read and know about after surgery. That we all know that doesn't work. We don't read it. The patients don't read it. And so we've got to have better and more clear education for that. So.
Mr. Breedlove.
Thank you, Madam Chairman. I have two questions, if I may. Doctor, thank you for your presentation. Just tremendous. And congratulations on the new complex. It looks amazing. My first question is, as a doctor, and at Children's, and you referenced, some of the patients could be up to 21 years old. So that's high school and college. So those might maybe older patients that could have awareness to ask themselves a question. And of course, parents would be there maybe for especially younger patients. So understanding it could be the patient or the parent. Do you find that when a procedure is being discussed on the front end, that this is something even on the radar about overdose and opioids, and but they bring it up proactively to you? Do y'all see more and more people asking, or is it something that's not on patients' and parents' radars?
It definitely is. And that's really in the last 5 years. But in the last 2 years, as more and more headlines and more tragic stories of teens and college students passing. And so that is something that families and patients discuss. I mean, teenagers go, gosh, I don't want to take any narcotics. So, before you've even talked about this, and like, that's great. That was never a discussion, that would be initiated by a teenager 10 years ago. And then, by doing studies like this, it also raised awareness among the surgeons and other doctors that are in the group and the healthcare system that, wow, we've got a lot of work to do in making immediate change. Even when we were doing the study, just monitoring it, doctors were changing their prescribing habits just from thinking about it. It was raising awareness that there wasn't formal education because it was still ongoing. We didn't have all the data, but just people being more aware of it.
Good. And if I may, I'll ask a second question, and it's a segue. I would be remiss if I didn't say, next time you're with your colleagues and y'all are planning your different state conferences, I'd love for y'all to recommend panels with legislators and peers and medical people to talk about this to the associations, to go back to those old school, been doctor forever and a day folks, so that they could hear some of this change going on. I think it'd be great. But my actual second question would be this, and I'd like to ask you from your perspective as a doctor. So if we take this out to its logical conclusion, there is abuse of prescription medication, and that can lead sometimes to then abusing illegal products. And then sometimes people these days have an incident occur, say in a business, a bar, a restaurant, a sporting facility, or whatever. And there's a stigma around one of the solutions, which we have in our capital now, overdose reversal kits. As a doctor, what would you say to a business owner about the stigma around maybe putting up a kit next to an AED box? They might have that. Why, from a medical perspective, why is it important for businesses, or is it important for businesses, just like they have AEDs, to have overdose kits available based on this broader topic we're talking, or maybe it's not?
No, that's a great question. Our athletic trainers, they have these backpacks that they take to sporting events, right? They're on the sideline, ready at a moment's notice. If a an athlete collapses and is in cardiac arrest, guess what? They have an AED. If they break their leg, they can have a splint, and we have it. And so why do we not have Narcan or naloxone available? And so we do now. And so, just like you might have an EpiPen for an allergic reaction, you should have this available. And, having them more widely available, because you really only have minutes to act at the most. And if you're looking for it, it's too late. And so we need these more widely available in restaurants. And I think getting through the perception that having it, you have a fire extinguisher on the wall doesn't mean you're going to have a fire, but you have it available. And same thing, it doesn't mean if someone had a heart attack in your restaurant and you had an AED that you created their heart attack. They suffered it in your presence. And the same thing with life-saving medicines like Narcan or naloxone. So.
Ms. Payton.
Thank you for your presentation. I have two questions as well. The first, I'm very fascinated by this 3% who use zero narcotic pills. Was there any data collected on that 3% that might help us understand what informed them not to use opioids?
We have some data on them in that regard. Unfortunately, it's not a large group.
Mhm.
So having a larger group and what will be really interesting and follow up further studies, having specific arms of patients that are, or groups of patients that have no narcotics at all intentionally from the outset. And so to learn more about that, but anecdotally, those patients use multiple modalities, medicinal and non-medicinal pain control. And so everything from music and relaxation techniques to decrease anxiety. We know anxiety worsens pain, whether that's pre-existing anxiety or anxiety created by the surgery, augments your pain. And we also know that use of benzodiazepines, muscle relaxers, or anti-anxiety medicines also potentiate the abuse and dependence potential of narcotics. And so really getting away from sending people home with narcotics and benzodiazepines for muscle spasms, because it increases the overdose risk as well as the abuse risk down the road.
So would you confirm from your anecdotal experience that these 11 patients likely had parents who had understandings of alternatives to opioids prior to receiving surgery?
Yep, at some point, whether they had before surgery or in the recovery period. Okay. That plays a huge role in these children.
Thank you. And then my second question, is there any type of screening that's done with children prior to receiving surgery to determine if they may be at risk for an opioid use disorder or substance use disorder of any sort?
There, yes and no. There could be better questionnaires systematically administered, but there are other screening mechanisms such as obtain the family history, of illnesses in the parents, siblings, and whatnot. There, before kids have surgery, the surgeon, the anesthesiologist, and then a nurse meet with them to review their medications, the anesthesia plan, and narcotic discussions are part of that as well. So,
Wonderful. Thank you so much.
Chairman Cooper.
I have several questions. First of all, schools don't like us to require anything at all. But if something and we came along and we could require something, would you think the athletic trainers are specifically most needed in high schools? I mean,
for sure,
would help a lot.
it would. Nurses play a huge and important role in healthcare in schools, and I would argue, and we can show data, the athletic trainers do as well.
Because I think the school nurses would tell you that they are busy with everything else and certainly not about concussions or things that go on as far as in schools that have big sports programs.
Yeah, in the last few years, particularly concussions and mental health, they've always been there. There's better recognition and certainly better treatments available. And the athletic trainers play a huge role in that. In the future, I would hope that you would have an athletic trainer and nurse would be a team of sorts in every school.
Okay. All right. Okay, on this study, and when was the study done or finished or?
It was finished in 2022.
Okay. And are these just the doctors at Children's? Okay, how many orthopedic guys are you, or was this all the surgeries?
This is in 15 surgeons.
15 surgeons, okay. Since I think tell me if I'm wrong with we got somebody that knows more about drugs than I do on this. On one of the problems that we have with opioid disposable programs that I mentioned, and that would be great, people do not give up their narcotics because they think, what if I need them? Now they'll try to dispose, am I right? And this and hadn't changed. They'll give you all the other ones that, the antibiotics that are left over that they didn't take right, but they won't get rid of the opioids. And for many children and young people, addiction starts with something that was in their parents' drug or some other parent they were visiting. So after you've had this, have you, as a group at Children's, when you've got this about how many pills are used, have you said, let's don't order more than that? Let them come back and ask us for more if they need them. Have you made sure that they're all following that so that there's not 30 pills left over or 20 pills left over?
Exactly. We have, and that was really helpful in the data to understand what was being consumed, and that becomes the prescription number or the upper limit. And that's why e-prescription has been helpful, because everyone would much rather underprescribe.
Okay.
And then if someone has enough pain, so narcotics are not being prescribed in the clinics. That's just not part of it, but this is after surgery. But if someone has enough pain that they are not able to manage it and they think they need additional narcotics, that would be something that they have to come back to clinic or come to the emergency room, come to the hospital, because they need to be reevaluated. If the pain is that bad, there could be some other complication occurring.
Right. So this has become, I don't call it a rule, but it is a required procedure at Children's. about the overprescribing. I mean,
Oh, yeah.
it's not just word of mouth between the doctors. This is in the hospital's protocol.
Yeah. So at least in orthopedics, which
Okay.
but this has interestingly raised awareness in the emergency rooms as well, that you know, someone with an ankle injury, they don't need to have narcotics for an ankle sprain, leaving the emergency room. And so it's had other effects outside of orthopedics as well.
Okay. The other doctors are looking at that's great. Well, and how do you get over, unless it's changed, about 30% of the kids, and I think Adam's not here today. Adam Kelly is on this commission, and he's been very forthcoming. His addiction started from a sports injury, and that's where it started, with a medication from that. Now, he has turned his life around. Went to law school, passed law school, and now he's working to help. And we passed a bill this year to help some discrimination about whether counties could require like 2 months for somebody to say that we don't want that restaurant to go in an area, and 6 months if it was a treatment center for opioids, to make them even. You can have it, but just make sure you're not discriminating against. And that's because of Adam. So I don't think he mind saying it. So, over the country, and I think it's still right, that 30% of the young people that get addicted, it starts with the pain medicine from an injury when they're below 18. It's why we fought so hard, and I fought so hard not to let anybody give them under 18. So is that a consideration also, that you don't automatically give them to kids under, and I would say 21, but since y'all take them, would be a good cutoff in it too? Or has that been discussed among that you just not use them?
Right. And this is all in kind of surgery patients, like non-surgical injuries. Like, there really has been no role in narcotics in our practice and center for that. And so, in the more invasive things like surgery, now it's moved to the point of patients going home after some procedures without any narcotics.
Okay.
And so we're making progress in that, and it can't happen fast enough, but we are.
Well, and I really appreciate that. And besides, Jeff says, I mean, I work with the orthopedic group, and several of us, Katie included, we go to the medical meetings, and there are panels of discussion. I mean, has anybody asked you to present this at the Orthopedic Society?
Yeah, we presented this in the Georgia Orthopedic Society, the American Academy of Orthopedic Surgeons, which is the major meeting in the world, with about 50,000 orthopedic surgeons attending.
Great.
Pediatric Orthopedic Society. So
I'm glad for that.
anyone that will invite us, we will present and discuss.
Okay, because I think that's what needs to happen. I mean, other physicians respect the fact that the study. The only other thing I would say is, how many kids were in this study?
342.
Have you thought of a follow-up to see how many would respond? And I don't know how to phrase the question. That's not something that I do. If they have become addicted to narcotics or illegal drugs.
Yeah, and there are a lot of great follow-up studies that we want to do and need to do. We had questionnaires that they completed before and after the study. There are about 30 other slides to include, but for the sake of time, I didn't. But in follow-up studies, asking about the exposure to narcotics, family exposure to narcotics, and then measuring more accurately the educational effect, because that's really what we saw the most, was education and expectation management and forecasting.
Well, going forward, I would really like to see if anybody would tell you whether they became addicted or not, and
Right.
we're anonymous. They could fill them out anonymously to do it. I want to thank you for practicing in Georgia. We need physicians. We need good people that are willing to look at different ways of practicing and bringing forth like this. So thank you very much
Thank you
for what you do at Children's and sharing this with your colleagues. Thank you.
Are there any other questions or comments from the committee? Well, not seeing any, I want to thank you. Very good presentation, packed with information that we need. I so appreciate your heart in this as well, and the work that you're doing to help other physicians realize what a true concern this is and how we can save lives.
Thank you.
Thank
Thank
you.
you for having me.
Thank you. All right, we're gonna switch up just a little bit here because we have a doctor waiting to do a procedure. So we're going to move on to we're going to just skip over everybody just a minute. We'll come back to the dentist. I apologize for that, but we have a tiny little window here to catch Dr. Shelley Street Calendar with the American Academy of Pediatrics and Dr. Jairouge Anathi at Emory Sports Medicine Center. Gonna connect to y'all, and then if you'll just take a moment and tell us, are we there? So, Dr. Calendar, you may be muted, but when y'all begin, if you could tell us just a little bit more background about yourself as well.
Well, good morning, everyone. Can you all hear me?
We can. Thank you so much. Thank you.
Thank you for having me, and it's a pleasure to be here. I would like to share my screen. Let's see if this goes ahead and works. Can everyone see that yet?
We still see you.
Okay. And I'll start with this slide because this will provide you a little background of what I'll be speaking to the group about in relationship to sports medicine in the realm of primary care sports medicine. But I grew up in Ohio, came to Georgia about 15, 16 years ago to work at Mercer University and start their sports medicine program. And then all of our two boys were born in the state of Georgia and are avid Georgia fans. And so this is a depiction of some of the pictures of the family. And we have now moved to Brunswick, Georgia area and live in St. Simon's Island. So our trajectory through Georgia, we've gone kind of through a lot of components of Georgia. So today, I'll share with you a little bit. About some of the other hats, like many of you wear a number of hats in your career and family lives, that I'm the chair of the Georgia chapter of the American Academy of Pediatric Sports Medicine and Physical Fitness. I also wear the hat of being the American Medical Society of Sports Medicine. I'm on their board of directors, and that's the largest sports medicine physician organization in the United States. I am multi-boarded, actually. I am internal medicine, pediatrics, and sports medicine. And then I also wear a hat. I serve as one of the physician members of our Georgia High School Medical Advisory Committee, affectionately known as our Sports Medicine Advisory Committee, affectionately known as SMAC. And so today, what I wanted to talk about is give you some background a little bit about what primary care sports medicine is, and then talk a little bit about where we've published some papers regarding the acute management of youth and adolescents in the realm specifically of primary care sports medicine. What I'm not going to cover, and it sounds like you all have had this covered by multiple other physicians, providers, et cetera, is really chronic pain management is sort of outside of my scope, and perioperative and postoperative pain management is also fairly outside of the scope of most of us that practice within the realm of primary care sports medicine. And to that effect, these are some of the articles. I highlighted 3 in this talk for you all so that I could kind of hone it down. I think that this one is one of the shortest articles that also gets to the meat of what we recommend as far as pain control. And then I'll give some examples of some of the things that I personally have done with regard to management of discomfort and pain in athletes. And that is the second article from the American Academy of Pediatrics. It's a much larger article and very much focused on opioids. So we talked a little bit about the background. The background of primary care sports medicine includes physicians that are pediatrics trained, internal medicine trained, family medicine trained, physical medicine and rehabilitation trained, and then emergency medicine trained. And those physicians do all similar fellowships in sports medicine and become a team physician or a practicing physician in sports medicine. All of these specialties may do some procedures. So we often will do some bedside procedures. Some people will do some injections, some spinal injections, but the majority, we are not surgeons. So no one is doing any surgical operations, for instance. When we talk about acute pain management, because we're often the physician that's standing on the sidelines during a youth or adolescent high school football game, we are also always involved in all of our major organizations across the country. There's usually someone who's primary care focused, that is sports medicine trained, that is also involved in the care of our athletes, in addition to, in often areas, an orthopedic surgeon. So we often work closely with our orthopedic colleagues, and oftentimes a dentist, depending upon the sport that you're talking about as well. When we look at some of the non-pharmaceuticals, so when we talk about our papers that go into how we should manage discomfort, we always stress that we should start with our non-pharmaceutical components. So a number of those include things like if someone dislocates or separates a finger, you want to relocate it. So we work on casting, splinting, icing, and that mnemonic, I'm sure many of you have heard of PRICE, protection, rest, ice, compression, and elevation. Not a lot of documented evidence to support that, and yet we all really subscribe to utilization of that mnemonic as one of our first areas of how we address pain and discomfort. And then there are some behavioral things. So we know that there's a component of behavioral. I'll give you an example on the concussion clinic that I started in our pediatric orthopedic area. We had our sports medicine practice. And in that sports medicine practice, we started a concussion specific concussion management clinic. And in that auspices, we had access to our marriage and family therapist training program. And so upon initial presentation or evaluation for concussions, we would include, as part of your visit, a visit with our behavioral health specialist as a way of, at the very beginning. We were actually just starting to look at evaluation of that process when COVID actually happened. And then unfortunately, those learners were not allowed in the space for quite some time. So they are just getting back to allowing them into that space on a regular. They were much like residents in training with their supervising colleague that looked over all of their materials. When we talk about pharmacological treatments, there are some of us that use a lot of topical medications, but there's not a lot of evidence in our youth and adolescent as to how topical medications might be utilized. Very rarely do people use injections for the same reasons, because our youth and adolescents, we really don't have a lot of data that suggests that we should be utilizing injectables for this particular community, different from our adult community. And then when we look at oral, the understanding is that we typically will start with acetaminophen or nonsteroidal anti-inflammatory drugs. And the data suggests that utilization of both of those together are more effective than either one alone. In those age groups under 12, we don't use muscle relaxants nor aspirin. And we try to utilize the lowest amount of dose of any medication, even our non-opiate medications, for the treatment of pain and discomfort. When I was first posed with providing some information to this group, I was interested because I personally have not used an opioid for for a sports injury that is not surrounding surgery. I couldn't even remember the last time that had ever occurred. A lot of our if you're using narcotics, that really involves your orthopedic surgeon in this particular age group. So speaking to personal utilization of it for sports injury, I can't actually speak to that because I've never found the need to really use it or need it in those circles. And so when we look at the pediatric summary of this document, they recommend that clinicians treat acute pain using a multimodal approach that includes both pharmacological and non-pharmacological therapies and non-opioid medications until you absolutely need opioid medications. And those are the reference. So I'm open to taking some questions if you have any, but I wanted to keep it short and give you some background and then allow for any questions that you might have.
Thank you so much. Committee members, if you have any questions, if you would just, got one right here. Mr. Breedlove.
Thank you, Chairman. Hey, thank you for your presentation. It was very informative. And you right at the end said something that prompts a question. I appreciate from a practical, and I'm sure I'm not a lawyer, but I'm sure from a legal perspective, the recommendations on delays of opioids being prescribed. But I keep thinking about something Chief Pursley said earlier about doctors that have, been practicing forever and a day, and back in the day, this was very commonplace. Do you find that there's an acceptance among prescribers today that opioids really should be delayed as long as possible, or is that just something written in a guideline?
When I look at within the scope of sports medicine, with that group that I am often represented as a member of the board of directors for both the AAP in that area and the AMSSM. The sports medicine group, that primary care sports medicine group, is relatively young because we're relatively a newer subspecialty. And two, I don't know that it's written anywhere as much as it's subscribed to. I mean, I sent out, just for curiosity, I sent out an email and a few texts to some pediatric sports medicine colleagues across the country that work at like Seattle Children's in Columbus and National Children's in DC. And all of them said the same thing. They don't remember a time that they utilized prescription opioid medications for the use of a sports injury that wasn't related to a fracture, acute fracture, or something that was surgical that they were actually doing in with their orthopedic colleagues. Does that answer the? Mhm.
Yeah. Yes, ma'am. Thank you. And Chairman, if I just may follow up. Doreen Barr is a friend to so many people here, and she lost her son Ryan to this disease as a football player about 11 or 12 years ago. And if she were testifying today, she would say they handed the opioids to him like it was candy. So I'm encouraged to hear you say that there's a shift in posture among newer doctors and prescribers, because I can assure you that was not always the case.
Thank you for sharing, and very sorry to hear that.
Are there any other questions or comments as we focus on this challenge for our pediatricians and their patients?
I do think it does offer us an opportunity within, because AMSSM in the sports section of AAP, we have over 5,000 members in those two groups, and we represent physicians that take care of every NCAA college across the country, most of our elite sports, all of our Olympic sports, much of our youth sports, and many of our high schools, that we may be in a position that we could actually poll our membership and find out what their trends are. But we actually, as a group, even in 2000, it was 2014 through 2000, and another one, I think in 2022, the board of directors put together a letter to Congress regarding pain control, stating the same as what I've shared with you all today. So I do think the word is getting out, and any way that we can help get it out further would be beneficial, I think, to anybody and everyone involved.
Thank you very much for and of course the pediatric group meets. Have they had a program on this, or what the trends are, or maybe an update at one of their statewide meetings?
So the last article I shared with you all from the American Academy of Pediatrics, but the American Academy of Pediatrics has also placed statements about the utilization of pain control for adolescents and youth, and pretty much have stated the same thing, but they regularly actually provide education and information surrounding those tasks. And the Georgia chapter has 3 state meetings that they have an opportunity to do the same.
Okay, thanks.
Thank you. Thank you so much. Anything else from the committee? Well, I really appreciate you taking time. I know your schedule's pretty tight, so we really, really do. And I do think, like you said, anything you can do to help create awareness and education. So if one of those polls that you're speaking of might just simply bring it to the forefront among your peers, that could be very powerful. If you should ever do anything like that, though, would love for you to send it on to us. This will be an ongoing conversation, certainly at least through this year, but I don't think it's something we're ever going to check the box on and walk
Right.
away from. So please continue to help us do our best for these youngest who particularly need our attention.
Absolutely.
You have a good day. Thank you.
You too. Thank you so much for accommodating our schedules.
Absolutely. I think our next speaker is connecting. There. What if we take a 5-minute pause in case anyone needs to run down the hall? And we'll come right back and try to do this, accommodating her schedule. Thank you.
Chance that they already have it loaded, which is what she told me.
That's fine. If they don't, I'd rather do it on mine with Keynote.
They do have this one. They have it loaded already.
I can get, so I just, all I do here is just hit,
So
go to my little thingy
Yep.
right here.
yep, just
Yep.
hit from beginning.
Yep.
Yeah.
Again, yeah.
Yeah.
Okay. I have mine.
Hello.
Neighbor, they just went on a short break while you were trying to get on.
Okay.
Okay, so they'll be right back.
Okay. I just have to inject one person. I'll come right back in like 2 minutes.
Okay,
Okay. Thank you. Hope things went well on your end.
went fine. I have a
Okay.
few more minutes, but I may have to cut out early when you're speaking, okay?
Okay. Yeah, I got it. And hopefully they gave share privileges. It looks like they did. So, okay. I'll try to.
They did give share privileges, so you'll be
Yeah.
able to share.
Great. Thanks. Okay. Hopefully that helps. And I think you think we're okay for 2 minutes? I'll do one injection and come right back, or looks like we have a couple minutes. What do you think? Be back in just 1 minute. All right. Are people able to hear me? I think okay, great.
As soon as we can get back together, we'll get started again.
And I don't know if Shelley, if you're still there, if what time you guys think you went over AAP opioid use guidelines, just wondering what the discussion already was, so I don't repeat anything.
I just shared that,
Okay, we're about ready to return for the next presentation here. If y'all are. So our members mostly are back, and let's reconvene here. So Dr. J, I'm going to tell you that I cannot pronounce your name. So I want you to take a moment and introduce yourself and tell us a little bit about yourself as well.
Sure. Actually, that's great because I actually end up going by Dr. J because I don't even think my wife knows how to pronounce her last name. She goes by Mrs. J sometimes.
Well, I won't feel so bad then. Thank you.
Yeah. So, well, thanks for having me, and thanks Dr. Colander as well too, and the group here. I know this is a very important topic. I'm an Emory sports medicine physician, and like Dr. Colander, I'm a non-operative, we call it primary care sports physician. I'm in the orthopedic department, but also I'm a professor there, and also in the family medicine department. And I co-direct our youth sports medicine program, and the bulk of my research over the last 20 years has been in youth athletes and actually in tennis players, but particularly in youth athletes. And so I have I guess a bit of a passion for trying to do the right things for young athletes. And yeah, I can say all the other fancy things and the professional or college teams and all these things they might help with, but the most important thing is I think taking care of the young people, particularly in our community and state. So, so that's why I was trying to see if I can even share a couple of studies that we've had done at Emory that just highlight some of these things with youth athletes and hopefully give context. If I'm not mistaken, I think maybe there might be one representative who's medical, but otherwise most others are not medical. Is that correct?
We have several, not all are in the room, and we may have one or two online as well, but
Okay.
different medical related professions.
Yeah. So yeah, so I try to keep it so it's understandable for all levels. So the first study, I want to just talk about is actually quality of life in youth athletes following injury. And we understand in general, youth athletes do get hurt, but we have to look at them differently than adult athletes, and the response to injury is different. I think most of us who have aged to understand pain and understand that's a daily part of your life, but with the youth athlete, it's a little different and maybe new. So this is a study, I give credit to Dr. Rajiv Verma, who's in Chicago now, who helped with the study, and he just presented this because we got it published, and so he created some of these slides, so it helped me a lot. And so, you all know that millions of kids play sports, and even millions of kids may lose time in school because of sports, and there's a lot of money involved, and there's a lot of anxiety as a result of it. And so how do we evaluate what we call the morbidity or the consequence of these sport injuries? So one way is looking at what we call the quality of life. And there's specific parameters that we use that are a term we call health-related quality of life measures. And so we don't have a lot of information on what type of quality of life measures are following injury in youth athletes. And so that involves a lot of socio-emotional things, mobility, some of the things you see on this slide right here. And so, we just know of a few studies that show that while athletes have superior mental and emotional, physical well-being in general, after injury, they may have some more bodily pain, and that might predispose you to pain management strategies. So, and some of the things we've learned, we published on about 350 athletes from 2 other centers in the country, Boston Children's and Lurie Children's in Chicago. And we found that actually the quality of life measures are worse 1 month after injury, specifically for females, young female athletes, if they're more mature and if they needed surgery. And so, but for all others, actually, it was not as big of a deal. In other words, you fracture your clavicle, people get it, kids even get it, and they move on, and it doesn't really make a big impact. You need ACL reconstruction surgery, it makes a big deal. Females seem to get bothered more. And the other area is a chronic overuse injury. So we want to know what would happen at 2 years out. Like, does this continue to happen or not? And I have to thank our academy and our Emory department for helping fund some of these longer term studies. And like I said, we looked at samples around the country. I would say about half of the athletes were from our center at Emory. And we look at kids. I always enroll like 8 to 18-year-olds. We're looking at younger kids too, and their response to injury. And again, there's basically 6 domains when we talk about quality of life, and you can see them on here. It includes like peer relationships to fatigue and mobility and sadness. And like I said, about 22 patients in our sample had surgery. And what we see is that at the 1 month mark, you see on the left of the screen, some of the measures are depressed, like we said, where their mobility, for example, might be decreased, but most resolve by 1 and 2 years, and their quality of life is actually pretty good and normal. So we don't see the long-term effects that sometimes we fear with young athlete injuries in most athletes, not all, but most athletes. And so we're very happy with that. So we want to encourage kids to play sports when they get injured. The problem is that we're seeing the female athlete be the only group that has continued problems, even at 1 year and 2 years. And you can see that this is a persistent problem, and it's significant. And so for whatever reason, we're still continuing to have a female athlete issue with quality of life following injury. And this has been seen by other investigators as well. And the other area is surgery. When kids have surgery, it really impacts their quality of life. And so a lot of our preventive measures like ACL injury prevention are to try to reduce and prevent that surgical outcome. And so we know there may be some short-term deficits, but in large part, except for females, we can still encourage kids to play sports. It's reassuring because we're not seeing the long-term effects of sport in most kids. So then it leads to the surgical issue, and I want to talk about my colleague, and he's the chief of our sports medicine. We call him Dr. X here, and his group did a really phenomenal study looking at opioid management following surgery, which is really the key of this group, I guess. It takes a lot of people to do this. They had a lot of good funding, external and internal, and you all know the impact of opioids and how many bad things can happen from it. But the specific things for our population, teen death is a big deal. And the first exposure is usually from a doctor. It's a prescribed physician. And a lot of it is related to acute pain or surgical management. And so we know the side effects, but when you get euphoria from it, that's the thing we don't want kids to get to. And that comes from a first use or prolonged use. So the goal of this study was to reduce it during ACL surgery. And it was very cool study. Basically, they use an app to monitor pain throughout the postoperative period, and then and look at the pill count and how many pills they use. And very simply put, they basically had three groups. You either got 50 pills, 30 pills, or 30 pills, and some education about how you should limit opioid use. And in 264 surgical patients, this was the
This
coolest
figure
finding.
is showing tablets consumed by each cohort. In red, we can see that the 50 tablet cohort consumed an average of 25.4 tablets. In blue, we can see that the patients prescribed 30 tablets took an average of 15.6. In yellow, we can see that patients receiving education consumed 12.4 tablets.
So what
Compared to
does
the
that
50
mean? That's a pretty,
This table is showing mean pain
and
scores
I'm
from
gonna
post.
kind of go past that.
This table is showing
So what does that mean? The surgical patients were using half of the scripts they were given. So if you're given 50, you only use 25. If you're given 30, you only use 15. But if you were given 30 and then educated that you don't need to use them and pain is a part of the process and just understand when it is, you only use like 10 or 12. So now the new protocol is actually just give them 15 and educate them. And so just having a significant drop in the amount of prescription opioids used, even in that period, helps reduce it and educating them. And so I think my guess is with Dr. Colander, she probably shares what I do is we don't use opioids in sport management, even in fracture care, and maybe I missed it if she did. But in large part, acute injuries, people understand, surgical injuries, we can reduce it. So for us, I think in the sports world, opioid management in young athletes should be a very restricted group. And I don't think there's really strong indications. I followed thousands of athletes through our research studies, and I can independently recall probably maybe a half a dozen that we talked about opioid use in those settings. So hopefully that gives you a bit of a quick idea of what our studies have been kind of looking at this from the Emory side and young athlete side. And we work together, good things can happen sometimes, right? I'm happy to take any questions or thoughts on this as well from the group if you have.
Well, thank you so much. And thank you for sharing that data and perspective with us as well. I value your passion, as you said, to try to do the right thing for young athletes. I have several grandchildren that are playing in sports now, and they are beginning to get hurt. I think right now we have a broken wrist, something that has to do with growth plates and a few other things going on. So I really do value all of the work that is done to help them, not only at the moment of an injury, but also to make sure that for their life, they are going to be able to be very physically able to continue with what might be their passion. So our first question is from Chairman Cooper.
Thank you for the presentation. Under the new norm of what you give, Tylenol and naproxen, but you also have down here oxycodone.
Yes. So
That
it's still part of the treatment. So they give 15 pills. And this is, I don't do the surgeries, my colleague is doing surgery, but yeah, they give, rather than 50 pills or 30 pills, they give a reduced amount, about 15 pills of the opioid with education. And so they're finding they're using about 12 of those.
is that routinely that they give it to every injury?
No, this is only for the surgical patients. In our non-surgical cohort, I can tell you from my perspective, we don't use opioids. And then there is one procedure that I do called PRP, and I do it sometimes in young athletes. We'll give a tramadol, which is not really considered an opioid, but has weak properties like an opioid, and we'll give a couple of pills of that. They may use for 1 or 2 days, and I would say maybe less than half use it, and it's about 1 or 2 pills. But otherwise, in non-surgical management, I think opioid use is extremely rare, should be extremely rare.
But it's an automatic give with the surgical patients of oxycodone.
So again, I can only, yeah, and this is actually a reduction. This is, and they have to have some sort of pain management strategy. It's post-operative for a pretty big reconstructive surgery. And so they are typically given, and now again, I can only comment on what we have presented from our study because I don't do surgery, but yes, typically you have to have some pain management. Tylenol, unfortunately, alone post-surgically would not be adequate.
Okay. I mean, considering in pediatric patients, they say about 30% of them become addicted
Correct.
because of the surgery. It seems like, and I'm just a nurse, I'm not an orthopedic surgeon,
Sure,
thank goodness.
Yeah.
And but as we try to reduce the number of people that become, and especially children, they're they say about 30% that get pain medicines after a surgical procedure, they become addicted. And, I think the prevailing thing is we really shouldn't give them to kids under 18.
Yeah, shouldn't need it at all. Yeah.
It just concerns me that it's an automatic prescription.
Sure. No, I think that's a fair point. And actually, it's a good question. I'll even ask my surgical colleagues. But I have to ask them what the alternative would be. What is there? And I'm with you. I mean, I'm personally very scared to give any any sort of opioid. So I actually don't. I can't even remember the last time I even prescribed an opioid, except for tramadol very occasionally. But this is actually a big progress. And you're right. That's not even the standard of care. I'm confident that there's a lot more opioids going around that aren't done by my Emory colleagues, surgical colleagues here. And so I think, even the very first step is reducing them, as making that the standard, and then eliminating them would be the next step post-surgically. But you have to have another, what is your pain management option beyond that? And I know they've explored, different types of anesthesia during the surgery and things, but post-operatively, what is your option for the perioperative period?
I mean,
I'll ask. That's a
there are
great question.
places, I'm sorry.
That's a great question. Mhm.
Well, and there are places, I mean, like Wellstar, I think, has almost decreased the use of any kind of opioids after surgery with, different methods. And it seems like, especially with children,
Mhm.
that Emory should be leading the way.
Yeah.
I'm a little prejudiced. My husband was an Emory Medical School graduate
Yeah.
and undergraduate and
Yeah,
an
we
NPA
should. We
graduate.
should. Yeah. Yeah, and again, to be fair to my surgical colleagues, I'm just presenting the slides from this study, so I can't comment on the exact, because there's a lot of surgeries being done, there's instability and all these different things, and this is only on a cohort of ACL reconstruction, which is a pretty large surgery. And so I can't say that this is every surgery gets this. This is only a study on one population of one type of surgery. So it's entirely possible that other surgeries are not.
Not giving it. Okay.
Yes, and so
Yeah.
that I don't want to say like, oh, every surgery that it can get. This is this was an evaluation study on just one population of a larger surgery, like a reconstructive surgery with ACL, and a reduction in
Well,
opioids. Yeah,
okay. Thank you very much.
yeah. No, those are great questions, and I'll circle back too. I think those are great questions, and I can even email Morgan. I certainly don't want you guys to walk away thinking, oh yeah, because you're right. Like we look at it as trying to, I guess from a scientific point of view, be the leaders in practice, about how we do some of these things. So yeah, I'll circle back.
Well, at least, I mean, it's an improvement. It says like,
Yeah.
They get Percocet 50 pains when given, they use 25. If it's becomes standard just to not order more than 25, that is the first step toward it. But of course, with children, it would be to eliminate them at all
Altogether.
possible.
Yeah.
For checking.
Yeah. Yeah, it's down
Thank
at 15. Yeah, and then they're using like 12. But yeah, no, I agree. So yeah, it's a great point. Yeah. Any other questions?
Yes, we have a couple lined up here. First is Mr. Breedlove.
Thank you, Chairman. Doctor, thank you for your presentation and your good work. I am going to go ahead and ask this question. And you prompted the question based on a phrase that you used, and I think you said often, and I want to qualify that often first exposure, that's the phrase that you used.
Mhm.
And that made me think, people like me, we trust the white coats.
Mhm.
There's a lot of respect for doctors and nurses, and that white coat means something. and a family comes in a time of medical crisis, and they're given these legally prescribed products. And I respect the 70% of Americans that nothing ever happens to them.
Mm-hmm.
But to Chairman Cooper's point and other testimonies, the 30% that it can and does, as a person in recovery, I've met many of my brothers and sisters that are very fortunate to be alive or are not alive, because that first exposure very quickly led to heroin or fentanyl or something else, and they are now dead or bankrupt or facing all kinds of societal stigma. And my question to you is, if first exposure is a reality, from a medical efficacy point of view, is this not like in the 1940s and 50s with cigarettes? I mean, back then, doctors and celebrities did commercials and they recommended and endorsed brands. And nowadays they're like, well, we didn't know. And we certainly, from a cancer point of view, do all we can do about cigarettes and tobacco. Are we in a position where we need to acknowledge that this product with first exposure can literally lead to the death of hundreds of thousands of Americans, and it's, from a medical efficacy point of view, wrong in the first place? Would you comment on that?
Yeah, and I should know my place in this because I can't comment on pain management practices, but and that's how I practice. But I have the privilege of practicing in a kind of more refined practice that's in sports injury practice, and I'm with you on that. I have a lot of fear personally for opioid use, so I don't prescribe it, and especially in the young athlete. The other areas that may need to catch up are in a setting of acute injury, and that includes emergency rooms and other areas where people get it. And I think I'm with you. I think that we need to, and I don't know if it's a legislative thing or if it's there's ethical, or if it's a physician practice, or all of them. But I think we need to take a hard look of where the initial prescription starts, right? And so the setting of acute injury seems to be that, and surgery is another one. And chronic pain in young athletes is rare. So, and I'm only talking in my world. So yeah, I'm with you on that. And I think we have to look at it. And unfortunately, and then when I was practicing 20 years ago, everyone said, you have to ask the pain score, you have to ask the pain score. And, I actually am not a big fan of pain scores at all. I don't like a pain score because it almost like says, oh, you're not allowed to have pain, but sometimes you hurt and it's okay and you can control it and you'll still have some pain, and we have to change that mindset. And we've improved from 20 years ago, but we still have work to do. And I agree with trying to, essentially eliminate it except for rare uses, perhaps, in non-musculoskeletal care for youth athletes.
Thank you, sir. Thank you.
Thank you.
I could
Ms.
probably take
Payton.
one more question if that's okay.
We've got one more for you.
Yeah,
I actually
Ms.
don't have
Payton.
a question. I have more of a comment. I just really wanted to commend you for using quality of life as your overarching measurement when talking about how individuals are affected by the opioid crisis and opioids in general. I think that's a measurement that is predominantly left out when we're examining individuals who are affected by the opioid crisis, and using sub-measurements like anxiety, fear, depression, fatigue. I'm just really encouraged to see those being used as measurements in opioid-related research. So I just want to thank you for that. And this is very encouraging overall. So thank you.
Thank you. Thanks for the comment. It's hard to do those. It's hard to get, young athletes to complete 20-minute quality of life measures and follow them, but thank you.
Well, thank you, Dr. J. And you've given us some great information to look over as we prepare to address this issue, not only now, but in the year and years ahead. We won't wrap it up, I'm afraid. Sadly, there will always be this challenge. So if you discover any more information that you'd like to send or think that would help us, please do.
Yeah, no, definitely. I'm very interested in the cause, and wouldn't have kind of snuck out of clinic and probably get yelled at by patients if I didn't feel it was really important. So I appreciate you guys letting me, put my 2 cents worth in there.
We appreciate your patience allowing you to sneak away. So thank you. Get right back to work.
I will. Thank you all. Okay. And keep up this important mission. Okay.
Thank you. Thank you.
Bye all. Thank you.
Okay, now we'll return, and I want y'all to know that we have been joined by two of our committee members online as well. Dr. Hawkins and Dr. We've all struggled with that name too for a little while. So,
Always.
glad you're here though. Thank you.
You.
So let's get right on to our next presentation, which will be coming from Janelle Adams and Dr. Mike Pruitt with the Georgia Dental Association. Thank y'all for being here.
Of course. Good morning. I realize that we stand between you guys and lunch, so we won't be overly long. I'm Janelle Adams. I'm the Director of Government Relations with the Georgia Dental Association. I want to introduce just a couple of people that I have here with me. I have Dr. Richard Weinman, who's a former GDA president, as well as our co-chair of our Government Affairs Committee, and our current GDA president, Dr. Jamie Mitchell. They're here if you guys have any questions after this. They'd be happy to talk with you. I'm going to introduce Dr. Mike Pruitt, who's going to give you guys, he's the expert on this, not me. So he's going to give you guys your presentation, but I just wanted to thank you guys for the work that you're doing.
Certainly a privilege to be here this morning. A little bit about myself. I was a graduate from the Medical College of Georgia School of Dentistry back in 1992. From there, I went on to do a hospital residency program at University of Virginia, and I did that for 2 years. Came back private practice, and then I taught at the university down at the dental college for 26 years. I recently retired, but I ran the residency program in hospital dentistry for 21 of those years, and then the rest of the time as in continuing education, which is really what we need to be focusing on in our profession in terms of managing this issue, is the continuing education aspect. But what's interesting is I guess I can actually make my comments based on it being a reformed practitioner. Because just to kind of give you an idea, you've heard several of the other speakers say that, historically how we got into this situation. And when I was a young resident, I got to the University of Virginia, and I was basically told, oh, you need to prescribe more medication. You need to prescribe medication. And it's one of those things where you don't want your patients to hurt. And I did a lot of cancer patients, a lot of other things. But overall, it was one of those things where I literally was pushed to do it. And to kind of show you a sign of the times, we would go to a dental meeting and you had companies there. You had McNeil and other companies and some of the others, but you could fill a piece of paper out and they would send you a box of Lorset, a box of Vicodin would come to your house. It's one of those things. So it was kind of a crazy situation. And then we realized that, as we all seen the data, which I'll get to a little bit of that, but in the gist of it, we discovered that we in dentistry were part of the problem. And that is, nobody likes to admit they're part of the problem, but we're not the total problem. We do treat a lot of people in their young ages. And we, in doing so, we can potentially be that first time they are treated with these medications. There's certain things now we're doing that we're cutting that off. So as I get started, let me just tell you one of the things that we've done is that, let's see here. Let's see if I can get this computer to work. Yeah. Okay, here we go. Maybe I'll get it to work. There we go. I'm used to a Mac. Okay, let's see. Right there. There we go. Okay, so one thing the Georgia Dental Association did, I actually had the opportunity. I was one of a general dentist working with an oral surgeon, and we were in charge of the Georgia Mission of Mercy. We've done this throughout the state of Georgia numerous times. We provided a significant amount of free dental care to people that in need of it. And one of the areas you can imagine would be really sought after is going to be extractions. And so when these extractions are done, we did our first GMOM event. We did offer a few narcotics. And we did that. It was a very limited basis, and we didn't have a whole lot of trouble there, at least that we know about. However, with the enlightenment that we as professionals have had, we elected in the last few GMOMs to limit what we prescribed to non-opioid analgesics. And in doing so, I was able to follow up these. We did 2,500 extractions, a little over that actually. And all the follow-up was done by my residents at the university. So we had a telephone that we dedicated to us. And I will tell you that after 2,500 of those extractions, we still only took less than 10 phone calls, for pain management afterwards, which was amazing. And I will say that we had one patient come in that was given something a little stronger, but they also had that combined with a post-op infection that resulted in more discomfort. So, there are those patients that will eventually need those things. Now, in dentistry, what's interesting is we should be somewhat of experts when it comes to managing analgesics. And the reason so is most of the analgesics that you're aware of are actually, tested, and their efficacy is actually tested on what we call the third molar model. Because we have a patient population that's young, healthy, the surgery is basically the same almost every time, and we know how long they should hurt or how difficult it should be. And so if we use the wisdom tooth or third molar model to test medications, then we know how well they work and don't work. What we in dentistry know is that, historically people would push narcotics. Now we know that looking at our third molar model, that ibuprofen alone is actually better than a combination of hydrocodone and acetaminophen by itself. And so, the effort is to push that, to educate people on that. So in dentistry, what else have we done? Being a member of the Georgia Dental Association, our Georgia Board of Dentistry, the people we have lobbying here in our government agency, we have been very proactive in the sense that now we require an opioid update by all of our dentists, when they get their license every 2 years. I actually teach that course around the state, and I will tell you that we offer it not just one and done. We actually offer it probably every month. That course is offered somewhere in the state of Georgia. We combine it with other meetings we have. And in doing so, what's nice is from the time I first taught that course to now, I've changed and updated my material that I educate my cohorts on, because we are coming up with new things, which I'll enlighten you with in a few moments, on better ways to treat our patients in their discomfort following surgery. But one of the things that I did want to touch on, and I guess I have the privilege of following some of the other speakers who are much better than me, is I got some ideas from them on things I wanted to enlighten you on. One of the comments out there is, how do we find ourselves in this situation? And there was a dentist who practiced in Ohio. She was a mother, a dentist, just a good person. Sadly, she became a spokeswoman, for this crisis, because she had a son, of all things, who had his leg injured in a motorcycle accident. He got addicted to narcotics. He then ended up, of all places, this is sad to say, in a rehab facility in the greater Atlanta area. And when he was in the Atlanta area in his rehab facility, he got addicted to heroin. So following that addiction, from his being treated for addiction, he gets addicted to heroin, another drug. At the end of it, he ends up taking his life, dying. But she has a quote that I end all of my lectures on opioids that I think is a good one to begin this lecture with. And that is, she says, one of the biggest problems we have as practitioners is that we must educate our patients. And what we have to understand is society as a whole is our problem right now, in one aspect, in the sense that we have gone from a society that expected us as clinicians, practitioners, to help them manage their discomfort, to manage their pain throughout their surgeries, their postoperative period, to now we have a society that wants us to eliminate their pain, to make it where they have nothing. And so we have to, as I tell my residents, it's the front end conversation I have with patients that actually makes this very manageable. And so in doing that, the things we talk about is going to be alternatives. And we talk about alternatives, and I talk about analgesic ceilings. And I touch on that. It's kind of a boring topic. But we as clinicians and our patients, we must tell them there's certain things that, you take a drug to a certain amount and we get an effect. So we hit a ceiling with it. So when I take ibuprofen, once I get above 400 milligrams of ibuprofen, I don't really get any more pain relief. I get a longer duration of pain relief, and no more really increase. If I hit 600 milligrams, I get anti-inflammatory effect. That makes it last a little better, does help me with the pain. Same thing when it comes to Tylenol. The analgesic ceiling of Tylenol is about 1,000 milligrams, one of the previous clinicians reported. So if you get above that, you don't really get any efficacy out of it. So, understanding this and combining these things will help us a little bit. And it makes it where we can be better clinicians, if you will. And one of the things that we, as a profession as a whole, not just in Georgia, realized, and it was an article that came out in the Journal of the American Dental Association in January of this year, is that dentists at this point, between 2015 and 2019, are prescribing opioids at a rate 35% lower than they had, actually it's 38% lower than they had been prior to that, which is a good start. They actually narrowed that focus down. They showed that some of the dentists, up to 60% of the dentists, were between 35 and 80% reduction in what they're prescribing. And here was the good news, is as bad as it is, the good news was only 3.5% of dentists were still doing it in the old-fashioned way. And that mentality you've heard numerous times from other speakers is, I've done it this way because I've always done it this way. It's the way I was taught, and not evidence-based. So luckily we're down to 3.5. And my joke about that is my residence is those guys will all retire soon, so we won't have a problem with it. We can just educate those that are coming behind us and those that are here with us today. So on that note, the other thing, we talk about the analgesic ceilings. We utilize those to affect opioids. Some of the opioids have an analgesic ceiling, but a lot of them don't, and that's a problem, because the ones that do have the analgesic ceilings are ones we don't ever use. But the ones that don't have a ceiling, i.e. hydrocodone, the oxycodone, those, they don't have an analgesic ceiling. And so you can actually take more and more of them and you get more and more relief, you get more and more effect. The irony is, for us in dentistry, the limiting drug for me prescribing a patient a narcotic or an opioid like hydrocodone or something like that is not the hydrocodone itself, it's the drug it's attached to. Because most of these drugs that we use are all combination drugs. So they're combined with hydrocodone and acetaminophen. Acetaminophen is a drug that actually, if you want to know the truth, it leads to more overdoses, admissions in hospital emergency rooms than any other drug out there. It is overdosing of Tylenol. And I'm a hospital dentist for years, I can tell you that. And it is a big, big issue. However, it is the limiting drug in this combination. But for dentistry, I list this list of drugs here. Predominantly the most prescribed opioid in dentistry is hydrocodone and acetaminophen. It's about 68% of all prescriptions are done with that if it's an opioid prescription. The codeine falls behind that at about 30%, and there's fewer and fewer and fewer. So that's a good thing in itself, in the sense that they're not the most horrendous of the narcotics, but still they're bad enough. Now, when we look at the narcotics or opioid groups, I broke them down into 3 groups, and when I educate dentists on this, I want them to know that, group 1 is where you have your naturally occurring opioids. You got morphine, you got codeine. These are naturally occurring things. And, and they used to be, and that's why the morphine is considered like the gold standard, in the sense that it's what we gauge everything else against. You've got a semi-synthetics, that's where our hydrocodone, our oxycodone, those drugs are in that group right there. And so they're kind of partially, synthetic, but some natural components. And then you've got group 3, which is the group that now is getting all the headlines. It's all the synthetics, it's the fentanyls, those kind of drugs. I am a user of fentanyl myself. I do IV sedation all the time. The joke is that my patients like me because one of us is going to be sedated. So they all like me. Y'all were supposed to laugh at that, by the way. But it's but no, the thing about the sedation is where I, as a practitioner, have had the opportunity to shape my practice, but also shape the minds of hundreds of doctors behind me, because I taught and I lecture all over the country now, is that when I am sedating a patient, I know, as you've heard from previous testimony, that the developing brain of a child, actually developing brain of a human being, is developing up until age 25. So a lot of people don't realize that. If it's developing up to age 25, the last thing I want to do is expose them to a narcotic if I can avoid it. So just this week, 2 days ago, I'm sedating patients over in Macon, Georgia. I'm taking out an impacted tooth on a young man. He is 9 years old. And I talked to mom, and here's where we in dentistry I feel like are doing a good job, is I talked to mom and I said, hey, we have a lot of issues with opioids this day and age. I'm going to sedate your son today. I'm just going to use Versed today. It's a good drug. We're going to follow it up with over-the-counter analgesics. I'll give you a combination of things, which I'll talk to you guys about momentarily. And I know that when I talk to mom about this, I always tell them, Mom, if we find ourselves in a situation where we need something stronger, we can always prescribe that later. However, since his brain is going to be developing up to age 25, I prefer to wait to do that later. And what I have found, I have had 0 patients ever say, no, doctor, I need a prescription today. I've had not a single parent tell me that, because I said, hey, I'm a dad of 3 daughters. And this is what I did for my kids. I sedated my kids. I took their wisdom teeth out. I treated my own kids. I did the thing. And I know I treat your kids like I treat mine. So that's kind of the way we do it. Now, the cool thing to know, though, kind of a little different, is if you are allergic, let's say to morphine, you can actually take a semi-synthetic a lot of times, or a synthetic opioid. So that's why some people say, hey, I'm allergic to morphine. I don't have to worry about this. However, you can, because if you're allergic to morphine or codeine, you can still take fentanyl in most cases. It's very rare to be allergic to both of those. So just for your knowledge, know that. Now, one of the things that we're doing really and being successful with is using non-steroidal anti-inflammatories. Now, we talked about that. Several of the clinicians ahead of me talked about this in length. And when we talk about those, the most common is going to be ibuprofen, which we're all aware of. Then we have naproxen to leave that we talked about. We have diclofenac, which is Voltaren. Not quite as often. You'll see it on TV. It has a cream that you rub it on your back, that kind of thing. But from a dental standpoint, the tablets are very effective for an acute pain situation. And then one that's really, really effective, especially if you've had a kidney stone, you'll know you've heard of Ketorolac or Toradol. Toradol is a fantastic drug. However, a lot of dentists can't use it. I use it, but that's because I start an IV on you or I'll give you an IM injection. You need to give that drug as an IM injection first or IV and then follow it up orally. But I will tell you, it's a fantastic drug for acute pain afterwards. And it's the classic for kidney stones, those kinds of things. So we talk about these drugs. How do we implement them? So we've got these alternatives that we're using in dentistry. The way we really are pushing it now is we're doing combination therapy. So we know that ibuprofen works great. We know what the ceiling, the analgesic ceiling is. But if we combine it with another, analgesic that's a non-opioid, i.e. acetaminophen or Tylenol, we have the combination, we get a synergistic effect. So what that means is the two of those drugs together, you can take them simultaneously and they work really well. Or a lot of times what I tend to do with my patients following wisdom teeth removal, I'll have you take the ibuprofen at noon. At 3 o'clock, I'll have you take the acetaminophen. I have them do it every 6 hours, but I stagger it for the first 24 hours. Then after that, if they need to take it again, they can take it every 6 hours. But by taking those drugs, alternating a drug every 3 hours, but the drug is still on a 6-hour cycle, they're not going to ever have a lull in something that relieve their discomfort. And that's going to be huge. If I do have to use a narcotic or an opioid, we'll try to go with one of the lower, likely to be of an issue, which is going to be codeine. Codeine is metabolized more. Most opioids, when you take them orally, you actually lose through the first hepatic effect. You lose 50% of the drug as it's metabolized throughout the body, unless you give it IV. So the one that's least metabolized that way or lost hepatically is going to be codeine. But we can use it in a very low dose along with ibuprofen. It's very effective. Now, some of the combination drugs we know work super. Like I told you, the best one for us in dentistry, ibuprofen, acetaminophen. Ironically, people try to market, and you can see I put an ad up there, this dual action, Tylenol, a dual action Advil. Great idea, but once again, I don't know if it's because it's, who knows if it's regulatory in nature, but the drugs in that preparation are subtherapeutic. And that's why I brought up my whole analgesic ceiling thing, is if you look at the prescription in there, you've got 250 milligrams of ibuprofen in that dual action pill. You only have 125 milligrams of acetaminophen. You'd have to take a ton of those to even get therapeutic. So you're much better off taking just over-the-counter regular dosages. Now, in terms of pharmacology, that's kind of what we're doing in dentistry. One of the things, though, that dentists do, and we take pride in, we give over 300 million injections a year. We give local anesthesia to everybody. Y'all hate us for that, unless you're me, and I'll put you to sleep before I do it. But when I give you a local anesthesia injection, we get a lot of benefit. The thing that can often be, we often say that it was that development of local anesthesia. It was probably the most significant, finding in dentistry, or most development of all of dentistry. But the thing about it is we have newer and better anesthetics. And one of the anesthetics that we don't use as often as we possibly could, that we do use, and like in my program we use, and I talk about all the time, is if I do a large procedure, let's say a surgical procedure on someone, I'm going to cause a lot of discomfort. I can give a block with what we call Marcaine. And Marcaine, not only does it last 6 or 8 hours, I use it on all my wisdom teeth patients, but as studies, I got 2 studies that reference up here, it'll actually give you pain relief up to an additional 48 hours. So it increases compared to other anesthetics. And so it's hugely beneficial there. And on top of that, what we've done is there's been some research with orthopedic surgeons and other groups. And now one of the areas that we're using, another form of that, is basically the same drug. So it's Marcaine, bupivacaine. It's in a liposomal form preparation. So it's basically in a fatty preparation. After an hour after you've given your regular local anesthesia, I've done a big surgery. You see all these things on TV, teeth in a day. So if I do all on fours or whatever, when I sew you up right at the end of the procedure, I just go around and inject in the area, or do this around wisdom teeth. And what'll happen is for the next 3 days, it'll slowly leach out, if you will, slowly is released. And that slow release, what we find is I've got numerous residents who use this here in the Atlanta area. They're not having to prescribe any opioids for those patients. They can just give, their usual Tylenol and ibuprofen, and that seems to be all they need. So, that's a great alternative I think we have available. Now, the first speaker I came in on was talking about what things cost. This is the only problem with this one. It costs a little too much. And if we can find a way to make this a little more, tolerable, make it where we get, I do have, or have had several of my residents find ways, and I'm not exactly an expert on it, but they say they have been reimbursed by insurance companies for this, for patients who they wanted to cut down the use of opioids. So there has been some reimbursement. I'd like to know more myself. And then the final, I kind of end things. This was just to kind of show you how serious we are in dentistry. This was a group, solvethecrisis.org, and it's the slide doesn't project well. I hope it's in your handout. And it basically was a group of dentists, general practitioners, endodontists, periodontists, oral surgeons. Everybody got together and trying to put their brains together. And, whether this was totally evidence-based, I think they probably tried as best they could, but came up with what would be, if you're going to prescribe an oxycodone tablet, how many tablets do you think would be appropriate for certain procedures? And as you can see, a lot of procedures in dentistry that a lot of people would at one time have prescribed drugs for now no longer are in need of anything. And what I find is when I look at this form, I think it's a great guideline, but I will tell you that along with something you've already heard today, which is if I educate my patients and tell them what's going to happen, I give them really good post-op instructions, which that is the key. I think one of the doctors talked about it, and I have my staff give them post-op instructions before I see them. When I walk into the room, I give them post-op instructions. We give them written to the mom to read or whatever take while they're having the wisdom teeth out. And at the end, we always ask them if anything's going on, and then our office contacts them that night after the surgery. So what I find is a well-educated patient. I do something that none of my colleagues think I'm crazy for doing. I give every patient I cut on my cell phone number. Now, that may be the most insane thing you've ever heard, but I honestly will tell you, I probably get maybe one call a month. And I feel like if I've treated you, you deserve that privilege to be able to get in touch with me. So that's just my thought on it. On that note, I will say that the Georgia Dental Association, I'm speaking on their behalf, we are an organization that is trying the best we can to help. We can't solve this problem, but we can certainly make it better, and we can do our darndest to solve it. And I think with the way our organization is creating avenues for education for the doctors that are here, you don't have to be a Georgia Dental Association member to take this class. We offer it to all dentists out there. We're pushing it. We've done our current president. He actually reduced fees to come to our meetings if you're a non-member, just to try to get people in so we can get them educated. So those are the things we're doing. And on that note, if you guys have any questions.
Thank you so much. Some great information and very encouraging to hear. I think the very intentional work to reduce just the number of drugs even prescribed and the different pathways that can, often I sit here and I think about it, and I know two of our members have said how you are living in recovery. I think, so when you have a patient like that, there are very serious considerations for what you might send them home with. And a lot of that comes from self-reporting when they talk to you. So I do appreciate the reduction that y'all are facing here. So do we have any comments or questions? We do from Chairman Cooper first.
Well, first of all, thank you very much. Dr. Pruitt, where do you practice?
Well, I'm just in the process of starting a new residency program in Athens, Georgia, at Athens Piedmont Regional. And we're basically the first time we've had a residence over there, a general practice residence, and we're trying to meet part of the need for the developmentally disabled kids here in Georgia. So we're doing OR cases on Fridays, but that's where I practice there. And then I go around the state and do surgery in Macon as well.
Okay, so you have a private practice too?
Yes, ma'am. I retired from the school. Now I'm private practice doing that as well as teaching it in Athens.
Well, I don't have any dental problems, but I think I'm going to keep your name. And if I do, I'm not real fond of dentists just because of the fact that I was a bad 12-year-old that wouldn't let them deaden them when they filled my teeth and stuff. And so I have lasting memories from that. What I want to, okay, so when you do these courses, because all right, is it the dental association that's doing the board of dentistry? It's a dental association?
It's the board of dentistry mandates that you cannot get licensed. So it's a nice thing to do because you have to make people do things. So the board of dentistry, to get your license every 2 years, you have to have at least that hour update in opioids.
And so is it and so they pay you to go around the state and set up these meetings?
No, the Georgia Board of Dentistry, they just mandate you do it. And then, of course, like the Georgia Dental Association, what they do is they charge members a minimal amount. And then usually, I know in my case, I just donate my lecture. I don't get paid for that. It's just what I do.
But you do it around the state in
Yes,
different
ma'am,
places.
around the state.
The reason I'm asking, I think that that I need to talk to the medical association and the medical board. It would help for us to do that because I don't think they do. They're required to take something online that we passed, but I don't think that they have the same kind of interaction and being able to talk to somebody that's made a difference in their practices, which would be I think a really positive thing. So that's why I was curious about how it was done on it. When you do that, I guess, I'm concerned about people of all ages becoming addicted, but I'm more concerned about kids because there is a big push. About 30% of the children that get opioids before the age of 18 become addicted. Any of them whatsoever. So if you haven't put that in your practice or looked up on it, could you
Oh, well, it's in there and the numbers.
push not to give them
Yeah,
anything?
well, and then the numbers that you've heard numerous times already, and that is what we discovered about wisdom teeth removal is over half the drugs that were being prescribed were not being utilized. So they end up in somebody's drug cabinet, and then that's the first gateway.
Right.
And so, by doing other things, and something I didn't elaborate on is, one of the doctors mentioned PRP. Well, I utilize what we call PRP and PRF. So we use platelet-rich fiber and platelet-rich plasma where we draw blood out on the patient. If I'm doing a big surgery, I draw your blood out, I spin it down in a centrifuge, and then I put it back in the area of the surgery. And what that does, it releases growth factors in the area locally. And so you reduce the inflammatory process, you reduce bleeding, you reduce pain. And I mean, I've had patients I've done study on when I was at the university, we do a surgery one day in the usual fashion. The next time we do it with the PRP. And they're like, oh gosh, I only want to have that used on me next time. So those are things that we're also doing there. And I guess the one thing I did forget, because I'm forgetful that way, is some really cool stuff that some of my colleagues at the university are doing. I had Dr. Elawadi, who is a periodontist, very talented gentleman that I work with down at the university. He is actually looking at genetic, evaluating patients genetically. So what he does is when he does a periodontal surgery, he brings you in. He actually takes a little swab and all, so he's going to find out the gene, look at your genes or whatever that are targeted just for these areas. And what he does is he treats you normally that day for whatever the surgery is, does half that surgery. Then he brings you back the next time. When he does the surgery next time, he's using his genetic markers he discovered. Things he's discovered is some patients where we're going to sedate you with a benzodiazepine Versed, that the usual dose would be 8 milligrams. He's finding this patient only needs 2 milligrams. And genetically, we're finding how predisposed they are to this. We're also finding things, though, on the other hand, that patients that you normally would see with ibuprofen would be very effective, that you can't give them as much because they're going to be a little more, it's going to be toxic to them if you give them X amount of medication. Now, this is really early in the studies, but he shared with me some of this stuff earlier. And I mean, it was so fascinating that I see one day us walk into the office, and just like we give your debit card, you'll just touch something, we'll get a little DNA sample, and next thing you know, we'll be able to tailor all your treatment to that. Sounds far-fetched, but so did the smartphone 15 years ago. So,
Well, thank you very much. And I'm certainly glad you're with our residents and still teaching. Thank you for your service.
Hey, we're going to join one of your friends right now on Zoom, and then we do have at least one
Okay.
more question in the room when we come back. So, Dr. Hawkins,
Can you hear me?
we can. Good morning for a minute.
It was really glad to hear you talk about Marcaine and hemostatic control. That does quite a bit for pain control. I'll tell you what an old guy used to do, and that I would give him Advil and Tylenol along with diphenylhydramine, which is Benadryl, and they would get a little sedation effect from the Benadryl, and we got as much pain control from the Advil. Or back then it was Motrin, and it was prescription, but now Advil. So I think dentistry has been very aware of the problem of opioid addictions, and I think we've been moving in a really good direction for the last 20 to 30 years. But I just say to you, Mike, I appreciate all you've done and all the services that you provided the patients around Georgia. Thank you.
Thank you.
Thank
Thank
you. Thank
you.
you, Lee.
Okay. And now, Mr. Breedlove.
Thank you, Chairman. Could you be my dentist? No, well, or even maybe Chairman Hawkins could be I need a new dentist. So after this, I need a new dentist. That's a joke, but what's not a joke is, one thing I learned from your presentation, and I thank you for all of it, is, I mean, and I'm serious when I say this, I mean, obviously we all know about how sometimes it's discomfort when you go to even for a checkup
Mhm.
or cleaning, much less if you do something more advanced. But I don't think in the 8 years I've been in recovery, and I guess I've been to a lot of meetings all over the country, talking to peers that sort of get into this, we don't really focus on the dental side of it. I've talked to my primary care physician at length about it. So I want to thank you just for nothing else, although it was more than this, for educating me that our community needs to build better relationships with the association and dentists like you that care, because we need more education to know what to ask when we go to see a dentist, to know what non-opioid options there even are. And I'll end with this, because as awesome as you are to care the way you do, not every dentist is going to donate their time and focus that way. So sometimes the least among us with the least amount of money, the least amount of resources, don't have the education that they need. So thank you for exposing me to this. And I definitely hope our community can work with your community.
Our privilege and pleasure.
Okay, are there any other comments or questions? Well, I have one, just a minute. Thank you so much. You're certainly doing a lot of work that matters. While I've got you here, though, I've got to ask you a question, because another place where I work is with special needs and developmentally
Yes, ma'am.
disabled. So if you have just a minute to tell us a little bit about the work you're doing there, because it is so vital, I know.
So prior to retiring at the dental college, we were very just influential. We go to the OR every month, take X number of kids and adults that are affected by this. And then what we do is also we did a lot of IV sedation in our clinic there. We find that with the sedation, the nice thing about taking someone to the operating room is, yes, it's a wonderful environment in the sense that it's well controlled. However, to get a lot of work done there, you have to limit your services just because the OR is not as easy to work there as you can in your private office. So by us doing conscious sedation that we were doing at the university, we were treating tons of patients. I bet we saw 4 or 5 patients. It was 4 to 5 patients, I'd say, a day. I mean, we had 16 residents there for a while. So we would see that many of them in a day. In fact, I had a variety of studies going on. When I finished up, the last study I was working with was the Department of Defense and our ER physicians. We were working, of all things, we were actually putting strips on the patients, and we'd sedate them as we gave them the fentanyl. We would check to see if we could detect opioids in their bloodstream, because we were going to check to see if we could rule out opioids as a weapon of mass destruction. So it was kind of something we as dentists were doing with our colleagues in medicine. But the gist of it is, so what I've done is, after retiring, now in Athens, our focus has been, we want to teach these young doctors how to be better dentists, which is we're hope to do, but we're also wanting to be able to teach them how to provide these services. And so we're going to the operating room every Friday. We take minimally 2, usually 3 to 4 patients with us, and we take care of all their dental needs. Usually it's a soup to nuts. In other words, a lot of times they're not very cooperative, so we have to do the x-rays there once they're asleep, fabricate our treatment plan, do our treatment plan, and go from there. But Dr. Brad Hall, who is he's my colleague, and honestly, he's more boots on the ground in Athens than I am. He is phenomenal. And then Dr. Tom McDonald over there. But the 3 of us are the ones running the program, and we've been very blessed to have the support of the Georgia Dental Association, and our colleagues at Hinman Dental and everyone else has been really supportive of us, and we're growing right now. So we're excited. So it's a good time.
Thank you. If there's anything we can do to help you do that, please don't hesitate to have another conversation at another time.
Sounds good. Thank you.
Chairman Cooper has another.
Okay, I think I saw a picture of it. Are y'all still doing, the Dental Association still doing the great big?
The GMOM event? Well,
when you go to like a great.
we haven't done a big one. What we started doing was the smaller versions, and we call them the Rams. And so they do these smaller versions in rural communities. So it's a rural
Okay.
outreach. And what we found is actually that was probably as effective, certainly trying to do more of those. As an association, we've been very blessed because most dentists that are involved in this thing, they with the service, they don't mind giving the services up. And then the other kind of good thing is for our younger dentists or want to be dentists, they have to, part of their getting into school now, they have to have so much time chairside watching a dentist work, have to, have this experience. So a lot of them also participate and they'll be assisting us in these events and those kind of things. So it works out real well. So that's what we're doing now.
I mean, I got to go to one up in Cartersville, and I mean, it was amazing. I mean, people who couldn't afford to have their teeth taken care of, everything from extracting teeth to, I think did they do fillings? I can't,
They
but
did,
it was
they did.
quite a production. And so I really appreciated the fact that y'all still do that for people who otherwise would, be going to the OR, to the emergency room to have extractions, because that is one of the things I think still maybe the second reason, especially for kids, that they go to the ER
Yeah.
is for the toothache. And it's so important about when, not to take out teeth where it's going to keep their prominent ones coming in crazy when they're taken out and this kind of thing. So I really appreciate the dental association doing that. And I miss the fish fry up in Cartersville. I don't know why y'all stopped that.
Yeah.
That was bad.
Okay. Thank you so much.
We're not through yet. We're not through. Just a minute. One for from Mr. Breedlove.
Okay.
Did you use the acronym was RAM?
Yeah. And that's the rule. What does it stand for? They call it the RAM.
But that's the right acronym,
Yeah,
RAM.
it's the right acronym.
We can, okay.
Yeah. Yeah. We call
Right.
it a mini mom, but for some
I
reason.
just wanted to make sure I had
Yeah.
that right.
Yeah.
I'll follow up with the question
Yeah.
later.
Okay. Thank you so much.
Great. Yeah, those are pretty sweet to see. Dr. Pruitt, thank you so much. And Miss Adams, we look forward to working with you. Welcome to the Capitol. Yeah, good. All right, we are going to pause now and have a lunch break. I want you to know that everyone who has or is presenting is certainly so welcome to join us. And we're going to be just right across the hall in 605. And our lunch is Julie Wyndham is in the room, the Georgia Association of Community Hospital. So I got it right, or Atrium Health. Oh, great. That's really good. That's hometown. Julie was going to be a big sponsor for us in Rome, and the hospital was as well. So we thank you for coming back and helping us do that. So thank you all so much. Everyone, please join us for lunch. We will, it'll be about 45 minutes or so, and we'll come back and get started with another interesting afternoon. Jeff Breedlove has something else to say here.
Chairman, before you adjourn for lunch, may I apologize to the chair publicly? I have to go, or I get to go. It's a great privilege to go with Senator Goodman tonight in Valdosta for a fentanyl event with the family with the Davis family that passed Austin's law. And to get to Valdosta tonight, I'll be monitoring in the car, but I want to publicly just acknowledge that the reason I don't come back isn't to be rude, but pre-existing event, and I wanted to ask your indulgence to be excused.
Most definitely. And of course, we'll meet again tomorrow. So thank you. Thank you so much. All right, we'll break. Okay. Well, I'll be late. Thank you again to Julie Wyndham and Atrium Floyd for lunch, taking care of all of us that are here working today. So we can get back on track here. So next up, we are going to hear from Dr. Mark Ellis and Dr. Winston Carhey from the Association of Chiropractors. And if y'all would rather be right there at the table, that is fine, wherever you're most comfortable. Do y'all have a presentation? Oh, here, yeah, it is. Here it is, right here.
Do you want someone up there to move it for you, or do you want us to drive it?
He has tablet.
I have a slide projector. Would you want me to plug it into the computer and control it from here?
Hang on just a minute. We'll get this worked out. Wait, let me go.
So I'll just say forward and you'll forward, or is it? Okay.
Okay, whenever y'all are ready, we are. Thank you.
Thank you.
Mhm.
Madam Chair, members of the committee, I'm Aubrey Valines. I'm the General Counsel for the Georgia Chiropractic Association. I have here today Dr. Mark Ellis from Cobb County and Dr. Winston Carhey from Fulton County. We want to first thank the committee for the hard work they've been doing throughout the year and traveling around the state, and we appreciate the opportunity to testify in front of you today. With that, I'll turn it over to Dr. Ellis.
Thank you so much. The thing that we would like to share with y'all today is that chiropractic is a non-pharmacological alternative to opioids. So as chiropractors, we are a primary portal of entry for patients in the state of Georgia. We have a licensure to diagnose, particularly in a focus to neuromuscular skeletal conditions, but we also are trained in diagnosis of cardiovascular conditions, respiratory conditions, neurological conditions like brain tumors and things of that nature. So what that allows us to do is while we're working on a person maybe related to pain, we can identify other comorbidities that could be associated, and we're able to get an early intervention and refer to our allied medical providers to ensure that we're co-managing these patients and keeping them safe. Our chiropractic education, we have to go through an undergraduate training to get into school, and then we go through 3 to 5 years of chiropractic training and a 2-year internship. Our education covers approximately 4,200 or a minimum of 4,200 credit hours. And we have courses related to physiology, biochemistry, nutrition, pharmacotoxicology, pathology, microbiology, as well as diagnostic imaging. As we understand the problem that we're facing today in Georgia and amongst the country, is that we have over 50 million people who are suffering from chronic pain. And unfortunately, some of those people are not utilizing the prescribed medications appropriately, and they're going through different addictions and things of this nature. As non-drug therapies that we provide as chiropractic, we're able to have options that not only address the pain, but also reduce the risks of dependency, other side effects, and reduce the risk of other long-term health complications that arise. So when we look at the cost of chronic pain in America, it's greater than the costs related to heart disease, cancer, diabetes. Some estimates are that those costs reach as much as $600 billion a year. There's evidence that suggests that long-term spinal manipulation has been shown to decrease these costs, which is a benefit to our healthcare system in America and to the patients that we serve. The CDC developed clinical practice guidelines for prescribing opioid pain, and it has a few steps in it. But the first step is to determine whether or not opioids are appropriate and if they want to do this treatment. Now, when you look at evidence-based medicine, we have what's the research that's showing the evidence, but we also have the clinical decision-making of the doctor and the desires of the patient. And the three of these things should be brought together to help advise the patient on what direction they want to go in their course of care. So if doctors have clarity about the role of chiropractic in pain care management, then what they can do is they can educate the patients about the pros and cons of chiropractic, and then that will empower the patient with the information that they need to participate in their own healthcare and make the decision that they need to make at this first level. And then we can have co-management with the patients and the doctors if they need to progress through some of the other levels. The CDC did a clinical practice guideline, and what they stated was that there are non-pharmacological opioid options and there are non-medication options. So you've already had a lot of people talking here about the non-opioid pharmacological interventions. So we're not going to address that. I think you guys have really had some great experts here, but we want to focus on the non-pharmacological interventions. And they put forth a list of some different options, and those include things like spinal manipulation, myofascial therapies, low-level laser therapies, and different forms of exercise and movement therapies. So one of the things that might happen in a chiropractic office is a patient might come in, let's say they come in for low back pain, and they can come in, and the first thing we might do is to provide a low-level laser therapy, and just to try to start to lower their pain responses. Then we may provide a myofascial treatment. Then they can see the doctor of chiropractic for the spinal manipulative therapies. And then afterward, we can do different exercise therapies like core stability and strengthening in order to assure that the person's in the best possible position to recover from the pain syndrome that they're suffering. So it's really a pretty sophisticated intervention that we do. And we have multiple non-invasive interventions that are available to us within our licensure here in Georgia. And it's been shown by the Agency for Healthcare Research and Quality in a systemic review that multiple non-invasive, non-pharmacological interventions help with chronic pain. So I know that a lot of people here are familiar with systemic review, what a systematic review is, but maybe for some people who watch online or something who are not familiar with that, a systematic review is a very high level of validity in research. So the lowest level would be just a case study. Then you have double-blind placebo control studies. And then a systematic review is where they go through all of the evidence that's available. They analyze potentially hundreds of different research studies, and they critique those studies for their validity and accuracy of the study. And then they make a opinion about all the different research on a specific topic. So this is a systematic review, and it shows that there's evidence that multiple non-invasive, non-pharmacological interventions improve chronic pain and function, and they're not associated with serious harm. So when we look at medication interventions, it seems that the medications are helping the people with their pain while they're suffering the pain. But when they come off of the medication, the long-term effect of that is less. And they oftentimes have unwanted consequences to that medication. Like they might have nausea, digestive issues, immunological problems, cardiovascular problems, and even depression. And the list really is pretty extensive. But if you're using multiple non-invasive, non-pharmacological interventions, then you have a better probability of improving their pain, but that improvement is maintained and it's sustained. And so as doctors of chiropractic, we have that access and option to use these multiple forms of intervention. The American College of Physicians recommends non-pharmacological treatments with superficial heat, massage, and spinal manipulation as the cornerstone of treatment for back pain. So they're recommending that we co-manage patients and work together in this area. So one of the things that happens for us is that we do very well working together with our medical counterparts, and it's extremely important for the well-being of the patient. So let me tell you a little bit about one of the patients that came to me. So she had pain that was an 8 out of 10. She came into my office in about 2018. And what was happening to her was she had these cysts where it was skin that was shedding inside of her brain. So normally, if the skin sheds on the outside of your body, it's okay, it just falls off. But unfortunately, with this type of a tumor, you get an epidermoid tumor in your brain, and the cells in your brain shed inside of your brain. And so that's the condition that she has. And she had neurosurgery for that saved her life. But she was left with pain, and she was left with difficulty walking, difficulty talking, double vision, things of this nature. She came to me for the pain, and we were able to reduce her pain and get her better. But because we also do these different exercises that help with gait and strength and movement, she appreciated that service, and she stayed as a patient of mine for a while. She was also under medical supervision from a neurologist. But as expected, these cysts regrew, which was anticipated. But fortunately, because we were able to screen her and we knew how her system was, I noticed that her gait was beginning to get a little bit worse and that her speech was getting a little bit worse. So we ordered an MRI, and she had this increase in her tumors. We very quickly got her back to her neurologist with a report, and the neurologist decided that it was time for her to have an additional round of surgery. She needed one on this side of her brain and then one down in her brainstem. And fortunately, we got to help her very quickly. She returned for care, and we continue to treat her to this day. And her quality of life is greatly increased because of the co-management between the chiropractor and the medical professionals. Chiropractors very frequently we spend a lot of time with our patients, so we can treat a person for years and maybe see them a few times a year or even more if necessary. So we have that ability. Another one of the patients that I was seeing was coming into me for low back pain, and he had a vascular insufficiency in his legs. And one day when he entered the office, I just saw he was very pale. He didn't look good. I was concerned about him. So I grabbed my stethoscope, and I heard a problem with his heart. I made the referral to the emergency room. He refused the ambulance, but we were able to get him to his cardiologist that day. And he was diagnosed with a supraventricular tachycardia. He underwent a surgery for that. And I think that it was a very good life-saving intervention for him. And then he was able to return for the further care that we were offering to him. So being able to have the diagnostic skill sets as primary providers, it allows us to have early screenings for patients and not just help them with pain, but to also be able to intervene and get them care that they need for other comorbidities that they might come across in their lives. So the VA did a study and looked at 14,000 military veterans who were undergoing chiropractic care. And approximately a third of them were also utilizing opioids for their treatment of their pain. And what the VA found was that the frequency of opioid prescription was lower if they were undergoing chiropractic care. Now, interestingly enough, these people to get into this study only had to get one chiropractic visit. So with just the one chiropractic visit, they saw that the frequency of opioid prescriptions was lower amongst our veterans. And their recommendation was that the co-management between medical doctors and chiropractors helped these people to be able to not need as many opioids, which I think is really quite exciting, important, and something that hopefully society gets better and better awareness of. Another study that was from the Journal of Alternative and Complementary Medicine showed a similar finding. So what they did was they evaluated the association between the utilization of chiropractic services and low back pain with opioids. And they found that the likelihood of filling a prescription for an opioid analgesic was 55% lower for recipients of services delivered by chiropractors compared with the people who did not receive that service. A couple of other studies that we just decided to highlight. One was a long-term study from Medicare costs associated with opioid analgesics versus spinal manipulative therapy for chronic low back pain. And what they found was that if you had chronic low back pain and you were doing opioid analgesic therapy, you incurred lower long-term costs for the low back pain, but you incurred higher long-term healthcare costs for the other things that occurred due to their situation. Whereas patients who had long-term spinal manipulative therapies, they had lower long-term costs for their care overall. Another group that looked at these things was a chiropractic manipulative therapy journal, and they looked at the cost of chiropractic versus medical management for adults with spine-related musculoskeletal pain. And it was a systematic review. And what they found was that patients with spine-related musculoskeletal pain who consulted a chiropractor in their initial visit, so starting off, they saw the chiropractor first, which is something that the CDC is recommending people do, that they had decreased downstream healthcare services associated with the cost of this pain syndrome. So these are some of the things that that we're looking at and we're finding. And Dr. Karhi is just going to finish the last few slides for you, and then we'll be available for any questions that you might have. Dr. Karhi?
Thank you. Yes, as we know, we want to make sure we have better outcomes with all our treatment. And chiropractic care has been shown to have better patient satisfaction. About 84% of the patients are reporting that they are very satisfied with chiropractic care. Not only that, the studies have been shown that the outcome, talking about quality of life outcomes, as done by this study, that is upwards to 60%, 58% have better outcomes with the chiropractic care. So it's definitely something that people appreciate, and they have better quality of life with chiropractic care. So we have another study here also showing you that acute low back pain and neck pain in these patients, opioids should not be recommended for acute nonspecific lower back pain. And this is very important. This comes from Lancet, which is a very highly reputable journal that is in Britain. As we stated before, and other your speakers showed that the use of opioids are very lower outside of the US, but here in the US is higher, because this is a journal that is high in quality, and it's telling you that you should not prescribe opioids if it's nonspecific lower back pain. So the question is, why then do we have this problem here in the US? Maybe we should look at changing some things. And we have some suggestions here. We can help you with non-pharmacological alternative opioids. The services that are provided by the chiropractors are considered to be the cornerstone of care in pain management. And these services are all non-pharmacological interventions. Chiropractors are primary care providers who are licensed to diagnose and treat neuromusculoskeletal conditions. The chiropractors also work intimately with other healthcare providers. And chiropractic physical examinations help screen for life-threatening disorders like heart disease, cancer, and diabetes. And we also refer to the appropriate physician for early medical diagnosis and intervention. So we are saying that chiropractic should be the cornerstone of any non-pharmacological therapy because we are primary port of entry providers and we can better serve the public in this effect. So we understand and we know that the downstream cost of opioid use disorder is real, right? So we understand there's a circle of concern and a circle of influence, right? But you guys have been blessed to influence the use of non-pharmacological therapies in the state of Georgia. Everyone has taken the oath to help protect and serve the public. So we're asking that you utilize chiropractic care as the first line of defense in the non-pharmacological therapies for the residents here in Georgia. And we thank you for your attention. Questions?
Thank you. Very good. Good information too. Thank you for bringing this for us to look over and consider as we move forward. We have first question here from Chairman Cooper.
Okay, first let me say that I do go to a chiropractor when I have minor problems from carrying too many books around or, my back gets out. However, as far as being the first line of defense, I know that you may have preliminary education in heart disease and so forth, but you do not have the depth that a physician has to be a primary provider. And so when you talk about being the first person to diagnose, I have a little trouble with that. It seems like to me that a family person or physician would be the first person to rule out any kind of a tumor or something that would be causing the skeleton pain. So that's my thing as far as calling yourself that you should be the cornerstone of the primary thing. I mean, I think that that we have primary physicians and all that, not that you don't have a place. Because like I say, I go to the chiropractor. I'd be glad to go to my colleague who I serve with if she wanted to do something to me. But I think when you talk about working with team members, I deal with the orthopedists a lot, okay? I don't hear this relationship. I don't hear the referrals back with people if their blood pressure's up or that kind of thing. So my first question would be, what are you doing to facilitate that teamwork?
Oh, I'm sorry.
Were you through, Madam Chair?
Well, I'm through with that question, sure.
Oh, I really appreciate that perspective. And I think it's so important because that's one of the things that we're really here to talk about. So in terms of us being considered primary care portals of entry, that is just what our licensure says. We have a primary care portal of entry. We're doctors of chiropractic. We have a specialty in the diagnosis of neuromuscular skeletal conditions. For sure, I agree with you, not of cardiac conditions, but we are trained in listening to the heart. We are trained in running blood tests. We are trained in various laboratory tests and advanced diagnostic imaging. So what happens is that a lot of people don't realize that we work very closely with other medical providers. And I think that more medical providers should realize that we're available as a non-pharmacological intervention. When we talk about us being the cornerstone for treatment for acute low back pain, that was a quote from the American College of Physicians. That wasn't us. That was after their systematic review. That's what they said. So I think that it's really important that we can educate the doctors in the world and in this country, as well as the patients of the services that are available that the CDC recommends that is within our licensure to help patients.
Well, and I understand that, but my question was, what are you doing? What is your society doing to facilitate that that interaction between the orthopedic and the other doctors? I mean, it's just not, I mean, if that's how you see yourself, I think and you don't think that's happening, I would think that that would behoove you to somehow or other work with the medical society or do something and not just sit and think they're going to reach out to you.
If I could respond to that, Madam Chair. A few years ago, you passed a law to allow us to incorporate with medical doctors, the MDDC, and it's worked well. We have many what we call joint practices these days. We actually have functions every month with medical doctors and chiropractors meeting, and we'd like to see more of that. The reality is medical doctors and chiropractors generally get along great, except under the gold dome. And I understand that. We have different issues, but out in the real world, my best friend, as close as a brother, is my medical doctor, and I talk to him daily. And we work well together. I wish we could work a little bit better. I understand about the referral question, but I think we changed that a few years ago, and we even put it in our rules that it's unprofessional conduct for a chiropractor not to refer to a physician on a medical condition. So they could lose their license for it. So we've taken the steps,
Okay.
and we've taken
Well,
the
I'm
steps. We even put it in a rule. And okay, yes, ma'am.
I mean, I think especially in Georgia, we have a little problem, and you both may be graduates of Life University, and it's changed. But for a long time, Life taught that you could cure anything. I mean, I live in Cobb County. I know what they taught and what they did. And it caused a real problem in the medical community.
I would agree.
Thank you very
I would
much.
agree.
There's a lot of distrust because of that. And there were cases of people having major problems because referrals were not made. And the chiropractor said, oh no, just take these vitamins or just do this and we can cure colds. And, and then it developed. So it's still a lingering problem. And that's why I asked what your society was doing to, if you want to work like this. And like I say, I go to a chiropractor when my back hurts, but
It is a lingering.
If you want that kind of thing, I think there's a lot of work to be done still.
I got it.
Fair assessment. It's a lingering perception, and we've worked on that perception. That perception has passed, and in at least the person, and we're still working on the perception of the public daily. But some of the things we've done is we've come down to you and asked you to pass the MDDC, which you did. We've incorporated, you have to refer, it's unprofessional conduct. We have these meetings monthly between medical doctors and chiropractors, and we have lots of joint practices. I set them up by corporations, and we have lots of that. And so we're hoping we're moving in the right direction, and thank you.
Well, but you're usually in practice with an orthopedist. And that's not, when you talk about heart disease and forth, that is not the people that really need to have, more knowledge and more thing of a working relationship and still have the problem that's not going to be, and it may be in your rules, but the problem is it depends on the chiropractor to follow those rules and until there's a terrible situation, somebody gets reported, but it's just a problem. And I think it may be a perception. Life has tried to change. And the person who is dead, who ran that school and did it, but it turned out thousands of chiropractors, many of them staying in Georgia, who came out with that belief, which I think has probably set your society behind.
Yeah, madam.
In its current.
Yes, we are the Georgia Chiropractic Association, and we don't speak for any other institution except for the Georgia Chiropractic Association. But we represent all the chiropractors in the state of Georgia. And what we are doing is we are educating, and that's what we do. We educate, have educational seminars. We're also a part of the Clinical Compass. This organization sets the guidelines for the chiropractic profession nationwide. So we're working with them to have more evidence-based educational series to educate our chiropractors in the state of Georgia. So that is happening in our association. And we are willing and we are ready to help educate the other doctors because we know they are busy, as you mentioned before. Some doctors are old school doctors. They have old ways of thinking, and they don't know that we are thinking about the present and the future. They don't know how we can help the public, which is our main concern, is helping the citizens of Georgia. And how we can do that is looking towards the future, how we can better serve them. And we can better serve them by co-managing the patient and making sure we're doing the best thing for the patient as based on the current level of evidence. And that's all we're doing is what's working, what's real, what's in the evidence, how can we make that in our practice? And that's what we want to work with you to help us educate our chiropractors, educate the other medical physicians in the state of Georgia as to how to treat the people that we serve.
Well, I don't think it's the legislature's job to do that education.
Yes,
No, don't put it on us.
We won't. No, all we want is
And I
access.
think that the attitude of when you go that you are the primary physician is not the way to go to a primary MD.
Can I clarify that if I may? We are the primary portal of entry for neuromusculoskeletal disorders. That's it. That's our lane. We're going to stay in it and we're going to work with them and refer.
But when you start off about we are trained in doing cardiovascular and that kind of thing, it gets off on the wrong.
I'm
foot.
sorry. I'm sorry.
So, I mean, like I said, I go to a chiropractor. I love my chiropractor.
We thank you.
And so, but I also know that if he tried to treat my cold, I'd say, hey, I'll go to my MD just before you try to treat my cold. So, I mean, it's just a problem. I mean, I'm just telling you the truth. As Audrey will tell you, I say it like it is and tell the truth about what the reality is. And I've been down here a long time and I don't see that working together, Audrey. Maybe okay with the orthopedist, but I don't see it when you start talking about the other and the referrals. And that's what concerns me. And I think that's what concerns the medical doctors.
Okay. We're hopeful and we look towards the future, but thank you.
Thank you, Madam Chair.
It's true.
So thank you for your presentation. I was just curious for my own understanding, are the majority of chiropractic services covered by systems like Medicaid and Medicare? And for modalities such as massage and the use of heat, is there resources there for those of low socioeconomic status?
We are not in the Medicaid system. We are in Medicare. Medicare pays only for our adjustments, not for x-rays or other modalities.
Thank you.
Chief Persley.
Thank you, Madam Chair. Gentlemen, good afternoon. I want to say one of you made a comment about, I guess this is not a widespread process in Georgia. What I mean by that is, chiropractors in Southwest Georgia, are they in tune to what, you're talking about today? All right. Well, how do you, and I'll go back to the education piece again, reaching to the more rural parts, and the doctor who I talked about earlier, what if that's someone who, I'm getting my hands on some medication just to take care of people, but how does the chiropractor association, how do you get that message out to make sure that more doctors are doing what you're talking about today? Because sometimes it may be easier for them just to, here's a prescription, but now you're talking about, and this could potentially be long-term care that you're talking about, correct? Yeah. How are you making that happen?
If I could take a stab at that, continuing ed is one of the best ways. We have 20 hours a year.
Okay.
You mentioned Southwest Georgia, Dr. Davis Kinney down there, longtime active member of the profession with a joint practice there, one of the larger practices with the medical doctors. And one thing we can do, we'll go to districts, we'll go across the state, and we'll send out the message. And one thing I do, I have to lecture constantly on jurisprudence. They have to have an hour a year on that. And one of the things I stress is you have to refer. You have to refer. And if you don't refer, not only can you lose your license, but you're going to be found guilty of malpractice. If it's not a chiropractic case, it should be out that door to that medical doctor immediately. And as Chairman Cooper mentioned a little bit ago, one of the things that happens is we get people in there that shouldn't be chiropractic cases, and we try to send them back out the door. We are the primary care in that case. They come to us and they say, no, you don't need to be here. You need to go somewhere else. And the only thing we can do is try to educate our doctors. And we have mandatory CE. We constantly have meetings throughout the month with the chiropractors across the state. You know, our president now is from Savannah. It can vary, you know, officers all around the state.
So one other question to go with that. What is the community engagement part of getting that message out to plain folks like myself? You know, I'm a police officer. I get injured. I fall and hurt my knee, you know, or something twist. But how do you get that message of what you're talking about? Because I can't afford to get on any kind of medication that may potentially hinder me from my job.
And can I just want to make sure, chiropractors don't prescribe medications. So we have 0 prescriptive rights.
Okay.
Yeah, we are completely non-pharmacological in our approaches and
Okay.
multi-dimensional with a variety of different treatments. So we don't,
that right either.
yeah,
I mean, we do not want the right.
Okay.
yeah. So we don't ever prescribe a medication. If we think somebody needs a medication, then we refer them to someone with prescriptive rights, and then we can co-manage that.
And so that's okay. So the co-management piece. So
Yeah.
and would it be best if, as long as we have a personal physician, we also have a personal chiropractor?
Well, we love that idea.
I'm sure you would.
Yeah, absolutely. So that's great. I mean, and that's very important. And it helps us too, because then we can say, hey, you know, if you could just have your doctor take a look at this, and we have these early screening skill sets from our education, so we can make that referral and say, could you just have your doctor look at this? And then we might write a note, let the doctor take care of it from there.
Last question, Madam Chairwoman. All right. So one of the things, and I know in the realm of recovery, that, you know, there are other things that you can do, and that is a long-term fight. However, how does being with your association, working with community service boards or Department of Behavioral Health, to where people who are in recovery, teaching, I can't say teaching, or providing or educating them on these needs.
Mhm.
So how does that work?
So if I hear you correctly, this may be people who may have opioid use disorder or some type of addiction.
Yeah. Mhm.
And then how can they utilize chiropractic care to help their recovery and get off of the medication or the need for it? That needs to be done by education. And hopefully, we are advertising enough and educating the public enough where there is going to be a push or a pull into our office. The other way we can do it, we can start working with the community organizations that are providing these services for these addicted people, and we can provide the chiropractic option to them. That may be a more effective way of doing it. And there are several different people who work with these types of associations that have very good results. So that's what I would employ, and they can contact the GCA if they want to find out more about how they can incorporate chiropractic care into their programs, which is a very good idea.
Okay. Thank you, ma'am.
Are there any other questions or comments from the committee? Not seeing any. Thank you so much.
Thank you, Madam
for
Chair,
giving
members
us
of the committee.
another thing to look at. I appreciate it so much.
Thanks so much.
Safe travels to each of you.
No.
We are also about to put a public comment sign-up sheet on the table right there. So if there's anyone here who is not on the agenda but wishes to speak to us at the end of the meeting, if you'd like to sign up, we'd love to hear from you. It will be sitting there for you. Okay, and next up, ready to go, it looks like will be Cindy Steinberg, the Director of Policy and Advocacy for the U.S. Pain Foundation. Cindy, make sure to tell us a little bit about yourself too when you get started there. Everyone also has this in their folder of information as well. From the U.S. Pain Foundation. Anyone who's watching or listening, just know we're loading up the presentation. It'll be just another minute.
Thank you so much. And sorry for the interruption there. We just had a download problem, but it looks like we're working fine now. So thank you.
Thank
First of all,
you.
I just want to thank the committee for looking into options for better treating pain because we know it's a huge problem. So let me give you a little bit about the U.S. Pain Foundation, and then I'll tell you about who I am and how I got to be doing this. So U.S. Pain Foundation is a patient organization. Our mission is really to educate and empower and connect and support people living with pain. And we have about 30,000, 35,000 members around the country. These are all people living with pretty severe chronic pain. And we do, in addition to our support groups, we have about 60 support groups are all online. We have educational programs. We do state and federal advocacy. We have a pediatric pain program for kids living with pain and their families, where we have all different programs for them. We have something called the Invisible Project, which, as you can see, has these magazines that feature all different types of pain, diabetic pain, autoimmune types pain, and give people education on pain. Whoops. Go back a minute. Okay, so as far as myself goes, I had a business career and I happened to be talking on the phone to a client and I went out to retrieve a file, and unbeknownst to me, moving men had stacked cubicle walls behind my file cabinet, great big lateral metal file cabinet. And I opened the drawer and all of a sudden the cabinet came at me and I turned to get away, but I wasn't quick enough and the drawer struck me in the middle of my back and then I was crushed underneath the cabinet and like 10 walls. And I had to be removed off of me. And as a result of that, I had severe back pain, pretty much damage across my thoracic back, my middle back. So I had nerve damage and I had ligament damage. And I worked for a number of years in horrible pain. Every time I'm upright, the pain increases because my back is not stable. And I have sort of a gnawing pain across the middle of my back. And then when I'm up longer, my muscles start to seize up and I get muscle spasms. And so what I did to learn to manage my pain was it took me at least 5 years to find help. They couldn't operate on my type of pain. And I tried many different, I went to many pain clinics. They gave me a lot of nerve blocks and injections. I tried all kinds of things, alternative types treatments, chiropractic and others, acupuncture, but it took me years to find help. And when I finally did, my doctor said, I will work with you, but you have chronic pain. There's no cure for this, and you need to learn to manage it. And so he worked with me to find things to help me. And so one of them is physical therapy. I have a land and a water-based program. I take something called amitriptyline, which is a medication. A lot of pain medications now are used off-label, other medications that were used for other things. And also, I limit the amount of time I'm upright. So I'm only upright for around an hour at a time, and then I lie down for 25 minutes, and I alternate like that. So I was a witness before the Senate when they did a hearing on managing pain during the opioid crisis. Because when I had my injury, I hung up a sign at a local library saying, just thinking I couldn't be the only one living in pain like this. And people just started showing up. So the first month, a woman came in with spinal stenosis and degenerative disc disease, and a guy with thoracic outlet syndrome. And then the next month, they came back, and a guy that had chemotherapy-induced pain came. And the next month, a guy that had migraine headaches every day as a result of chemotherapy treatment that he had gotten. People with various types of musculoskeletal pain, people with, replacement surgeries that had developed into chronic pain because of nerve damages. And I realized, wow, this is a huge problem. There are a lot of people living with pain. And at that point, I had found a way to manage my own pain. And I had realized that, wow, I mean, this is a huge problem. Most people had gone to 4 or 5 doctors before they had found any help. And I got involved with state policy at that time, looking into, well, what's the reason for this? Why are so many people living with pain like this? And there weren't good solutions. And it turned out that doctors got very little education in pain. That was one of the things I first found out. Medical doctors in our country get about 11 hours, and we get the least number of hours of medical education on pain than any other developed country. Veterinarians get 87 hours, so I sometimes say your pet is getting better pain care than people are. So medical schools do very little education. Go on to the next slide. Also, research in pain, and I'm going to get into that a little bit more. At the time, had been very little research done on pain at the NIH, which manages and funds most of the basic research in this country. So we still don't understand the basic neurobiological mechanism of pain in the human body. I'm going to go on and talk about the different types of pain and what are ways to manage them. So I just wanted to define terms because people have talked about all different types of pain, but you can really look at pain in terms of how long it's lasted. So acute pain is typically pain that'll last about a week or so, short-term injuries. Subacute pain is pain that's lasting for up to about 3 months. So sometimes acute injuries can take longer to heal or take longer to resolve. Chronic pain is pain that's lasting longer than 90 days. In many cases, this can be pain that lasts for years, or in my case, my accident was more than 20 years ago, and I still have pain every single day. So a lot of people living with chronic pain have it for the rest of their lives because there really is no cure for chronic pain. Any of these pains can be, mild to severe, and high impact chronic pain is now defined as chronic pain that is generally severe and limits your daily activities and function, and it's often disabling. So pain is the number one reason for disability in this country. It is the number one reason for disability globally as well. So as I was saying, it is incredibly prevalent and huge, and that's some of the reason why we've had the problem with opioids, which I'll get into later. But we have a lot of people living with pain. So these are documented numbers that 80 million people experience acute pain per year in this country. And it's 70% of people going to emergency rooms are going there because of pain. Now, the CDC has done various types of statistics and analysis on the prevalence of chronic pain. And through the National Health Interview Survey, which is one of the most reliable surveys we have, it goes to about 37,000 people. We know that there are 50 million Americans living with chronic pain, and there are 17 million with high impact chronic pain, the kind of pain I talked about before that is really disabling. So right there in 1 year, we could be looking at 130 million people with pain, which is why the numbers of prescriptions have been a lot. If you take 4 pills a day and you're taking opioids, that's why we have a huge problem with pain. And that is what people don't realize. It's sort of like the hidden epidemic, right? There's 2 million people, as you heard before from the orthopedic surgeon, there's 2 million people with opioid use disorder. So in comparison, if there's 50 million people with pain, that's a lot of people living with pain. And I bet most of us know somebody that's either a relative or friend or somebody in your family that has some type of pain, whether it's arthritis or cancer or diabetes. Something like 40% of diabetes patients go on to develop diabetic neuropathy. So in 2010, the National Academy of Medicine, as you heard this number before, did an economic analysis and said that pain, direct and indirect costs, cost the economy $600 billion annually. So that is in productivity loss, in cost of disability, in cost of missed work, in direct healthcare costs, because as I said, people with pain go from doctor to doctor to doctor looking for help, because oftentimes doctors are not educated in how best to manage pain. And in Georgia alone, there is 1.64 million adults living with chronic pain and 575,000 living with high impact chronic pain. So 500,000 people in Georgia live with high impact chronic pain. So a lot of your constituents are living with pain. And high impact pain, as I talked about before, really destroys people's ability to have a quality of life. Oftentimes people can't work if it's the number one cause of disability. Sometimes people can't sleep with pain. It's hard to socialize. You become more and more isolated because, you're not predictable. You might have to cancel and you might not be able to go to a concert or go to socialize with your friends out to dinner. And people have, their lives get more and more isolated. The WHO defined chronic pain as a key risk factor for suicide, and the risk of suicide is twice the rate for people that are not living with pain. So, when the opioid crisis came along, and as you had learned, a lot of people doctors had managed pain, with opioids, not really understanding the best way to manage pain. And when the CDC said, we really want to, keep opioids below 90 MMEs and we want to get people off of opioids, a lot of doctors became very fearful and many people were forced off of opioids, tapered off, dropped from care. Oftentimes doctors now are fearful to treat patients with pain. And so we hear from a lot of patients with pain, chronic pain, who can't find care, who are unable to find care. So, as I talked about, most people see many doctors. Why is that, right? So I began to say before that very little time is spent on educating doctors on the best way to treat pain. So 96% of medical schools don't require a course on pain. And I talked about the 11 hours being the average in this country. And the underinvestment in research for the number one reason why people go to their doctor is pain. NIH spent out of their $49 billion a year budget, less than 2% on pain research. So we still don't understand the neurobiological basis of pain in the human body. And there's a lack of specialized physicians. Less than 1% are specialized in pain management. So realize that most people with pain are seeing PCPs. PCPs are having to handle the great numbers of people living with pain. We also don't have, there's a lack of really effective treatment options. So there's not been a new pain therapeutic in more than a decade. And the Biotechnology Organization did an analysis last year, and they said the chances of getting a new pain drug approved were 0.7% from phase 1 of clinical evaluation to FDA approval, whereas the average for any disease is 6.5%. So pain has been very challenging without us understanding and putting research into the basic biological mechanism of pain and how to develop new drugs. So we've had over-the-counter drugs, and medication, which is generally for mild pain, and then opioids, generally really best reserved for severe pain. And you think about it, there's not a lot of options in between. So when the opioid crisis really peaked, I am somebody that does a lot of work in both state and federal policy, and so I was asked, by lawmakers on Capitol Hill, well, why don't we just use other medications? And what my answer was, great. Do you know what they are? What should we use instead for severe pain? We don't have a lot of options. We need to dramatically increase our research dollars in looking at pain as well as in better treatments for substance use disorder. And that was in 2018. Congress has now made a huge investment in pain research at the NIH. So since 2018, they've now we've more than doubled the amount of money going into pain research per year. So it is now $500 million is going into pain research per year. So we've now spent over $1 billion in pain research, and we're starting to see new targets for new medications in the pipeline. And I'm going to talk a little about that, but that investment has made a huge difference in understanding the basic biological mechanism of pain so we can attack it. The other thing Congress asked was, given where we are now, with not a lot of truly effective other medication options, what is the best way to manage pain? And as a result of that, the answer was that we need to appoint a panel of experts appointed by the HHS secretary, and this was back in 2018 during Alex Azar Trump was president then. Alex Azar was HHS secretary. And Congress asked them to appoint a panel of experts to say what's the best way to manage pain now. That was called the HHS Pain Management Best Practices Report. And this has really become the standard of care in pain management. I think it's really important for you to know about that report and some of the handouts I gave, and I'll send more to Morgan and give her also an electronic form of those so you can take a look at them. But basically, this panel was 29 experts. I was the only patient and patient advocate on the panel. Most of them were all physicians or researchers who are experts in pain. And our charge was really to identify best practices, gaps, and recommendations for pain. Our final report, which was issued in 2019, of which the handouts were excerpts from that report, was endorsed by 165 healthcare organizations. The AMA president came to our last meeting. AMA issued a press release backing the report. And these are some of the other organizations, the American College of Physicians, the American Academy of Pain Medicine, et cetera, who basically said that this report is what we really should be doing in pain. And so what did we say was the best way to manage pain? First of all, comprehensive. The doctors need to do an assessment, a diagnosis. They need to come up with a treatment plan, really communicate that plan, and coordinate with other healthcare providers. That it should be individualized because everybody's pain is different, even if you have the same condition, and in every aspect of it, in the selection of what treatments, in the optimal dosing, if you do use medication, and then that it needs to be multidisciplinary and integrative. And what we mean by multidisciplinary is really combining treatments from a range of treatment options. And one of the things we did in the report was we laid out all the categories of treatment options for pain. And within each of those categories, the report lays out all different treatments. So for example, medication, opioids are only one small part of medication now that we can use for pain because doctors use other things off-label. None of them are effective for everyone, but some of them help people. So for example, gabapentin is a medication that's an anticonvulsant. That's one of the things we looked at, Lyrica as well. They help people with fibromyalgia, and gabapentin helps people with nerve pain. That was a medication that was developed for epilepsy years ago, but now they use that off-label. There's other medications like antidepressants, which were used years ago, that are now used in small doses for pain. They realize it can help nerve pain. Again, it doesn't help everyone, but it does help some percentage of people. So for example, I take amitriptyline, which is no longer used for depression, but years ago it was. But in small doses, it actually is effective for the type of pain that I have. So using, and not everybody needs medication. There's restorative therapies. You've heard about that. So physical therapy, it's important for people with pain to get moving in different ways. It might be gentle exercise, but PT, OT is a restorative therapy, Tai Chi, yoga, gentle exercise programs. Interventional procedures, because some people are helped by nerve blocks or by injections. There are various types of medical devices that can be basically implanted. Some of them also are outside your body, but spinal cord stimulators, and they've developed very sophisticated spinal cord stimulators that block the pain, that work to sort of the gate theory of pain, whereas, if you have an injury and you rub it and you feel the rub rather than the pain underneath, that's kind of the way the spinal cord stimulator works. They basically distract your nervous system from experiencing the pain. Behavioral health approaches. So there are many psychological approaches, things like cognitive behavioral therapy, mindfulness meditation, acceptance and commitment therapy. There's a number of different psychology treatments for pain that help people not only cope with the pain, but also distract their mind from the pain. And then there's complementary and integrative treatments. So for some people, acupuncture, massage, yoga therapy can help as well. And the idea with these different treatments is not that one treatment is going to work totally and take people's pain away. But if you combine multiple treatments and each thing brings down your pain 10 or 15%, if you get a 50% reduction in your daily chronic pain, that's huge. It really can make the difference between being able to work part-time or not, for example. I've seen that a lot with people, being able to take care of your family or not. And so the idea, like I gave you the example of how I manage my pain. I limit the amount of time I'm up. Almost everybody with pain needs some type of pacing, some type of limitations. If it's migraine, a lot of times lights really affect people. Loud noises might affect people that are living with daily migraines. So the combination of limiting your activity and doing that kind of pacing, and then, for example, for me, doing this exercise program, I have a water-based program and a land-based program, and taking this other medication that is very specific, like my amitriptyline for the nerve pain that I have. In combination with all that, I've reduced my amount of pain such that I can function. I can come here, I can talk, I still have to lie down, but I can still alter my position and function. It took me years to learn that, but that really is the best way to manage pain. And so using a combination of treatments, and everybody's treatments are different, as I said, that report lays out, it must be, 50 different treatments organized by those 5 categories, and combining those is really the best way to manage pain. Opioids do have a place, particularly for severe pain, but for all the issues and risks that they present, we don't want to use them as first line. We want to use them generally as a last resort and in combination with other things, so we can bring the amount of opioid down that people might need, but use these other treatments in combination with those. So this is an example of what we did in the report, an individualized treatment plan. This is a graphic from the report, shows that, there's patient A, B, C, and D, and you go to your physician, does a diagnostic evaluation, and has this toolkit. and really needs to understand that based on your type of pain, what would be the most likely things to try. And then, as you can see on the output on the other side, people have an individualized plan that combines whatever these treatments are from different modalities to really help manage their pain. And, you know, our group was, this panel of 21 experts was managed by a Stanford pain physician. She was excellent. She was brought in just to be the chief medical officer at HHS to manage this panel, to present this report. And from the years that I've been living with pain, more than 20 years, I started a support group. I still run that same group as a volunteer. 24 years later, more than 500 people with pain have come to my little support group that's in a suburb of Boston. And really, this is the best way to manage pain now. So if individualized multidisciplinary pain care, now widely considered best practice and preferably, you know, non-opioid, how do we get there? And the way that I spend most of my time is working with state lawmakers like you and federal policymakers to come up with ways to achieve this. So how do we get there? So at least 4 different possible things I can think of, which are educate patients, providers, and even lawmakers. And I heard one of you say earlier, isn't it important to educate our colleagues? I'm going to give you examples of how we do awareness days for lawmakers so they understand what the best way to manage pain is. And there's many other options besides opioids. We expand treatment choices for people because it needs to be individualized. And so you need to combine things from lots of different modalities. So we need to be able to expand the choice for people so they have options. Improve people's access and make those options easier for them to get. And then improve coordination of treatments, you know, to ensure that these things are integrated. Like I said, people need to combine those things so together they reduce your amount of pain. So I'm going to give you examples of bills that I have worked on at the state level and some that have passed that try to achieve this, and all different ideas for doing that. And I have a number of different legislative ideas for you. So one is require state health departments to produce and distribute educational materials on non-opioid multidisciplinary acute and chronic pain treatments based on that HHS report. And you know, you could have your state health department produce educational materials based on that report because it really is the best way to manage pain. You can require healthcare providers to provide copies of pain education materials to patients when they're treating acute or chronic pain. So both of those we've put in bills in several states. And I'm going to give you examples of some things we've been able to pass. You can require pharmacies when they're actually dispensing medication to provide pain education materials to people as they're picking up their medication so they understand there are many ways to manage pain. This isn't the only way, and you need to try some other things as well. You can require prescribing providers, as you heard before, to complete continuing education in non-opioid multidisciplinary pain treatments in order to renew their license. That is something that I did in where I am from in Massachusetts. We had a law that we worked on. It was a bill we worked on to require multidisciplinary pain education, continuing education units. And we got that passed in 2010. 3 hours. They have to do 3 hours of this training every 2 years. So that's something I can, you know, work with you on and show you the language that we used. Create a consultate. This is another sort of creative idea that I worked on with our lawmakers as well, which is we created a consultation service for PCPs in which the state pays for a team of pain management experts and substance use disorder experts to, for free, consult with PCPs instead of them dropping patients. And so we had a study commission to look into this idea, and everybody agreed that they thought that this was a good idea. And what was happening was we had heard from so many people that were being dropped from care, being force tapered off of their opioids. I mean, it had gotten so bad that I don't know if you realize this, but the FDA in April of 2019 issued a warning to doctors that this was caused, literally they used the words, suicide, extreme anxiety, increases in pain, withdrawal, because doctors had become so fearful they were dropping patients. And so what we decided to do was to encourage PCPs to keep their patients by having them be able to just for free consult with a team of pain management experts. And that is, it's called the MCSTAP program, MCSTAP. It's the Massachusetts Consultation Program for Addiction and Pain. So that's one thing that we did, which was sort of a creative legislative example. You can require public and private payers in Georgia to provide materials to healthcare providers and their beneficiaries explaining what non-opioid pain management modalities they currently cover. People have no idea what else they can do. We're not going back to opioids. Most doctors will not prescribe them anymore. There's, as you've heard, a 50% drop in people's prescribing. And that's the way we want them to be. But what else can you offer them? You can't say we're going to take away this medication and not offer other modalities when people are in severe pain. And so really, you could, as lawmakers, it wouldn't cost insurance companies anything to require them to write up what pain management options they have and provide that to their beneficiaries. So that's an easy one that you could easily implement. And this is what I was saying before. So we have held, U.S. Pain Foundation has held pain awareness days at state houses. And I'm going to show you some examples of a couple of things that we've done to really educate staffers, lawmakers, patients and providers speak. These are people trained in pain management. So I had a pain physician. I'll show you some of the examples. So we had a pain awareness day at a state house, and that was flyers that we put up everywhere. We had a bill to remove prior authorization from non-opioid pain management treatments, and we talked about that. And I had a nurse practitioner specializing in pain, a lawmaker. Her name is Representative Marjorie Decker, and she talked about her own pain and how she used acupuncture and yoga and Tai Chi to manage her pain. We had a patient come up and speak about the ways that they're getting their pain managed. And it was a great event. There is, the four of us who spoke. Up on the left-hand side there we are. We must have had like 50 staffers and lawmakers who came to hear these new ideas on how to manage pain, and educated them on why we need to vote for some of these things that are suggested. So I think it's really a good idea. I mean, pain is incredibly prevalent, and people really don't understand what to do to manage it. Now I'm going to give you some examples that expand treatment choice and improve access for people. So requiring payers to cover a wider range of non-opioid pain management options, and it could be done in a number of different ways. So one thing we've done, I got this passed in Maine and in Massachusetts so far. I have a bill in New York. I have a bill in New Hampshire. So there's lots of ways to require this idea of covering more options. One is by saying, letting the payers choose, okay? You need to cover 2 non-opioid medications, and you need to cover 3 non-pharmacological treatments. And the payers got to choose what they cover. So they need to let beneficiaries know what those things are, and they need to let providers know what those things are. Maybe they're PT, OT, and pain psychologists, cognitive behavioral therapy. Maybe it's acupuncture, chiropractic for musculoskeletal pain, and something else, so they get to choose, but that's kind of what we're requiring both public and private payers to do. And like I said, we just passed that bill in Maine, and we already passed that in Massachusetts in 2018. You could have them cover complementary treatments with evidence like acupuncture, chiropractic, or mindfulness meditation as options for people. So they're typically not covering those things now. But for example, Blue Cross Blue Shield chose acupuncture, and so they cover acupuncture for pain in Massachusetts now. Another thing that is very helpful, as I talked about, is movement, some type of exercise, some type of, perhaps it's a gentle exercise, but for most people with pain, being able to move is really important, and learning to, not be fearful of doing exercise, because it actually really does help people with pain. But oftentimes, as you know, pain is a chronic condition. And so getting 10 PT visits a year for something that you're going to have for 10, 15, 20 years is not really going to help you. What you really need is more longer term physical therapy. And so one of the things I think would be very helpful is requiring expanded coverage of something like physical therapy for people living with pain. Because that's really helpful to keeping them on their program, keeping them exercising. Maybe it's only one appointment a month, but do we want those people to fall back into not exercising, not having options, or using medication when they could be using an exercise program? No. So I think requiring them to cover some number of physical therapy visits is more important for a longer time. Also, as I talked about psychology, counseling people on how to live their life with pain is really important, because pain is so devastating to people's lives. Just coping with the, not able to work, not able to take care of your family, just being able to cope with that is really helpful. And so having more counseling or psychology visits for people living with pain, I think getting them to cover that would be really helpful. So by covering treatment modalities for, some number of treatments in addition to what they're already covering. Number 13, that language comes out of a bill in New Hampshire now that would require treatments within those categories that I talked about. And then utilization management. So, prior authorization on certain high-value, low-cost options. So things like acupuncture or PT or chiropractic, removing prior authorization from inexpensive treatments like that is really a great idea for treatment for pain. Because, again, wouldn't you rather people do a long-term exercise program and not, confront utilization management when they're saying, we won't pay for that physical therapy? It doesn't make sense when the cost of, if they had a problem with opioids, is much higher than that. Or they seem to cover surgery at the drop of a hat, but they don't want to cover another 10 PT visits. It doesn't make any sense, so those are, some ideas. And then improving coordination of treatment. So requiring payers to cover coordination of treatment, again, is another idea that's really helpful. If we want people to see a physical therapist and a psychologist in addition to their PCP, then we need to cover communication time for the physical therapist and the psychologist to coordinate on that treatment plan for that person. It would be much better to have them working together for that, to keep that person on that treatment plan in all these non-pharmacological treatments than it would be to incur the expense of having them, have a surgery that wasn't going to be great for them or having an opioid problem. Another approach is to use broader language in a bill and then more detailed requirements in regulation. And so, for example, some of the bills we've worked on say that the payer's quote shall provide coverage and access to a broad spectrum of pain management services in accordance with guidance. And then we work with the health department to come up with a specific guidance. And that's where I was saying they can cover, 2 non-opioid medications and 3 non-opioid pharmacological treatments. That was written in regulation. The language of the law was broader. So, it depends on how you want to approach it. You can keep the language of the legislative language broad and work with your health department to write guidance, or we can put more specific language in the law. And again, I have examples of various bills I've worked on. And then education, right? So I'm talking about now federal solutions. That's quite different than all the state examples that I gave. So at the federal level, what can we do about this multidisciplinary approach? So one, is we work with HHS to do some CEU webinars on the findings of the task force. We had great attendance. We had 2,400 people calling in because it was HHS. But, there's many more physicians than 2,400 that need this education. HHS did distribute some briefs on the task force, but really they didn't do a great job of disseminating the report. Unfortunately, the report was done right before the pandemic in 2019, so it didn't get as wide coverage as it should have gotten. But a couple of things that we did do was that Congress asked the task force to work with CMS. And so, for example, I gave a talk at CMS in the report and what could be done about it. And as a result of that, CMS did a couple of things. One is Medicare will cover acupuncture for chronic pain that's administered in a physician's office. It's not ideal because most acupuncturists don't really practice under physicians, but they will pay now under physician supervision, they will pay for acupuncture for Medicare for chronic pain. And then also, Medicare introduced new specialized codes. This was something we worked with them on. They're comprehensive codes for pain management. They're CPT codes. And what they will do is give physicians longer time with complex pain patients, because pain patients take longer time to work with, to develop a treatment plan like this, to come back and modify the treatment plan. And so CMS will pay for the first half hour, and that's, I think, longer than they typically give PCP. So the first half hour will be covered, and then they can add 15-minute increments to that, and they will cover that. They will cover also coordination time of the physician working with other people in working on the treatment plan, like I gave the example of. Those codes just went into effect a year ago, and so they're new. So I gave a talk at a conference for doctors and nurses, and I asked how many people knew about the codes, and hardly anybody knew about those new codes. CMS is not great about getting their information out. They put out these physician fee schedules that are 3,000 pages long. Like, who's going to go through those, right? But there really are these new codes, and hopefully they'll be getting better coverage with those codes, basically paying physicians for longer time. So that's really all I have to say, and I'm happy to take questions.
Thank you so much for sharing great information, but also your personal journey that brought you there as well to get there.
Sure.
So I know Mr. Breedlove is in the car. He was here earlier today. You heard him, and he is going to join us on Zoom. I think we may have to switch this out here just a minute to get to him. Mr. Breedlove, are you ready?
I am. Yes, ma'am, Chairman. Thank you.
Great.
Yeah, I just want to thank you for your wonderful and thoughtful presentation. It was very educational, and I thank you for the example of legislation in other legislation in other states. When I put my request in virtually ask the question, it was before you did that. So I'm really just going to make a comment now to say that I look forward to looking at these examples. Some of them seem very patient friendly, peer friendly, family friendly, and clinical friendly too. So let me just say thank you for that. I think you've given us some great things to look at. So thank you very much.
Oh, sure. I'm glad you found it helpful. Yeah, I mean, most other talks today covered like sort of one aspect of this, but this is really looking at pain from a really comprehensive view. And just from my own personal experience of living with chronic pain for 20 years, of working personally with more than 500 people, and working with U.S. Pain Foundation, where we've got 30,000 people living with pain, that you really have to look at a comprehensive view of how to treat pain. There's many ways to treat it, and just unfortunately over focus on opioids has created a real problem when there's really many ways to manage pain.
If I could
And I
just
think there's
quickly
some.
follow
Go
up,
ahead, sure.
if I could just follow up, I know some of the states you shared were Massachusetts, Maine, two great states. But just to be candid, a lot of times our friends, the General Assembly, always say, "Well, what about those SEC states? Go Dogs!" Are there any other southern, southeast states that you would point to that we might look at for doing innovative legislative activity?
So who else did he say? What type? Southern states.
I was saying any southern state. Yes.
Southern states. Not that I can think of. I was contacted by someone in Mississippi, but I would love to work with you guys in Georgia. I mean, I have New Hampshire might be something that you might consider more similar. I don't know, but no, okay. I don't know of any Southern examples, and mainly I work on where we have states that have our advocates on the ground, because I like to work with people that are local, that really are, personally invested in pain locally. So we do. U.S. Pain Foundation is a nonprofit, so we don't have that much funding. There's like 10 of us that work for U.S. Pain Foundation, so we really work with advocates on the ground, and I do a training program every year, and looking for people from different states who want to work with us. But I don't know of any other southern states that are doing anything like this yet, but I'd love to, work with you, Georgia, or on, any of these legislative ideas.
Thank you, Chairman. Let me answer.
I'm sorry.
Thank you for listening.
Oh, yeah,
Hang on
thanks.
with it. Hang on with it. Tiny. Okay, so next, Miss Peyton.
Thank you for your presentation. It was very good. You mentioned a number of times throughout the presentation that there's been very limited research done on pain. In your professional opinion, what research practices do you think could be done to kind of help bridge our gaps in understanding, if you do have an opinion?
Well, so interestingly enough, I mean, the research that's being done now is something called the HEAL Initiative, HEAL. It stands for Healing Addiction Long Term. And it is a huge program that involves NIDA, the National Institute of Drug Abuse, and NINDS, the Neurological Institute. And they're looking at all different types of things. One, they have a big program on back pain that's looking at what is the best combination of treatments for different types of back pain. So, I think that one of those is based in University of Michigan, and it's looking at, so if we combine cognitive behavioral therapy and physical therapy and occupational therapy, will those three things better work for this type of lower back pain than, three other types of treatments? So there's that sort of practical, they call it pragmatic clinical trials. There's also new research in things, I mean, like sodium ion channels and, things at the level glial cells and at the level of really trying to come up with what's a potential new target for new therapeutics. And because of some of this research in the pipeline, we expect, and this is like, amazing because it hasn't been a new medication in years, but we're expecting a couple of new medications to be approved by FDA. And so we are hopeful that with this research and with the amount of research that's being done, there will be some new non-opioid, non-addictive medications in the pipeline. And, one of them is, slated to be in the first quarter of this coming year in 25, which would be a huge breakthrough because, as I said, realize that there hasn't been a new pain drug in over a decade. So that's one option coming along. There's a couple of others in the pipeline, and so I am very hopeful that we're going to see big changes in pain medication and pain options for people in the next year or so. And it's been a long time coming, but I think I'm very hopeful that it's pretty exciting, actually. So
Thank you. That was a very thorough answer. Thank you.
sure.
Thank you. And Dr. Wang.
Yes, thank you, Ms. Steinberg, on a great, thorough presentation. I really enjoyed it, really hit home. I think your presentation really concentrated, I think, on a lot of the modalities, disciplines that we can use outside of pharmacologic intervention. I think that's important because so much of what we focus in on has been the drugs themselves. And with, pain, which is a perception, it's very difficult to just throw a medication that may or may not dull the symptoms. So I think getting at the root cause is the important part. And I think it really hit home on the slides that you have with the multidisciplinary approach, with each discipline potentially taking 10 or 15%
Yes.
improvement. And it's additive.
Yes.
Additive, absolutely.
And I'm an example of it. I mean, I'm here only because of this.
Yeah.
So, at the point that I was at when after 5 years of searching for help, my doctor said, look, you've got to give up your career. You can't, you're just making the pain worse. And we've got to get you on a program that combines a number of these things. And I really did change my life around by being on that combination program. I mean, the medication that I'm on only takes maybe 10 or 15% of the pain off. The limiting your activity and the exercise program in combination with all those things. I still live with pain, but I'm able to function. I'm able to, be an advocate that I am.
Absolutely. And a couple questions related to that. This pain part is not new. Pain has been here since the beginning
Yes.
of time. Why are we at this point? Partially, I know the drug companies probably detoured us during this with legislation and so forth in the 90s. Why are we at the point where we don't have even CMS, Medicare properly reimbursing physicians or other disciplines in here properly for what they do? And even more importantly, these multidisciplinary pain centers don't really exist out in abundance. And these are evidence-based pathways, based on everything that you've described and that we've seen. People would rather go and get a pill for that or a procedure for that. And so that may be, I'm answering my own question, but why isn't that been out there? Why haven't we seen more of that? Why has CMS only up until now extended some, codes, CPT codes for this? And are we just now getting through it? And then the other part is, I think behavioral health is such a huge component up until today that those two words have not entered these conversations. And as I've said, as a physician, pain is a perception. I've watched plenty of patients where I throw something to them and it'll dull the pain, but they're completely unconscious. I've seen the effects of behavioral health, especially in an individualized, tailored way. Why has that also been on the back burner and now just also entering the stage?
Those are all really good questions. For one thing, I don't think people have realized how big a deal pain is. And, I mean, most people don't get that 50 million Americans are living with pain. And it's just been ignored. I don't know why it's been like that. People, because of the stigma of living with pain or admitting you have pain. I mean, we talked today about a lot of sports injuries. Of course, sports figures have pain. Are you kidding me? They must all be living with pain. No one's talking about it, though. Why not? I mean, we really need to realize that pain is huge and, that there are much better ways to manage it than just taking a pill all the time. And I totally agree with you. It just hasn't been given the attention that it really needs. We need to, that's why when we have the numbers like we do, I think it's really important to get that out there and get it publicized. I mean, just a public awareness campaign and understanding there's a big difference between these different types of pain. And, living with chronic pain for years and years is costing us fortunes of money. I mean, it's the number one cause of disability. And yet we're not paying attention to the things that really matter. I think also there's a reluctance to pay for long-term things. Like, wouldn't it be better, like I said, to pay for physical therapy appointments, as many as people want a year, rather than, pay for what we've had to with the opioid crisis? I mean, it's crazy. It doesn't make any sense. You're right. People are looking for sort of like a short-term thing, whereas pain it really is a chronic illness. And I think people don't realize that. And with our aging population, some interesting data came out just recently. One was in JAMA that basically said pain is increasing more than all the other chronic illnesses at a faster rate. So the incidence of new conditions of pain chronic pain is getting much higher. Well, think about it. Our population is aging, bringing with it age-associated pain conditions like arthritis, diabetes, and cancer. And yet we haven't really acknowledged that. It's also been responsible for 23% of the increases in disability. That research just came out literally 2 weeks ago. I saw that article, and it's fascinating because we haven't paid attention to that, and it's crucial. I think it's really important. You asked a lot of good questions, and we're very thoughtful about your questions. So thanks.
And just one other comment, I think your piece on the physicians, the number of hours, 11 hours.
Yeah.
I'd be lucky if I received that. And I went to Emory, a decent medical school, trained at a good residency. That's probably changed a little bit now, but part of the issue is there is no pain physician. There is a pain specialty.
Yeah.
But you said 1% of, I think if that, but everybody takes on pain, and primary care has been pushed to that. So I think we need to do something at a federal level with the education of our medical students, our residents, and this needs to be resolved on who is going to carry the torch for pain. I mean, if 50 million Americans have it and 20 million have high impact chronic pain, it's disabling, then that's a really big deal.
It is, and it's just not paid attention to. As much as I can, we give guest lectures. So I'm speaking at Tufts on January 8th, Tufts Medical School. I've spoken at the Georgia Medical College of Georgia. Just about a month ago. We were contacted. U.S. Pain Foundation was contacted by a professor there who teaches family medicine and said he wanted a lecture for his residents on pain management because it was becoming a big issue. And so we did. I did a lecture for his residents on Zoom. It was great. So there's interest. I wish that it was more prevalent, though.
Thank you.
Thank you. Chairman Cooper.
Okay, thank you so much for coming in. It's an excellent presentation. I get from what you're saying, we probably don't have an advocacy group here in Georgia.
No. Right.
Okay. I don't know how they get started, but if you can start one, it's okay.
You can start a chapter of, of our organization here.
Well, that's what I meant, but hopefully somebody will maybe be listening to this and reach out to you. The other thing is, I think that, when you talk about information to hand out, we don't have a budget for printing something like that. I mean, we do have public health, but most of the time when there's groups that do advocacy, they bring their own handouts. And so if you ever got to that, they sort of have one that's well done and it's consistent. If you ever get to where you come and do an advocacy day or something for us, maybe that was something you could do, because we just really don't have a way of mass producing.
Interesting. I mean, could you do grants for something like that? Could you do a grant for something?
Well, we might, but that would be, we'd have to get one of the departments to take it on, not us as legislators. But that's just was talking. And Jesse, I wanted to know, do we have any insurance companies that give options on paying for pain that you know of that do it here?
Yes, ma'am. So we'll actually hear a little about that in our next presentation. But it kind of would be variegated by plan across the board, depending on who the sponsor was. If it's, Medicare, Medicare Advantage, Medicaid, commercial, it's just going to be very differentiated across the market.
Market. Okay. And I would think on Medicare, one of our radio personalities, come on, somebody help me, who is our cheapskate, who tells you how to save money, Clark Howard was telling people on Medicare not to go to one of the managed plans, that they were much better, because Medicare pays for more. The plans are supposed to pay for anything by law that Medicare will pay for, but they don't. They deny it. So are you finding that people on straight Medicare, or have you heard that they get more care through the plain Medicare?
I've heard that they get more physical therapy through the plain Medicare. I don't know if that's really true or not, because I don't know of any studies on it, but there might be studies that you could look and see about what is covered. I think what's really important is, plans will say they cover X, Y, and Z, but that they might offer, 50 different plans. What's really important is requiring them to tell people what they offer for pain. We're not even saying offer this, offer that. We're not even making them offer it. It's just that if you're a person and you have a program through, I don't know what your main insurers are here, Humana, Blue Cross Blue Shield, I'm not sure who they are. But Blue Cross Blue Shield must offer 40 different plans. When you're sitting there at home and you want to know what I can do for pain, you don't know what your plan covers. Make them you can make, as lawmakers, I can't imagine you can't make them tell their beneficiaries what their pain management plan is. What are they already covering? They might argue, well, we don't want to be mandated new coverage because we cover these things. Okay, tell every single one of your beneficiaries what their pain management plan. They get X number of PT visits, they get X number of psychology visits for pain, they get X number of occupational therapy visits for pain. Look at all the treatment modalities and say, you need to tell people what they cover so that people have it in their hands. This is their option. This is what they can go to. Even that would be an advance, honestly.
Well, just to tell you that, one of the strongest lobbyists around here are the health insurances.
I bet.
Just no response from Jesse. So it gave him a hard time. So getting them to do that. The hospitals complain because, they sign a plan and say it's for a year, and then the plans come through and change the plans every 2 months or 60 days or so. So the other problem we have in doing something like this, Jesse, we can only affect about 12% of the plans because of ERISA. We have no
ERISA. Federally, it's federal controlled.
Federal plan, so it almost needs to be a federal mandate on it. But thank you so much. You've given us so much to think about, and I really appreciate the presentation.
I mean, letting them choose too. I mean, basically what we said, in Maine and Massachusetts now, is, look, all of you, in order to get your accreditation, public and private payers in this state, need to have a pain management plan. You need to tell your beneficiaries what it is, and we're letting you choose. It's got to be 2 optional non-opioid medications, and it's got to be 3 non-pharmacological treatments. And you can choose what it is, but you have to have a pain management plan, and they can't get accredited without it. Who doesn't cover pain? They've got to have some kind of plan, right? They just don't tell people what it is. So anyway, we're happy to work with you, and I hope this has been helpful to understand a comprehensive view of pain.
It has. Thank you for giving us this. It is truly quite good. And for the time that you spent even standing up, I know you need to go get off of your feet
Thank you.
and relax that back. Hopefully you have a safe journey. Appreciate it.
Thanks.
Mhm. Okay, I tell you what, we're going to take just the shortest, quickest break for everybody to run, refresh a minute. And then when we come back, we will start with Dr. Robertson Jones and learn a little bit about some of the things that have been inquired about. See y'all in just a minute.
Okay.
I guess. Escape. I saw a file. Oh, apologies. Here it is. Alternatives to opioids.
There it is. I put it in,
Yeah, sure.
PDF. There it is. Yep. Okay. Great. We're good.
You got this.
Hey, I think we're all back. Let's get going here. I know this is going to be a great presentation. Looking forward to it. Dr. Robertson Jones, Associate Vice President of Pharmacy for CareSource. Please feel free to tell us anything more about yourself that you would like to.
Okay. So, Terkeisha Robertson Jones, AVP of Pharmacy at CareSource. I've been with CareSource since coming into the Georgia market July 1st of 2017. And prior to that, I worked for the Medical Assistance Plan, also known as Georgia Medicaid or Fee-for-Service, for 6 years. So, Chair Lady, I want to thank you and the committee for having me here today and giving the opportunity to provide some insight from a health plan perspective. So if you're not too familiar with CareSource, we are one of 3 managed care organizations that serves the Medicaid population here. CareSource has been in the market since July of 2017. And overall, from a company perspective, we service more than 2 million members across multiple states. Since being here servicing the Medicaid population, we've also expanded into the marketplace and dual special needs population as well. But today I will be focusing on what we cover from an outpatient pharmacy program standpoint, to give you a better understanding of what that looks like. So just to kind of do a pharmacy 101, just wanted to go over some terms that you may hear from me today or just in the pharmacy space in general. So the first part I'd like to speak to is the pharmacy versus medical benefit. So when you think of pharmacies, most folks think of your Walmarts, your Publix, your independent pharmacies. And all of those, they do fulfill prescriptions, but there's a difference in the billing. So with claims that are processed at a community pharmacy, they use a national drug code, or as we call it, an NDC. Under the medical benefit, we use the Healthcare Common Procedure Coding System, or we call it HCPCS codes that are submitted on claims. So those can be billed a couple of different ways. The prescriber may instruct the patient to get the prescription filled at a community pharmacy and bring it into the office, or the physician or prescriber can choose to what they call buy and bill. So they will purchase the medication directly and they will bill the health plan for the cost of the medication and for the administration. And so usually with that, you may see some of our more complex drug therapies billed that way, or specialty medications. So from a Georgia Medicaid perspective, Georgia Medicaid covers all prescription medications who participate, the manufacturers participate in the federal rebate program. There are a few exceptions. So sometimes it gets confusing to some individuals when we speak with Medicaid, with preferred and non-preferred, compared to our marketplace terms where it can be covered or non-covered. So the bulk of our population is Medicaid. About 80 to 85% of the members we serve is the pediatric population. So some of the things that you will see later on in the presentation, of course, may not be applicable because of that population that CareSource serves here within the state. So be it that for the Medicaid, it was a federal program, that as long as the drug manufacturer participates in the rebate program, the drug can be covered. But we do differentiate between preferred and non-preferred. With Marketplace, what you'll see in some subsequent slides is the tier program. So we have a tier, from 1 to 5. And so based on the plan that the member purchases, we have a bronze, silver, gold plan. That price will vary. And some other terms that you may hear within the pharmacy space is prior authorizations, quantity limits, and I won't go into detail there because I've pretty much provided that information there. But if you have questions, just let me know. So with Georgia Medicaid, the co-payments range from 50 cents to $3. And one thing I want to point out is with Medicaid members, if they go to the pharmacy and they say, I don't have the 50 cents or I don't have the $3, we cannot deny the member their prescription. So there is a way that that information is logged when that occurs. So just wanted to call that out. And there are some exceptions, certain groups of individuals who do not have a copay. But for Georgia Medicaid through CareSource, we do cover for regular Medicaid and then also the Peach Care for Kids program. And as I was stating earlier about the marketplace tiering, this gives you kind of a brief overview of what that looks like. And the price will range depending on the plan that the member has chosen. One thing I will tell you is that we do majority of our covered medications on Medicaid as well as Marketplace are generic medications. As you know, depending on brand or generic, usually the brand medications are a little more pricey. But that gets more into the financing and the rebate process, federal rebates and supplemental rebates. So that's a day for a whole nother, probably hour presentation to kind of go over that. So I just want to kind of give it to you high level, but feel free to stop me at any time if you do have some questions. Yes.
Okay. For the higher prices, does the copay go up, or the copay is always 50 cents to $3?
For Georgia Medicaid, it is 50 cents to $3. $3 is the max.
Okay.
Any other questions? So I'm not for sure how I should feel, because I feel like majority of my presentation was somewhat covered in different pockets earlier with the previous presenters, but feel free to say if you have any questions. But I did want to provide some data that's specific to Georgia. So with the Georgia Department of Public Health, as you see that there was a large increase of 302% of opioid-involved overdose deaths. So to give you more specifics on the numbers, this has happened over a 12-year span. And in 2010, there were 740 opioid-related overdoses. In 2022, that number went up to a little over 2,200. So that's a significant jump. So we're seeing from 740 to almost 1,500 increase over that 12-year span. And as you can see, as outlined here, and a few other folks had mentioned earlier, just the costs associated with the opioid use disorders. So definitely, as the speaker prior to me and several others earlier, it's not cookie cutter, it's not one size fits all when we're looking at alternatives to opioid treatment. And so I do want to make the disclaimer, this is not an all-inclusive list, as we've heard earlier today, but these are some of the agents that we see at CareSource that have been requested for our members. So as stated before, with the Tylenol or acetaminophen, or your non-steroidal anti-inflammatory drugs, which can range from your naproxens or your Aleve, ibuprofen, Motrin. I'm giving both names just in case you're more familiar with the brand or the generic of the medications, and some of the topical analgesics as well. And in a few slides, I will go into the details of what our coverage is for several of these agents within CareSource. Some of the non-pharmacological approaches, I think we've gone pretty in detail with those through other presenters. But if you have any specific questions from a pharmacy perspective, please feel free to ask, but I will go, oh, yes.
Notice that you cover osteopathic manipulation, but not chiropractic. There a reason for it?
Well, with Medicaid program, we have to make sure that we cover what we will get reimbursed for. So there's limitations on that.
And so they cover osteopathic, but they don't cover chiropractic at this time.
Correct. I'm not looking at that particular slide yet. I know that's towards the end, so I need to make sure I lay my eyes on it, but one second.
It's under the non-pharmacological approaches.
Yes, the non-drug alternatives. Further in the presentation for Medicaid, it is not covered. Yes, but for Marketplace, CareSource does cover it. So that's not regulated by fee-for-service or DCH.
Okay, out in the marketplace, general marketplace, you do cover.
Correct.
Okay, thank you.
No problem. Any other questions about this particular slide? Are you all able to see the slides? I just see me. Oh, you have the presentation. Okay. Yeah, I'm sorry. I was just talking and didn't realize that it was there. This is yours, right? Okay. Okay, great. Thank you. Okay, so here in the next few slides as well, you will see our coverage for CareSource from a Medicaid and a marketplace perspective. And as you will see, majority of the non-opioid medications that are covered, they are preferred. And once again, just want to reiterate, when you were talking about Georgia Medicaid, we use preferred and non-preferred, or for short, we call it a PDL. But in a marketplace, there's a difference with a formulary and non-formulary. So with formulary, if something that's non-covered, then that's just what it may be as non-covered, or it may be a higher price for if they get a tier 5 compared to a tier 1 medication. So, but just to reiterate, with Medicaid, we don't say something is not covered. It's just non-preferred. And then if the physician or the prescriber wants to make a request and able to provide that additional details that we need, the prescription can be covered. All right. So as you can see, majority of the acetaminophen and NSAIDs, your Motrin, Tylenol, a lot of these are over-the-counter medications with the first three. I think one of the other presenters had mentioned that as well. So there is an option, I will tell you, for over-the-counter prescriptions. We do cover that for the Medicaid population. They just need to have a prescription written by the physician or their prescriber. But we do cover those over-the-counter products. And as shared in some of the previous presentations today, there are some other non-opioid medications that can be used, such as the muscle relaxants and topical analgesics. And in a few more slides, I will go over a little bit more detail as far as that safety aspect of it. So just to make sure that I level set, when we look at medications to determine what their status is going to be on our preferred drug list or on our formulary, safety and efficacy is first. Safety and efficacy is first. After that has been determined, then we look at the cost. So that's where you will see why medication may be preferred or non-preferred, or covered or non-covered. So safety and efficacy is our primary focus, and then we consider costs. So any questions about that piece? With the anti-seizure agents, I know this was brought up, I think with the previous presentation, but I did want to kind of expound on the gabapentin. So within the state of Georgia, this medication is not controlled. And so when I say control, meaning we have various schedules for the medications. So a Schedule 2 medication is your oxycodones. And so depending on the level of dependency and potential for abuse, that comes through the board of pharmacy and on a federal level. So within Georgia, gabapentin is not controlled, but in other states it is due to its potential for abuse. Pregabalin is a Schedule 5 here in the state of Georgia. So there is potential for abuse for this medication. So that's why it is not what they consider a legend drug like your Tylenol and your Motrin, but it has received a status of a Schedule 5 due to its opportunities for dependency or abuse. And some of the safety profiles, just wanted to kind of touch on this with some of the previous drugs, but have it listed there. anything from drowsiness. A major thing with the opioids is constipation. And so there's usually, something, another drug or another over-the-counter product to kind of help with combating that. But when you have chronic use of opioids, that can really be a big challenge for those individuals taking those. Also dizziness or drowsiness. So if you've ever received a prescription, they'll tell you do not operate heavy machinery on your prescription bottle, or, just precautions as far as driving and things of that sort. So just wanted to highlight some of those safety profiles. So cost comparison. So the figures that you see here represent what it costs for CareSource in the state of Georgia. So I think earlier in the presentation, there was a mention that that it would cost more to get a non-opioid medication than your Tylenol or your Motrin. So this is data specific to our health plan in the state of Georgia. And as you can see listed here, that is just the opposite. So the cost to the patient is definitely significantly less than what it is the cost to our health plan. Any questions with that? And I do want to highlight the difference with those opioids, the morphine, oxycodone, hydrocodone, and acetaminophen, and how those kind of play out within the whole scheme of things. And they are more expensive than the non-opioids based off of the data that we pulled. So I think we kind of touched on this a little bit ago about the non-drug alternatives. And as you can see, majority of those alternative agents are not covered, but some of them are available over the counter. So I just wanted to highlight some of those. With the heat therapy, the heating pads are available as an OTC, and the cost is about $15 to $60. It ranges. And for the TENS treatment, those can be offered at a physical therapy appointment. And as you see, for both Medicaid and Marketplace, we do cover, CareSource does cover that alternative treatment. So that's something that can be taken into consideration. And then just in general, I know we cover it, but I just wanted to give you guys some information. If someone had to pay out of pocket for physical therapy, that price can range anywhere from $50 to $350 per session. So that can get a little costly if someone does not have insurance. Okay, so that concludes my presentation. Are there any additional questions for me?
Does the committee have any questions or comments? You got one? Okay.
Okay, okay. On the morphine, the plan costs $24.87, but only $1.57 to the patient. I thought did I get it backwards? We were talking about, weren't we talking about that the opioids were much more expensive?
That was what was shared this morning by a different presenter. But so this is the data that's specific to CareSource. That's the cost per pill.
Okay, but y'all are still covering them at the low price.
Yes.
Okay, so if they use these others, it does save you money.
Well, both plans have a structured copay. So like for Medicaid, depending on where they fall in the category for eligibility, the max they're going to pay out of pocket is $3.
Okay.
And just remember, if they do not have the money, they'll let the pharmacy know, and they still will get their medication.
Okay.
Any other comments or questions?
I don't know if that's good or bad.
Well, this is pretty comprehensive. And like you said, we have heard some of the basic background before,
Yes.
and you're giving us the X-ray picture of exactly what y'all are doing. What do you think are the biggest stumbling blocks to people who are trying to get pain medication specifically, or pain treatments beyond an opioid?
And I think each scenario is going to be different. It's not that one size fits all. But what I can say within CareSource, we have a comprehensive team. Care management does take place. So if there's any assistance that we can provide our members, we make sure that we implement and utilize those additional resources. I mean, there's a lot to take into consideration, you know, those who may live in a rural area. Our partnership within CareSource, we've been really moving forward with our independent pharmacies that are in our rural areas. So, and just to kind of, I guess, give you all a background as far as what we do from a pharmacy space, we have a pharmacy advisory board that consists of pharmacists. It's a 10-member board, and they're from various practice settings. You have some that specialize with opioids. We have behavioral health pharmacists. We have independent pharmacists. We have drug manufacturer pharmacists. So it's a whole array of pharmacists that make up this board. So we do present them with questions similar to what you've asked, and to get their feedback on what they're seeing as they're, you know, filling the prescriptions, or some of them may actually do have some consulting business there. So I think it's going to be different for each scenario, but I think as long as we incorporate the whole picture, the whole health of the member, not just like the prescription, but behavioral health, there's an opportunity for us to bring in that team and care management team. I think that will take us to that next level that we're looking to, maybe not be so dependent on the opioids.
Can you confirm that like non-opioid options are covered?
Yes,
right
ma'am,
now?
they are.
They are covered.
Mhm.
Okay. Some physicians who don't prescribe opioids say that those are not covered at all.
Well,
And
for
I'm not saying
CareSource,
specific-
they are.
Okay, well, that's good.
Yes.
That was a broader, like that some are having trouble in certain areas. I didn't know which, but
Okay.
if y'all are doing it, that's great. That's very important.
Yes, and I think I may have included on the slides where we see the acetaminophen and the NSAIDs. If you look down that last column for coverage, you'll see it's preferred for Medicaid all the way down. And then there's tier 1. So tier 1 is going to be on that lower end of cost based on which plan, the bronze, silver, or gold plan that they choose for the marketplace. But tier 1 is basically considered like a generic.
And this is just verbiage for me. So you said earlier in the presentation, you said Medicaid, it's preferred and non-preferred. And
Yes.
marketplace, what were the two terms?
Covered and non-covered.
Covered and non-covered. I just want to
Yes.
get that right. Okay. And I think that Chairman Cooper has another question.
Yes, ma'am.
Okay, who do you cover? Children.
Majority of the CareSource Medicaid populations is pediatric. So about 80 to 85% of who we serve are pediatric. So you got 2 other managed care organizations in the state. I can't speak to their population, but for us, it's mostly 80 to 85% pediatric.
Okay, I'm going to be really confused now. I thought our children on Medicaid were on Peach Care.
So with Medicaid, so you have the overarching umbrella of fee-for-service. And so fee-for-service several years back said, we're going to move into that managed care space. And at that time, they brought on 3 managed care organizations. So you've probably heard them. You have Peach State, AmeriGroup, and at that time, it was WellCare. And so about 8 years ago, there was a rebid for the business. And so Georgia Medicaid brought on CareSource, which is who I represent. And so we all are managed care. So we get a certain capitation for treating the healthier population. So fee for service right now services that age blind and disabled population, which is the sicker of the sick. So, or, you know, called ABD. And so how that outlines is that the managed care organizations are supposed to get the healthier ones, but every now and then there's a few that may slip through the crack that may have a chronic condition. And but we work with them to see if they're appropriate to be shifted back to fee for service.
Okay, but our children don't have a regular Peach.
Yes, Peach Care for Kids is offered to state employees and for their children. I think you might be speaking about the foster care population, which is serviced currently by AmeriGroup.
What am I asking, Jesse?
Jesse, okay, sorry.
Madam Chair, Peach Care is for people whose income is above 235% of the poverty level, but it pretty much mirrors the benefit in managed Medicaid for people whose family income is under 235%. So Peach Care and low income Medicaid are very similar, and they're managed by the three CMOs
Yes.
that Dr.
Okay.
Robertson Jones is referring to.
And that benefit is extended to state health benefit plan children as well, if they meet the qualifications.
Okay, I have one more question.
Yes.
If you do all these children, do you know, since we've made a big push not to let children under 18 or under get opioids, do you know how many opioids you're filling for children under 18 or?
I don't have that information with me now, but that is a takeaway and I can get that and get back to you.
Because I would be curious, it would indicate if our regular pediatricians and all are following that new directive out of, the pediatric national thing about not letting kids have opioids before. I'd be really curious. Thank you.
What I can confirm to you is that we review our utilization overall for which drug classes is used, and that is not within probably the top 10. Majority of what we're seeing for our dispensing is chronic conditions, unfortunately, like diabetes, behavioral health, asthma. So the opioid and the opioid piece is not within I wouldn't say the top 5, let's say that. So
I would hope
so it's
that-
lower, definitely lower, but I can get you the specific numbers that we're seeing for Care
Thank
Source. No problem.
That's great. Why don't you send that to Morgan and she'll make sure that we all, but particularly Chairman Cooper, get
Okay.
that information.
All right.
Are the, Jesse, did you want to say anything else? Or
Oh,
was
no,
that-
Matt was just clarifying the estimate.
Okay. Okay. I'm sorry, Mr. Wethington. I didn't mean to. Trying to be real official here.
Okay.
Are there any other questions or comments for us today? Thank you.
All right.
Thank you
Thank
for
you for
hanging
having-
in here with us all day and for helping us understand this portion.
No problem. Thank you.
Thank you. Okay, we have one final presentation today, and I know it's going to be pretty special here. So Cammie Wolf-Rice, the Christopher Wolf Crusade, and Cammie, come tell us about yourself, and we'll put you right here. Do you want to sit at the table? Is that okay?
I don't need your slide, the help on the slides. They're not, sorry. I'm gonna hit that one, right? Do you remember what you called first? House slides, Cammie. Yep. Okay. That one? Okay. Okay. Thank you, Madam Chairs and the committee for this time. I always got to start with my why. The beautiful smile on, I guess it would be on your left, that is Christopher Brett Wolf, my son. And he had a health crisis. In middle school, he was diagnosed with ulcerative colitis. And it's a horrible disease, as you all know, 18 times a day going to the bathroom and blah, blah, blah. He had to have his large intestine removed, and this is 20 some years ago, and it was right when Oxycontin was released to the marketplace as the wonder drug. And he had complications with his surgery. He was in the hospital for 70 days on morphine, and we went home with 90 Oxycontins, and we followed by 90 more. And I did exactly what the white coats told me to do, and that was to give them to him every 4 hours. And it hijacked my son's brain. And my son was so disciplined, y'all. He aspired to be a Navy SEAL. That's what he wanted to be, as a Navy SEAL. And so he fought addiction for 14 years. I have a PhD in treatment centers. It's called MOM. I've lived it. But we failed because he died February 26, 2016. And for 2 years, got to go back. For 2 years, I kept very quiet because of the stigma, because I didn't want a disrespectful death to my son. And then in 2021, my brother, after COVID, right after COVID, a friend came by. He had a lot of anxiety, and he gave him a Xanax and had a speck of fentanyl in it, and it killed my only sibling. So I understand my assignment very, very clearly about the opioid epidemic and the fentanyl crisis. So I woke up one day 2 years later and I said, I got to stop it before it starts. CWC's swim lane is prevention, 100% prevention. And we as a nation do not prevent anything very well. We're not good at that. But we have to get better at it when it comes to the opioid epidemic, because you all know better than anybody, once you're addicted, what it does to that individual for the rest of their life. They have a disease to fight every single day, and it destroys the family as well. It takes the entire family down. So that's why I woke up and said, there's a missing piece to the healthcare team in hospitals. We as a society have coaches for everything. Can you imagine UGA football team without a football coach? Can you imagine the Hawks without a basketball coach? We have coaches for everything in our society. Workout coaches, lactation coaches, sleeping coaches, executive coaches. There is no coach in the hospital when you're having a health crisis. You need a coach, and that's what CWC brings to the table. So we've been talking about a lot of problems today. I am standing before you to tell you CWC Alliance has solutions, and we've cracked the code, and it works. And this is not just Cammie up here telling you. Look at this advisory board. I met with over 150 medical professionals, and I said, poke holes through my strategy. Tell me what's wrong with having a life care specialist, a care coach at your bedside. And they said, Cammie, this is perfect. It's needed. You got to find the money. I said, is that it? Everybody said the same answer to me. You have to find the money. We did. We found the money. So we got a lot of expertise on here. The chief medical officer of CWC Alliance, she's the chief of surgery at Grady, and she believes in this, and she uses our services every day. We have a pediatrician on board. We have the former chancellor of Emory. We have the chief technology officer of Emory helping us to come up with innovative ways. And we have the retired vice chairman of GE, who, oh, by the way, happens to be my husband. So we got a powerful advisory board because I want you to understand the expertise behind our strategy. But let me tell you who I was before I lost Christopher. I was in corporate America, and I managed global partners. I managed IBM, Accenture, Deloitte, Ernst & Young. I had to get everybody to sit at the table, shake hands, sing Kumbaya, and get the deal done. And that's exactly what I was prepped for to be able to be doing the work that I do today. Because it's all about partnering. We cannot work in silos fighting the opioid epidemic and the fentanyl crisis. We have to partner and come together. And I would not be standing here and get to brag to you on the next few slides if it weren't from partners. If it weren't for Grady Hospital that believed in me when I went and sat at their table and they let me put life care specialists in, even through COVID. We did clinical trials during COVID. If it weren't for Emory, if it weren't for Dean Sumner at Mercer University. She is my champion. She is my cheerleader. I love her, I'm just going to say. I wouldn't be here if it weren't for all these partners. So the position is this. I listened all day and I tried to be quiet back there on that pew, but a lot of people talked about what we have already in hospitals, and that's a life care specialist, someone in the hospital to be your care coach at bedside. So if you have to be on an opioid, we're going to talk to you about the importance of how quickly you taper off those opioids. Now, one thing you said, Madam Cooper, that I loved, you said people don't read pamphlets. Oh, we printed them and printed them, but guess what? It's the human being. It's the human being at bedside to be a listening ear. Many times they're just listening. The patient needs somebody to vent to and to validate their pain, right? So we help them with sleep. We've come up with many, many innovative things, music therapy, coping skills. We're all certified with the Trauma Resource Institute to provide coping skills to deal with anxiety, stress, depression, PTSD. If you're in the hospital, you probably have all those things. You have to have the mental side of getting well in addition to the education about the opioids and the pain medicine. The other thing that's happened is that we've uncovered so many other comorbidities because we spend time with the patient. So then we find out there's food insecurity, there's home insecurity, there's domestic violence happening because we have the time. Now, data is important, and we've done clinical trials. It's tough. I don't like it. I'm just going to be honest with you. It's hard work. It's hard work. So I depend on my partners with Mercer and Emory, and we've got research teams. But I want you to hear some of the stories because you can't hardly put that in a data report. How about a nurse saying, the only thing I have in my arsenal when a patient is pressing that pain button is an opioid. I'm lucky if I can have a heating pad. Now I have the life care specialist, and they are my lifeline. I call the life care specialist and they come in. And that's a quote from a nurse. This is working in hospitals. How about the gentleman that says, oh my gosh, I had no idea I was taking an opioid. My wife is in recovery. I can't go home with this big orange bottle of opioids. We provided him a safe so he could lock up his medicine when he went home. Had he not known about that he was on an opioid, 70% of the patients at Grady didn't know they were taking an opioid. They didn't know what an opioid was. They knew the street names, but they didn't know what an opioid was. So there's our job, to educate and to provide skills. Now here's where the success. Grady is our training hub. That's where we do our practicum. Our online curriculum is housed at Mercer, at the School of Medicine at Mercer. So the life care specialists go through the online 13 modules, then they come to Grady to do the practicum. We are in Mountain Lakes Hospital up in Clayton, Georgia. We're rolling out in Coffee, Georgia, Stevens Hospital, Valdosta. Arkansas, we moved out of Georgia. 2 rural hospitals were already implemented in Arkansas. We have Vanderbilt applying for our system this Friday for opioid settlement money in Vanderbilt. Over the last 2 months, we've had calls with Kansas, Tennessee. Carter, help me out. There's been 3. Yes. Pardon? Nevada. But guess what? This is our home. Georgia is our home. And we need you all to be our strongest partner because this is our headquarters. This is where we are based at home. Arkansas, I love going to Arkansas. I love Arkansas. And they will tell you, we want life care specialists in every hospital in Arkansas. And now we're going to do the 2 flagship, and then we're going to roll it out to multiple hospitals. So I wanted to show you what we've done up to this point. If you look over to the right, I was speaking at a chief medical officer meeting, and there were physicians there. And these physicians came up to me after I got off stage, and they said, "We want to get certified to be life care specialists." I was like, "Oh, okay." I thought they meant the online piece. I said, "We can do that." No. These physicians flew in from Arizona to Grady Hospital. They did the online curriculum. Why? Because they didn't get one bit of that training in med school. They got trained on pain management. They got trained on opioid addiction, right? They got coping skills to help their patients. And now they left. I got them on video saying, we're going to go back and be better doctors because we know how to talk and help our patients with anxiety, stress, depression, PTSD, pain management. So everything that we've been talking about today, we have it right here in Georgia, and it's working. Okay, this really makes me happy dance. So Harvard did a case study on the life care specialists, and they just published it in August. We're supposed to be receiving 500 copies that would be in your folder, but we haven't got them yet. I've also been asked to come up to Harvard February 4th, which is my mother's heavenly birthday, and I'm going to teach a class on life care specialists at Harvard. This is my son's legacy. Yes, this is a business, but this is my pain turned into purpose that is saving lives, one life at a time. And so I'm incredibly proud that it's working because I know that it was desperately needed in hospitals. And I know my son's smiling down on me right now. So there's 3 things. There's 3 things in your folder. There's 3 things needed. And that is education and prevention in the clinical care setting, which you all are fully aware of that, because you are the experts. You are intelligent about this space more than any room I've been in. But we need funding and we need sustainability. We need a code for life care specialists specifically. I've got all these grants, okay, but they're going to expire in 2 years and then 2 years and then 2 years, and I throw stuff to the wall and I pray that it sticks, and it has been sticking. But we have to get smarter about this, because if we don't prevent, you all know how much addiction costs once it starts. I don't have to tell you how many deaths are happening in the state of Georgia and the cost to the state of Georgia. What I'm begging you for is the partnership. I'd love to sit down and I would love to pick your brains. I would love for you to give me ideas on how we scale, how we sustain this model and this new position in hospitals. I thank you for your time. Happy holidays. Bless you all. And Merry Christmas. Oh, yes, I'm open for questions. Sorry. I know you guys want to probably go home.
Hang on. Yeah. Okay, Ms. Payton.
Thank you so much for your presentation. I think you are amazing. I love what you do. I've worked in prevention for a long time, and I just think this is such a needed program that you've created. My hat is off to you. It makes me quite emotional to hear you talk every time I've heard you talk. My primary question, however, so you're in Grady, and I would assume that probably 90% of individuals who are in the Grady ED department could utilize your services. So could you please explain to me, from the moment a person is admitted into Grady or Emory, what the referral process is to get those individuals? How do you determine who is eligible, and who to intervene on, and what that kind of process looks like?
Great question. So our model's a little bit different, rural versus urban, okay? Because rural, we see all patients. We're in maternal health care. We are floating to the ED. We see all the patients because we can, and we have the bandwidth to do that. In urban, there are peer specialists, which you all are very familiar with peer specialists. They're in recovery. Now, we've trained some peer specialists with our training, and we've also hired some people in recovery to be life care specialists. But we're not in the ED at Grady. Where we started was orthopedic trauma because of sports injuries in young people, right? So that's where our clinical trials started. We then moved also into sickle cell. So we're in sickle cell. It's hard there because it's chronic pain. They've been on opioids their whole lives. So we provide a lot of mental wellness skills for sickle cell because they're on opioids, right? And then we're now moving into oncology, and we're expanding into Grady. And rumor has it that we might have some opioid settlement money to expand even more departments into Grady. So what we do is, look, we're partnered with the nurses. That's who runs the hospitals, in my opinion, are nurses. And so we're partnered with nurses, and they have our contact and they have our phone numbers, but we're on the floor. And we go, the life care specialist goes to the nurse meeting in the morning, and they go, on the floor, and they see the patients regularly. And then they follow up with them. Now, what I'll tell you also, in the rural communities, they do things in the community as well. So we also go to the Rotary, and we speak at the Rotary, and we go to school in the rural communities. I go out to all these communities as well, and my team. So they really are a part of the community of advocacy, not just in the hospital. Did that help?
That does help. Sorry to kind of drop the ball on Grady's ED, but so the nurse refers them.
No, they just actually go in. They know who we are, right? Because we've done orientations and built relationships. It has been a little challenging with traveling nurses because there's new nurses coming in, but they just have their set floors that they go on. So Dante at Grady, he will go to floor 5, and he goes in and sees patients. The nurses know who he is, so they're okay and comfortable with him going. Now, if they have a patient that's really causing an issue, right, then they will call us. They've got a little card and a phone number. We're on the whiteboard. For example, I won't say which hospital this was, but there was a young lady that jumped out of a semi escaping a sex trafficker. She wouldn't speak to anybody. Nobody knew her name. The nurses didn't have time to go in and sit. So we said, you life care specialist, you don't leave her side. You stay with her. I don't care. You stay with her. Nurses wouldn't even go in to give food, medicine, nothing unless the life care specialist was in there, because they were able to build a rapport, get her to talk, get her name, get her family to help her. Because we have the time to do it. Nurses don't have the time to do that kind of thing. Does that make sense?
Yes,
Yeah.
thank you very much.
Yeah. Long-winded answer to your
No,
question.
that was perfect.
Chief Pursley.
Thank you, ma'am. So I hear the passion, and I will say, I pray that everything that you do going forward is, beyond measure. A comment and a question. First, the comment is, I would consider also talking to the Department of Public Health, because in each health district there's a public health analyst, and they kind of go hand in hand when we talk about injury prevention methods. And reason being, that can be another source to reach out to the other people in that atmosphere of that public health analyst. The question is, how do you find the people who are to be the life coaches? Do you recruit, or do they come to you? Is it a combination of both?
It's a combination of both. We just implemented 2 life care specialists at Emory. We received over 100 applications. We do look for a medical background. However, and I was very strongly opinionated on the rural areas. You don't need a college degree. We have the curriculum, we can teach. What I'm looking for is what you're born with, and that's compassion and a heart and a listening ear and non-judgmental person that's going to be a coach to somebody. We can teach the rest. And so they do have to go through the certification. They do have to get certified from Mercer School of Medicine. So it's a lot of time referrals. We've had EMTs apply, people that want to go into med school, work at Grady. They're going on to med school, but they feel like they're going to be better doctors by being a life care specialist on the floor before going. So it's a mix. We have and then we've got a couple people in recovery in one of our rural areas that she's in recovery and 9 years clean. And she's gotten, since February to now, she's gotten 5 people into treatment up in Clayton. That's making a difference. So it's across the board. And here's the thing, there are child life specialists in children's hospitals. There's 6,000 of them in the United States. 6,000. But when you're 18 and above in an adult hospital, you have no coach. So we're just going to duplicate that for adult hospitals. This can be done. This should be in every hospital across this country. But I want Georgia to lead the way. I want my state to be the one that's backing CWC Alliance.
Thank you, ma'am.
Mm-hmm.
Thank you. Chairman Cooper.
Reflection on anybody else, but we saved the best to last. In prevention. On the chart, have you picked out particular places that where you're in the hospitals with those stars that have opioid problems, or was it just where you could get in and have life coaches? Because they all have people.
Yes, ma'am. In the state of Georgia, particularly, we partnered with Dean Sumner and the Rural Innovation Center of Georgia, and they were the ones that to help us identify where we should go first.
Okay.
And we did look at, where we were having overdose and where we had relationships and where we could get, some flagship going. And then we planned to expand, but I really leaned on the partnership because she's an expert in the rural communities. And so I leaned on her to tell me where we needed to go.
Well, just get out of the way because I am Dean Sumner's #1 advocate and person. Okay, you have to be second.
Okay, I'll be
All
second.
right. No, she's the smartest woman in medicine in the state of Georgia, maybe everywhere. And I mean that sincerely. Okay, so you go through the training, and I have a young lady who wants to go to medical school and is working toward that. What does she do? Contact you, or how does she make an application? And when they're through with this, do they get paid for working in the hospital?
Yes, ma'am.
Does the hospital pay them?
Yes, ma'am. So for like in Arkansas, for example, we got opioid settlement money that pays for the salary.
Right.
The hospital applied for the grant, and we're the vendor that supplies the program. Now, and yes, they can email me. My card is in that folder. Anybody that's interested to email me direct, and then we'll put, together with Carter and my team. But here's the thing. It takes ongoing training because you can have the best curriculum and you can have the practicum at Grady, but then the life care specialist, the first patient they see is a 9-year-old girl that took their hammer to their mother and grandmother. Well, we didn't train for that.
Right.
We weren't expecting that, but stuff happens, right? And so what we do is we have ongoing support. So our life care specialists get on a call weekly, and we continue to support them and train them. And we have a warm line that we can give them support because they're not going to have all the answers.
No.
Right. So we really keep our hand on the pulse, and we've built a team that's how they're learning because they're on a call every week and sharing stories, and that's how they're getting better and smarter about their job.
Well, I can't think of a better program for people who want to go to medical school, because this would be a tremendous thing. And I'm going to have Valley, which she goes by, her middle name is Valentina, but I'm going to have her.
Have her reach
And
out.
she's bilingual, and I can imagine Grady could use somebody bilingual. And when students come and want to go to medical school or something and ask me, I now have a resource to say, maybe this is something she's done. She's worked with children for 3 years every Friday in a pediatric practice. And
We are actually hiring at Grady, and bilingual would be a huge help to us. So definitely, in the rural areas too, it's helping workforce development because, like I said, you don't have to be going to medical school. It could be anybody in a rural community that wants to make a difference, and everybody knows everybody in those rural communities. It's been an amazing experience for us going down there, but they have a career now, and they're very passionate and love what they do and very committed to their community. So it's really helping the workforce development in the rural areas as well. And in Arkansas, we're into very rural areas as well. So there's a big focus because Dean Sumner, the first time I met her, she asked me to come to Macon. I didn't know who she was. And she said, do you realize you have the answer to rural healthcare? And I was like, can you say that again really slow and let me record you? I tell that story everywhere because she's such a champion. So I'll be number 2 to you though. I'll be number 2. Yeah, that's okay. I'll share.
And I wonder if there would be a place maybe for the education on the program that you set up with your teachers in our technical colleges.
Yes, ma'am. I would love that.
I mean, I wonder if you need to connect with the people who run our technical college. I know that we worked with lactation specialists and they set up a place in, was it in Rome up with you, or maybe it was Carrollton, and a program for that. And it just seems like to me, if you're looking for more and help in training and, we have now 20 things that we don't charge an admission for because they're critical things for the state of Georgia, like welders and that kind of thing, that the medical assistants and LPNs, and seems like with the right connections, this might be one place where you could expand your coaches.
I would love to have a follow-up meeting, honestly. I really would love the support, and I know you have so many ideas and connections and support for us. I just feel it. And so yes, that would be great. I would love that. Anything that you think that would be valuable to our program, let's lead it.
Hey, do you know who runs the technical? Do you know them?
So we have a question from Mr. Breedlove, or a comment. Let's see if he can join us. Are you there?
Yes, Madam Chairman, thank you so much. I just, could not let it pass. I feel so terrible that I'm not there because you did save the best for last. And that's no reflection on anybody else, but I know the work that Cammie does with the crusade, and it truly is transformational. And I look forward to tomorrow when we're doing our work to talk about this presentation and how it relates to what she testified about, how maybe a certain staff member in a hospital doesn't have the time, rightly so, to invest. But now with this concept, somebody can be there when a person is in the middle of a mental health or addiction crisis, maybe defects is on the way, and there are just all kinds of things going on. And we invest time in these patients in this critical situation. And I think it ties in with the great work the General Assembly does with peer certifications. And I think there's a way to marry up what Chairman Cooper just said about the technical college systems with the good work that the peer certification is doing, so that Cammie can spread her good work across every hospital in Georgia. And I just look forward to talking about that tomorrow.
Thank you, Jeff. Thank you. I appreciate that.
Yeah, I think we'll all be talking about that tomorrow and for the days ahead. This was so good. We, of course, saw the presentation in Macon for those of y'all who were at that meeting. And yeah, this is powerful.
Thank you so much.
I believe we can thank Morgan Hall for this, actually. Yeah, for the wonderful closure of this long day, but I don't want you to go away yet. So let me see. So you mentioned that all the children's hospitals do have the
Yes,
coaches.
ma'am.
So our CHOA,
Yes, ma'am. They have,
do you know how they fund it? Do you know how where that comes from?
I can easily get you specific information from Donna Highland, the CEO of, she's been a huge advocate. As a matter of fact, having dinner with her is what sparked that I needed to do the life care specialist, because I kept saying, if only we would have known to taper off quickly, right? If only my son would be here today if he had a life care specialist, right? And the resources I needed as his caregiver, right? So yes, child life specialists, it was hard to find out because I did historical. They started just as kind of bubble blowers and played, candy and stuff. But they do distraction when kids have to have stitches and so forth, right? We just took it to another level at adult to educate on opioids and so forth. I'm not sure how they're funded, but I can totally ask Donna and find out for you.
I would love that. I'm a big fan of hers as well.
Me too. Me too.
Yeah, I think we need to build on that and see what we can do. I feel like we've opened up a brand new box that we're gonna jump into. So.
Yeah, it does seem, prevention does, this whole thing, the epidemic and the fentanyl crisis, it seems so big and overwhelming, right? Like it's so overwhelming. But but one patient at a time with solutions. And I really feel strongly that we have a really good one here. I'm super proud. And the reason I gave you my book, well, number one, I'm proud and I'm trying to reach the masses, right? And that's the reason I wrote it. I never thought I'd be an author. But after every chapter, there's a QR code. So if you don't like to read, there's a little video. But what's most important in the back is there's a QR code in the back of a resource library. And what makes that so important is it's ever changing, right? And so I can update my book every day if I want to. So I'm constantly adding new partners, new hospitals. I can add the Harvard study. So this book will never die. This is on the flight. And we all land at different places in life: happiness, sorrow, grief, sickness. We got to keep flying. And that's what the flight is all about. So I hope you enjoy it. And thank you again so much for your time. I know it's been a very, very long day, but I really appreciate the hard work that you all do. Thank you so much.
Thank you for your inspiration.
Any more questions?
Any more? Any more?
Nope.
Okay.
Okay, thank you.
Thank you so much. Thanks to everyone who has hung in here with us. We will convene again tomorrow morning at 10, I believe, right here for some talking. And then we're going to try to see what we can do to wrap this powerful report up that has gotten more and more meaningful, I think, even today as we worked through so much work today. This was a heavy listen, y'all, and I do appreciate everyone, particularly Legislative Counsel Morgan. Thank you so much. This has been a great day. Great day. Wasn't it good?
It's good.
So y'all sleep fast. We got work to do tomorrow. We are adjourned. Thank you.